Good evening, everybody in India. I welcome all the delegates, chairperson, moderators, and speakers of the meet to this 20th edition of our, this time, virtual clinics in hepatobiliary diseases. Greeting from Sir Gangaram Hospital, our Institute of Liver, Pancreatic, and Biliary Sciences Diseases. This is the last but not the least day of the conference, in which today we are going to discuss threadbare the advances of all the knowledge which we have acquired over the last 3 days. Endoscopy is the mainstay of diagnosis of various types of gastroenterology and hepatobiliary disorders, and we have learned only yesterday the nuances in its diverse manifestation in terms of our approach to different hepatobiliary disorders. Today, we are going to put the use of these advances in knowledge of diagnostic endoscopy to a therapeutic use, the ramification and implication of which are going to be made available to us as we are going to take these advances from bench to bedside. We have excellent galaxy of this speakers who are going to take us through this journey, coupled with very senior and mature moderators and chairpersons in presence of the lively audience. With that, may I request Dr. Ashish to carry forward the proceedings. Ashish, please.
Yeah. Thank you, Dr. Arora. So, good evening, ladies and gentlemen. So, without wasting much time, I would start the first session. The first session is on advances in diagnostic and therapeutic cholangioscopy. And for that, I would like to invite our moderators, Dr. Sandeep Nijhawan and Dr. Shaukat Zargar. Dr. Sandeep Nijhawan is a senior professor of gastroenterology at SMS Medical College, Jaipur. Dr. Shaukat Zargar is from Srinagar, Kashmir. I think Dr. Shaukat Zargar is held up somewhere due to internet connectivity probably, so he might join later. So I would request Dr. Nijhawan to start the session, introduce the speaker and the panelist.
Good evening, everyone. Thanks, Anil and Ashish, for the opportunity. It's my proud privilege to actually introduce Dr. D.N. Reddy. We call him by love Dr. Nagi. He's the chairman of AIG Institute. He is my mentor and teacher, and of course, he is the mentor and teacher of innumerable gastroenterologists, not only in India but abroad. He has more than 700 publications, 23 chapters. He is an editorial board of various international journals, peer reviewer of more than 6 journals. He received B.C. Roy Award in 1995, Padma Shri in 2002. He is fellow of innumerable societies around the globe. He'll be speaking on advances in diagnostic and therapeutic cholangioscopy. And at the outset, I will actually introduce my panelist also, Dr. Ashish Jha. He is my student, now associate professor at IGI MS Patna. He is also one of the editors of World Journal of Endoscopy. Dr. Sanjay Gupta is professor and head SGRR Institute of Medical Sciences, Dehradun. And PK Agrawal, we by love call him PK. He's a consultant gastroenterologist at Asta Hospital for the last 26 years practicing in Dehradun. Followed by Dr. Sharat Chandra. He is a PGI alumni. He is practicing at Meghraj Memorial Hospital, Jhansi. So we'll have initially a recorded lecture by Dr. Nagi, but he is available for the panel discussion. So over to for the recorded session.
Good evening. I'd like to thank for giving me this opportunity to be a part of their annual course in September, which has become so popular now. I've been asked to talk on advances in diagnostic and therapeutic cholangioscopy, particularly to review the recent papers that have come in last 2 or 3 years. Of course, the basic concept of cholangioscopy came up because of limitations of ERCP. For example, the low yield for discriminating strictures and filling defects, complex and time-consuming of difficult stones, and of course, challenges in cannulation of certain strictures, and radiation exposure to the patients and staff. If you look historically, parallel cholangioscopy actually was introduced in 1975. These were prototype machines which came from Olympus, where 2 scopes were used, a mother and baby. And then came direct parallel cholangioscopy in 2007. Of course, it is not come into regular practice, but is used occasionally in certain units. In 2007, spyglass was introduced. This was a legacy spyglass. The view wasn't very good. And then came, of course, in 2015, the spyglass, the digital spyglass. And now we have the second version of the digital spyglass, which has extremely good views. The main indication for cholangioscopy is in diagnose indeterminate biliary strictures, in therapeutic ability to deal with difficult CBD stones, and several others, including, for example, removing migrated stents. So let's come first to the diagnostic indication, and as I said, especially it's for indeterminate biliary strictures, and also to take tissue under direct control, biopsies can be obtained. We can also delineate the intraductal tumor margins, and I shall show you examples of this at later date. But the most important indication is to differentiate between various types of strictures. For example, here, unless you are told what the stricture is, it's very difficult to differentiate malignant postoperative from inflammatory. What are the limitations now? If you actually look at the limitations of ERCP, the sensitivity in terms of both brushings and biopsy is only 45 to 48%, and even if you combine both, you have a total sensitivity of less than 60%. Let me show you a few examples here. These are 2 patients with mid CBD CHD obstruction, where the diagnosis is not clear. When we did a cholangioscopy, you can see obviously on the left side there is a mass there. Biopsies from which showed a lymphomatous lesion. It was a B cell lymphoma. On the right side, you see caseous material coming out from this. This was a tuberculous lesion. So obviously, the whole therapy changed in these patients. And similarly, in patients, for example, like this with IgG4 cholangiopathy, you can see very clearly that very clear pictures are obtained on cholangioscopy, and biopsies confirm the diagnosis. This is a recent paper from Almeida in 2012. You can see that the sensitivity of cholangioscopy in terms of visual impression is very high, 87%, with a specificity of 71%. Biopsies, of course, increase the specificity, and this was again a recent paper in surgical endoscopy, where efficacy of digital single operator cholangioscopy in visual interpretation of indeterminate strictures was looked at, and you can see in this systematic review that pooled sensitivity and specificity is a very high degree in these patients, and therefore just visual impression is okay in majority of these patients. Recently we actually did a randomized control trial to look at the use of cholangioscopy guided biopsy versus ERCP guided brushings in an indeterminate biliary stricture setting. For example, if you get a patient with indeterminate biliary stricture, our tendency to first take ERCP brushings, and this is negative, go for a cholangioscopy and biopsy. What we wanted to look at to see if instead of doing this, whether we can go directly to a cholangioscopy guided biopsy, and whether our results would be better. We randomized 29 patients to ERCP guided brushing versus 31 to cholangioscopy guided biopsy, and of course majority of these patients completed the study, and you can see the final results here that cholangioscopy biopsy or cholangioscopy guided biopsy had a much higher sensitivity and overall accuracy compared to ERCP and brushing. So you can see obviously even in terms of cost economy analysis, we find that cholangioscopic biopsies may be sometimes cheaper instead of repeatedly doing ERCPs in these patients. The other indication for cholangioscopy is in actually evaluating these patients in terms of looking at the extent of the disease. For example, this patient has a hilar tumor, has to go for surgery. We want to tell our surgeons where exactly to operate on this, and if they have a preoperative picture which is not very good sometimes with MRCPs, then we can do a cholangioscopy, and you can see here a guide wire is being put into the left hepatic duct, and once we selectively get into the left hepatic duct, we follow up with a cholangioscopy so that we get an accurate idea of where the malignancy is ending, so that the surgeon has an exact idea of how much to resect. And you can see here we are starting to get some abnormal tumor vessels here, and then this is where the tumor is starting from. So we can actually map out exactly where the tumor site is, so the surgeon, the hepatobiliary surgeon is more comfortable with where he is actually resecting these tumors from. In fact, again, a study which came recently in Journal of Clinical Gastroenterology, which looked at mapping of biliopancreatic neoplasm for determining the resection margins, and you can see here that the change in the surgical plan occurred in 34% of the patients, significantly high number of the patients. In 25% surgery could be avoided, in 65% less extensive was planned. So obviously an MRCP actually when you're looking at these tumors with an MRCP, you are under mapping, and therefore it becomes very important to look at it by cholangioscopy. Now coming to the therapeutic indications, of course this is another area where it's becoming importantly indicated. The recent cholangioscopy, especially the second generation cholangioscopies, are extremely useful. Intraductal lithotripsy of difficult stones and related stents and so on. Normally, if we have a difficult CBD stones, especially like these which are stuck at the CHD, or those multiple stones, it sometimes becomes very difficult to remove the stones, or time consuming with conventional ERCP. So what we do in these patients is now resort to cholangioscopy. Similarly, intrahepatic stones are not very easy to remove by traditional ERCP, so we resort to doing a cholangioscopy. Of course, it's a cholangioscopy guided laser lithotripsy which is extremely useful in these cases, and this was a meta-analysis of intraductal lithotripsy for difficult CBD stones, and you can see that an overall fragmentation success of 91%, and a single session fragmentation with ductal clearance was obtained in almost 80% of the patients. So very high success rates with a low adverse events. How does this compare with the standard of treatment? Standard of treatment in many of these patients for large CBD stones is to do balloon dilatation followed by mechanical extraction with a balloon, with a basket, crush the stones and take them out. And you can see in this study which came from Los Angeles that mechanical extraction occurred in 67% compared to 93% with cholangioscopy. So very high success rate with cholangioscopy compared with just mechanical lithotripsy. So I think this is a strong indication in our patients. Now this is another very interesting study from Orlando which looked at single operator cholangioscopy guided lithotripsy versus large balloon sphincteroplasty, and you can see in this single center RCT 66 patients were randomized to one of these procedures, and these are all large stones in excess of the diameter of extrahepatic bile duct. With cholangioscopy, the success rates was 94% compared with 73% with the standard methods which included balloon dilatation and mechanical lithotripsy and so on. And of course, the treatment costs and overall adverse events are not more, and therefore they concluded that a single operated cholangioscopy with laser lithotripsy is superior to conventional methods when you're dealing with large CBD stones which are more than the extrahepatic bile duct diameter. Another study which came from Thailand also very clearly looked at mechanical lithotripsy versus laser lithotripsy using cholangioscopy, and you can see very clearly the stone clearance is much higher with cholangioscopy compared with standard mechanical lithotripsy. So all these three studies published recently have demonstrated clearly that in difficult CBD stones or large CBD stones, it is better to use a cholangioscope with laser lithotripsy to clear the CBD rather than conventional methods that we have been using for so long. Now, intrahepatic stones can also be dealt with by this, and you can see a video here where we are entering into the intrahepatic ducts, and you can see the stones there. You can actually enter even into the secondary intrahepatic ducts now with the present cholangioscope, and using laser lithotripsy or EHL we can break these stones or fragment these stones into very tiny bits, and these stones can then be extracted, flushing it out with saline. This is again a procedure which may sometimes take some time, but is worthwhile because the other alternative in these patients is to go for a surgical resection which can have significant morbidity and sometimes mortality also. There are of course other indications for cholangioscopy. For example, We can now use the cholangioscope in a percutaneous technique, which I'll show you later. We can use it in a radiation-free removal of bile duct stones and of course migrated stents and so on. Radiation is becoming an important problem in ERCP, and radiation injury to the staff is well documented. So we are now trying to use cholangioscope typically with the baby scope without radiation. So the whole procedure is done under cholangioscopic guidance without the need for radiation. And you can see an example here. This was actually a pregnant woman in whom a cholangioscopy is being done. A sphincterotomy is done after putting in a guide wire into the bile duct, and stone is identified. We now have baskets which can be passed through the cholangioscope, mini baskets, and these can hold the stone, and you can remove the stone from this without the need for any fluoroscopy at all. These stones are less than 1 centimeter in size and therefore can be removed very easily. Now, in addition to this, if the stones are larger than 1 centimeter, sometimes you'll have to crush these stones or use laser. And in a recent report that's published in surgical endoscopy this year, a group from China reported the use of laser lithotripsy with radiation-free digital cholangioscopy to remove the stones. And this is an example of a very large stone which is stuck in the lower end of the bile duct. A guide wire is put in so that we have a guide to go into the bile duct. No radiation has been used up to now, and when we go into the bile duct, you can see this very large stone, and using laser this stone can be completely fragmented, and after fragmentation clearance you can see the bile duct which is cleared, and this is a post procedure MRCP showing complete clearance of the stone. So it's now possible for both simple and complex stones to use this radiation free technique using a current cholangioscopies to free the bile duct completely from these stones. The other indication is cholangioscopy guided for difficult strictures, and this is an example of a difficult stricture where using the standard ERCP we couldn't go in, and then using a cholangioscope we can actually visualize the opening and then get a guide wire inside. So precise steering and additional support for flexible wires is provided by these cholangioscopes, and this is increasingly becoming an important indication. A new cholangioscope which it can be used percutaneously called the Spyglass Discover has just been introduced this year by Boston Scientific, and you can see the example of this being used. This is the first report actually in 2020. This has been reported in a patient who had very difficult intrahepatic stones, and we couldn't access endoscopically. You can see percutaneous access after PTBD has been done. This is a very small diameter scope, can enter very easily, and you can see this can target these stones in different parts of the bile duct, in the intrahepatic ducts, in the extrahepatic ducts and so on. You can see the large stones here in the common hepatic duct and the common bile duct that can be targeted using extra EHL probe. You can actually fragment these stones into tiny bits, and these stones can then be pushed through the bile duct itself in an antegrade fashion into the duodenum, and you can see this here, complete fragmentation and complete clearance of the duct can be done, and this is the first clinical case report by Horst Neuhaus and his group last year in Video GIE. There is another scope that's also being introduced, and this is actually again in GI endoscopy 2020 that Lee and his group have published this. You can see that this is a new scope which is a multi-bending scope, and you can see the scope which is now can be used directly without the need for ERCP scope. That is, this scope can then be passed on a guide wire to enter directly into the bile duct. Again you can see this is a 2020 publication in GI endoscopy of this use of this scope, where they have compared this multi-bending scope versus the standard ultrafilm endoscope in a parallel cholangioscopy, and you can see that success rates with this multi-blending scope is much higher than with the conventional ultrasim scope. Right? So I think this multi-bending scope, once it becomes commercially available, may become an important aspect of doing cholangioscopy, and you can see examples here again in this recent publication of this multi-bending cholangioscope. You can see very nice pictures. You can do a narrowband imaging, you can take biopsies, and ultimately you will get use very nice large biopsy bits for analysis by the pathologist. Similarly, this scope can also be used for difficult CBD stones. And this is an example of the scope which has been used in a large stone like this, which can now be fragmented using EHL. After complete fragmentation, the stones can be cleared. So clearly, there is now a role for a direct cholangioscopy without the use of an ERCP scope, and increasingly this is being used in certain patients. Of course, these scopes are still not commercially available; they are prototypes, but hopefully they will be available now for clinical practice. Of course, peroral cholangioscopy has got some complications. Cholangitis is the commonest. It can be seen up to 20% of the patients. Pancreatitis can occur as a part of the ERCP itself, or because of repeated manipulations you can get pancreatitis. Air embolism is the most important complication that one should look at. In fact, carbon dioxide embolism has also been reported. We now stopped using air, we use only carbon dioxide, but still even this can have embolization problem, and therefore one should be careful. Perforation, especially when you are using the direct cholangioscope, can occur of the bile duct, and of course hemophilia. All of these complications can be, if they are recognized early, can be treated very effectively. So in conclusion, single operator cholangioscopy has become an important component of our bile duct examination and therapies. It's a technology of choice because of its easy application for a variety of indications. For well-studied efficacy and safety, it is superior to ERCP alone for evaluation of indeterminate ductal lesions, and this we have clearly shown in our randomized control trial done with Horst Neuhaus, where we have shown that its efficacy rates, accuracy rates are much higher compared to ERCP brushing. In selected patients in whom ERCP fails for difficult bile duct stones, cholangioscopy with laser lithotripsy is superior to conventional methods to clear the CBD stones. Again, 3 randomized studies last year and this year have clearly shown that cholangioscopy guided clearance of the bile duct stones is superior to conventional techniques, and maybe this should become the first choice in these patients. Also, as we have shown, complex radiation free interventions can be done. Initially it was done for small CBD stones less than 1 centimeter, but again this year we have a large publication in surgical endoscopy showing that in even large stones which are more than 1 centimeter in size, using these cholangioscopes, radiation free laser lithotripsy and clearance of the bile ducts can be done. So I think in the end we can conclude that cholangioscopy has become a very important component, armamentarium in our patients dealing with complex pancreaticobiliary diseases, and hopefully in future this is going to be used much more frequently. We should be aware of the complications of this procedure, and these can be dealt with quite easily once they are recognized very early. Once again, I would like to thank Dr. Anil Arora and his group for giving me this opportunity to talk in this very important forum. Thank you very much.
Yeah, thanks, Dr. Nagi. As usual, a very excellent talk, very concise and with very good carry-home messages. Initially, I'd like to have comments from my panelists, one after the other, then followed by a few questions, which I have already in my chat box. So, Dr. Sharat Chandra, please.
So excellent talk, sir. So I had one question. So would you recommend cholangioscopy and its assessment and biopsy in the very first round of ERCP in a patient with high suspicion of malignancy, or you would first do a brushing and take a fluoroscopy guided biopsy and place a stent? And if the results are negative, then you would go ahead and do a assessment.
So, Sharad, that's a very good question, because if you have a patient who has an indeterminate biliary stricture or an indeterminate filling defect, you now have a choice between doing a standard ERCP, standard brushings and biopsy, versus a cholangioscopy guided biopsy, which we know has a higher pickup rate. The question is, of course, the economics involved in this. If the economics are better, especially when you use this in Western countries where cholangioscopy is actually cheaper than doing repeated ERCP, then we would suggest, based upon a study published in GIE, that in patients who have indeterminate biliary lesion as determined by radiology. So the concept or the definition of indeterminate biliary stricture has changed now. It used to be earlier, you do ERCP, biopsies are negative, you call it indeterminate biliary stricture. Now, based upon radiology, that is MRCP or CT scan. If you can't say whether this is malignant or not, then you call it indeterminate. So for this so-called radiological indeterminate biliary lesions, we believe that if economy favors, it's better to do cholangioscopy and biopsies. But unfortunately, in our country still, we worked out the cost. It is still cheaper to do, say, 3 ERCPs before you do a cholangioscopy. So therefore, for us, it's an exception. We would still do a routine ERCP, brushings and biopsies. And if it's negative, go for cholangioscopy. Earlier on, we used to do several ERCPs before we go for a cholangioscopy. And now, with the cost coming down little of cholangioscopes, if I get a negative brushing in the first or second instance, I'd quickly go to a cholangioscopy, as we have found that this gives a positive diagnosis in over 90% of the cases.
Yeah, Dr. PK, your comments, please. You have to unmute yourself.
You are muted, PK. Yeah.
Sorry, sir. Excellent talk, sir. As usual, we are always mesmerized by your talk, sir.
Right.
How good is cholangioscopy for diagnosing PSC, sir?
Yeah, because that's another very good question. Unfortunately, diagnosis of PSC is always challenging. And especially even with a cholangioscope, the visual appearance can be quite confusing between an extensive cholangiocarcinoma and PSC. Also, biopsies, in spite of extensive biopsies, they can still be negative in a case with PSC because of the nature of the disease. So I think one of the limitations of cholangioscopy, as you're rightly trying to point out, is a PSC. The only way, of course, is FISH. If FISH can be done, which is done in very limited place in our country, then you can come to diagnose. Otherwise, cholangioscopy doesn't add too much for routine diagnostic impression in these cases.
Thank you, sir.
Ashish Jha, are you there?
Okay, sir. Thanks, sir, for very nice presentation as always. I have a technical question. Actually, for distal CVD or lower end CVD, we feel sometimes passing a biopsy forceps through the scope is a little tricky. Any trick for that to minimize?
Yeah. So, Ashish, distal lesions in the bile duct are always difficult for a cholangioscope to enter and visualize because you don't have much space. In these lesions, I always use a guide wire, a stiff guide wire, and push the cholangioscope on the guide wire rather than freehand cannulation, because freehand cannulation is very difficult. But in general, in these patients, I would do an endoscopic ultrasound evaluation first, as the yield is much higher than with the cholangioscope. So any lesion in the distal 1/3 of the CBD or involving the pancreas, I would always first do an EUS and US guided biopsy. And if these are negative, and there's a chance that this patient has a rare bile duct lesion, then I would then switch to cholangioscope. And cholangioscopy invariably has a lower yield than proximal lesion in this case. And this cholangioscopy is always done on a guide wire.
Thank you.
There are a few questions, Dr. Nagi, in the chat box.
Yeah.
One is how you compare the results of EHL versus laser lithotripsy for these difficult stones.
Yeah. So this is a good and important question, because very commonly people say laser is expensive, so why not do EHL? So the efficacy rates of both laser and EHL are similar, used through the cholangioscopy channel. There's a difference. Difference is the first, the cost. The capital cost of laser is very high, minimum 30 lakhs, whereas the capital cost of EHL is about 7 to 8 lakhs. So it's cheaper. But the catch here is that running cost of EHL is much higher, because these EHL probes are very fragile. They break very easily, whereas laser probes are much more sturdy. So the running cost of EHL is much, much higher than laser. And over a period of time, the capital cost gets covered. So my recommendation now is to go for laser better than EHL. The second difference is adverse effects. With laser, even if you misfire and hit the wall of the bile duct, nothing happens. With EHL, you can actually perforate the bile duct. So this is another problem. The way the stone is fragmented is different with EHL and laser. With EHL, you get a cavitation, and then you get larger fragments. With laser, you get a fine powdery appearance that comes. So there's a little difference in method, but the success rate eventually is similar. Although the initial cost of laser is high, I would recommend this over EHL, because the running cost of EHL we have found is extremely high.
Yeah, there was a second question we already answered, that the the fibrosis following CBD fibrosis, wall fibrosis following laser for diffuse stone.
Yeah. So generally laser doesn't cause much injury or fibrosis to CBD, so it's very safe, and that is one of the advantages of the laser in these cases.
And there was another question like confirmation of the wire cannulation using our cholangioscopes. You still require fluoro.
Yeah. No. So what we would do is that we would first put in the wire and put in a spindletome or a catheter passing the wire, and then aspirate bile. Once bile comes in, we know that you are in the bile duct, and then take out the spindletome and pass the cholangioscope over this guide wire into the bile duct. So this is a technique. The flaw here is that wire-guided cannulation may not be always successful, because very often, in difficult cases, we require to use a fluoroscopy to guide the wire. But in cases where there are actually CBD stones, indication is there for CBD stones, we find that the wire goes in very easily into the CBD. So the steps are: first, side wing scope, pass a cannula with a guide wire, and the guide wire is first pushed without fluoroscopy as deep as possible into the suspected bile duct. The cannula or the spindletome follows. We remove the guide wire, aspirate bile, and once we are sure bile is coming out, we would then on this guide wire put a cholangioscope. The small occasional problem that occurs is sometimes we find that if you're deep in the cystic duct or gallbladder, still bile would come and we'd mistake this, and the cholangioscope goes into the cystic duct. What we would do in this case is just to pull back the cholangioscope a little and wire back, and then re-put the wire back into the regular CBD. So that's not a problem. Now the cholangioscope, the latest one, has got an angled tip and is little tapered. So cannulating the bile duct primarily not so difficult as the original one was. But if you want to totally avoid radiation, this is the technique. Some people do what is called a partial radiation technique, where in the initial part of the guide wire, they use a small amount of radiation. But ultimately, I think the aim is to get a total radiation-free technique, especially in pregnancy and so on. And that's where we use this more often.
Sandeep, can I ask you a question?
Yeah.
Dr. Reddy, thank you so much for excellent task and brilliant as usual. My question is the pathogenesis of so-called indeterminate stricture. What makes it indeterminate? In case you do not have a lesion in the paraductal region, there is no history of chronic pancreatitis, IgG level is normal, there is no history of diseases, IgG4 disease. What makes it indeterminate? And if you look at 100 cases of indeterminate biliary duct stricture, what is the etiology? That is number one. And secondly, we are always worried about the risk of infection in the proximal obstructed CBD. It invariably happens, especially in a patient who is operable. So what is the way out?
Yeah, so those are two very good questions, Anil. First, coming to the infection, which is easy to tackle. Actually, with cholangioscopy, the infection or cholangitis incidence can go up to 20%. The important thing, of course, is not to irrigate too much. In our enthusiasm, sometimes we're putting in too much of saline. And how much saline we put in, it's important to try and aspirate that. So I sometimes even selectively cannulate the site where we suspect there's too much of saline going in and try and aspirate as much as possible. Of course, you can't 100% avoid infections, but infections are a problem. We have tried several things like putting antibiotics into the saline and so on, but none of these things work. So the infection rates, especially when these patients are going for surgery, is a problem, and sometimes the surgeons are quite upset because we send them an infected case for Whipple's and they find it so difficult to do one of these radical cases. The second question is regarding indeterminate stricture. I think this is again a very important point to discuss, because the definition of indeterminate stricture has changed a little. About a year back, indeterminate strictures used to be those strictures which on ERCP brushings were found to be negative. So if these strictures are found to be negative, we say indeterminate strictures. And when you work up these patients, that is, do repeated biopsies, go for surgery and so on, 30% of them still were indeterminate. They could be either autoimmune cholangiopathy that's unrecognized or PSC unrecognized and so on. Now the diagnosis has been based on radiological findings. On MRCP CT scan, very often we can make a definitive diagnosis or a near certain diagnosis of malignancy. For example, nodes are there and so on. So these are excluded. If you take out those cases and actually have cases where on a imaging technique, either MRCP, CT or whatever imaging technique, we're not able to get to an obvious diagnosis. We call this indeterminate. Now, these indeterminate strictures, now we find that when we follow up and work up these patients, only 10% will ultimately remain indeterminate. 90% will belong either to the category of malignancy, or there would be autoimmune cholangiopathy, which are increasingly seeing other infections and so on. So 90%. The 10% so-called idiopathic, we don't know the cause. They have fibrosis. They go for surgery sometimes, and we still don't get a cause.
Thank you.
Thank you, Dr. Nagi. I think it was an excellent session, and everybody got the carry-home messages regarding cholangioscopy. So I'd like to thank, big thank to you, and thanks to Sharad, PK, and Ashish for an active participation.
Thank you.
Thanks, Anil. Thanks, Anil and Ashish, for the opportunity. Over to you, Anil.
Thank you. Thank you. Ashish will carry on. Ashish.
Thank you, Dr. Nijavan, for that excellent moderation, and thank you, speakers and panelists. We move on to the next session, that is on therapeutic US for beginners. And for this, I would like to invite our moderators, Dr. Vipul Roy Rathore and Dr. Jayanta Samanta. Dr. Vipul Roy Rathore is a past secretary and president of SGEI, director, the World Gastroenterology Institute, and consultant gastroenterologist and endoscopist at Bhatia Hospital and Breach Candy Hospital, Mumbai. Dr. Jayant Samanta is the assistant professor in the Department of Gastroenterology, PGIMIR, Chandigarh. So over to you, moderators, and we would like you to introduce the speaker as well as the panelists and start the session.
Thank you very much for this kind introduction. Dr. Arora and his team, congratulations for a brilliant program. First of all, I would like to invite my co-moderator, Dr. Jayanta Samanta, as he already been introduced. He is assistant professor at the PGI Chandigarh Institute, Gastroenterology Department. So without further ado, I would like to call upon our speaker of the day, Dr. Vinay Dhir. Actually, he needs no introduction, but for the formality's sake, I would say he is the chairman of the Digestive and Liver Disease Institute at SL Raheja Hospital in Mumbai. And currently, Dr. Dhir is the president of SGEI. He has many publications to his credit, both national, international, and many international students for training. His unit has been awarded as a Center of Excellence by the Asian US Group for US Fellowship and Training. And also a very prestigious Crystal Award from ASG has been conferred on him. So I would like Dr. Samanta to introduce our panelists, and then of course we'll go ahead with Dr. Dhir to start the proceedings.
Good evening, and thank you, Dr. Vipul sir. And at the outset, I'd like to thank Dr. Anil Arora sir and his team for organizing this excellent group of sessions for this excellent program. I'd like to introduce the panelists today. We have our esteemed panelist with Dr. Ajay Kumar Chaudhary, who is a consultant and a faculty at the GB Pant Hospital, New Delhi. We have Dr. Satyarth Chaudhary, who is a consultant gastroenterologist at the Jaswant Rai Super Specialty Hospital at Meerut. Dr. Yogesh Batra, who is a senior consultant of gastroenterology hepatology department at the Indraprastha Apollo Hospital, Sarita Vihar, New Delhi. We have Dr. Mandhir Kumar, who is the co-chairperson at the Sir Gangaram Hospital Gastro Department. And finally, we have Dr. Kunal Das, who is the head of gastroenterology department at Manipal Hospital, Dwarka. Welcome all the panelists, please.
So Vinay, you can start the proceedings.
Thanks, Vipul. Thanks a lot for that kind introduction. I would also like to thank my friend, Dr. Anil Arora, for giving me this opportunity to be with you. This meeting has become a very important meeting over the past few years, and I think it is one of the best synopsis of all the relevant issues which concern a gastroenterologist and a hepatologist. So my topic is therapeutic EUS for beginners. So this talk is directed not towards experts like Vipul or Jayanta. This is for beginners, those who are either trying to start venturing into therapeutic EUS, or who have just started and are looking for some tips and tricks. So as you are aware, interventional EUS has evolved tremendously over the last 2 decades, and we find this as a wonderful mix of therapeutic endoscopy, which we all love, ultrasound, and interventional radiology. So all three procedures mix to create an interventional EUS procedure. After initial decade or so where it was, a lot of small studies came. Now in the past decade, we have had very good studies with decent numbers, and we have level 1 evidence for several interventional EUS procedures. And this is causing a paradigm shift in management of many disorders. So interventional EUS is here to stay. It has very exciting prospects, and we endoscopists, wherever there is a big endoscopy practice, it is important that we learn the basics of interventional EUS because it helps our patients. So if you want to succeed in interventional EUS, there is no shortcut. There are multiple things involved. The first and the foremost is to have a right indication. Then you should get the right procedure, which procedure applies to which indication. Your department or your unit should have all the right accessories required for the procedure, the right stents required, and last but not the least, it is very, very important, the right kind of training for interventional EUS. So these things are required. The number of interventional EUS procedures have expanded over the years. So you have biliary ductal drainage, pancreatic ductal drainage, drainage of fluid collections like pancreatic fluid collections, perirectal collections. You have cancer-directed therapy like alcohol ablation and other things. And then you have, of course, coil injection for gastric varices, celiac plexus neurolysis, and other things. So a lot of therapeutic EUS procedures are there currently. Who should do the interventional EUS procedures is a very, very important question, I think, because these procedures are really advanced endoscopic procedures. So we met about 3 years back at the Asian EUS group, and these guidelines were published in GUT 3 years back. And if you look at these guidelines, we also discussed who should do this. So these are the guidelines for EUS guided pseudocyst drainage. These are the guidelines for biliary drainage, and these are the guidelines for pancreatic duct drainage. So if you look at these, they are more or less similar. Most important thing is multidisciplinary support. You need an intervention radiologist support, surgeon support, anesthetist support, and also critical care support in your department if you venture to do these procedures. You should acquire the skills of these procedures through observation. So go to a senior who is doing this procedure, observe these procedures, take some hands-on training on models. There are a variety of models available. And then finally perform the procedure, preferably under supervision. If not, then alone. So this is how you have to get into it slowly. ERCP skills are very important, whichever part, if you are doing a pseudocyst or a biliary or a pancreatic duct drainage, it is better that you have good ERCP skills because it helps you not only in the scope maneuvering, but it also helps you in wire manipulation and other techniques. You should do a few supervised procedures, if possible, a few supervised procedures. You are in an academic institution before you start independently. So these are the requirements who should do interventional EUS procedures. So teamwork is essential. You need, of course, the endoscopist, but your GI assistant is crucial. Your GI assistant should know how to help you in various situations. Then, of course, you need a good anesthetist, and in case you land in problems, interventional radiology, surgery, and good ICU is required. Coming to the technique of the procedure, actually the technique is very old. In 1953, Seldinger, he is a radiologist, he published a method for percutaneous arterial catheterization. And this is the procedure which we follow in almost all interventional cardiology and interventional gastroenterology procedures. It's a very simple method if you look at it now, but it was revolutionary. Basically, he created a hollow needle through which a wire can be passed. So you put the needle in, put the wire through this hollow, and then remove the needle, and over the wire you can do various procedures. So it became very popular in cardiology, in gastroenterology, ERCP, stent placement, and now in interventional EUS also. So the basic technique is simple. If you look at it, needle puncture, which is enough for certain indications like injection. For example, if you want to inject around the celiac plexus, so needle puncture is enough. If you want to inject glue into varices, then needle puncture is enough. But for other things like stenting, you need a wire passage, tract dilation, and stent placement. So multiple things. Equipments, you need to have very good equipment at your unit, and you should have everything. You should not miss out on important technology which is coming and which is increasingly coming now. So of course you need a EUS therapeutic EUS scope. 19 gauge needle is most important for interventions. Then an assortment of guide wires, dilators, and stents you should have. A variety of different kinds of guide wires, dilators, and stents will be needed. And these are the two scopes. This is the linear echoendoscope, our bulwark, the main scope that we use. Of course, you have a forward viewing therapeutic scope also available from Olympus, which works in certain situations like pseudocyst drainage and certain varieties of biliary drainage. It's a good scope. You need a 19 gauge needle for vast majority of cases. Sometimes you also need 22 gauge if the ducts are not dilated. Wires and dilators, you need a variety of 032, 025, and 035 wires. You need dilators. The most preferred one is cystotome, 6 French cystotome, and balloon. These are the two commonly used now. Pre-cut papillotome, I advise don't use it because it is not a coaxial dilator. So use a cystotome or a balloon. Variety of stents, some of them are borrowed from ERCP, the plastic stents and the fully covered and partially covered stents. Then some EUS specific stents are also now available. Axios, Pexus, and Nagi are some of them. These are specific to EUS, are large diameter stents with a small length. And so they help in anastomosing the two layers together. You see, these are 1, 2, or 3 centimeter stents. Now we have hot stents which bypass the Seldinger technique. You don't need the Seldinger technique with these. It has a cautery at the top, so you can puncture directly your way through into the bile duct or gallbladder or the jejunum as the need may be. So when you're starting, which procedures to start first? My suggestion, and there is no evidence for this, is go for retroperitoneal regions. So celiac plexus is one area which appears to be relatively okay. Posteriorly located pseudocysts or wands are good to start initially. And if you are venturing into bile duct pathologies, rendezvous, because you only need a needle and wire and complications are less. So try EUS guided rendezvous. So these are the procedures you begin with. Once you are comfortable with these procedures, you go into transperitoneal regions, because here you are going through the peritoneum and leakage may be higher. So EUS guided biliary drainage, gallbladder drainage, GJ. And then I have kept vascular therapy lower down because the complications can be really severe. But if you have the confidence and if you have been doing lot of gastric variceal glue injection, then probably you can start vascular therapy earlier. So this is the advantage of starting early with pseudocysts, is that as I told you, it is posterior, it is in the retroperitoneum, so you are not going through the peritoneum. And B, most of us are used to doing pseudocyst drainage, at least people of my age, we have been doing through the ERCP scope also. So the steps, as you know, needle puncture, guide wire passage, cystotome, I'll go fast forward all these things and then place a stent. So stent placement is crucial. You have to learn how to deploy the stent within the scope always, and you will have a good drainage. So this is a procedure where I would say you would, if you are doing a lot of ERCPs and other interventional procedures, you can easily transition to EUS in pseudocyst drainage. Rendezvous procedure is another such procedure where you will need little bit of training, but once you are a little proficient, it is straightforward. You use a 19 gauge needle and put it into the bile duct. Your scope position has to be good so that the wire passes into the, you see the scope position here, wire passes across easily. So these are some of the procedures which I consider can be started initially when you are venturing into the interventional EUS procedures. One thing is, just like ERCP, we were taught ERCP and we were told that scope position, scope position, scope position. Scope position is the most important, and when you are learning, you have to learn what are the various scope positions associated with various procedures. And this applies not only to biliary drainage, it also applies to all others. Gallbladder drainage, GJ. A stable and good scope position is essential. And how you learn to keep your scope in a good position, do a lot of EUS guided biopsies with 19 gauge needle first. A 19 gauge needle is different from a 22 gauge needle. It works a little differently, it is stiff. So a few biopsies you do with 19 gauge needle so that you understand the mechanics. And then you see this is a segment 2, the position has to be different. Segment 3, the position has to be different. Choledochordioidnostomy, the position is very different. And rendezvous, as I told you, the position is different. So different positions for different procedures. So one is get a good position, 2, keep the position stable, because most of these procedures will be done under ultrasound. And you have to see the guide wire passing into the area of interest continuously. If you don't see it, there is a problem, your position has changed, and then your procedure is likely to fail. So number one thing is get a good scope position, and please keep that position throughout the procedure. So interventional EUS is a game of angles. You know, it's like football, it's like soccer. If you give me 1 second, I put some light in my room. I think I have become very dark. Just give me 1 second. I hope it helps. No,
You are always bright, sir. You are never dark. You are always bright.
Sorry. So I'm at my home, so it's pretty dark here. Anyway, so learn the game of angles. Spend some time thinking about angles. You know how the soccer players do. So you have to imagine the trajectory of the needle, the trajectory of the wire passage, create optimum angulation by manipulating your scope and needle. Then your procedure will become very, very straightforward. So as I said, scope stabilization is very essential. So you see here, if you're going for a B2, and you see how it changes. You're keeping a straight scope, your needle is going in this direction. You angle it a bit and you're getting a very straight view. So small things matter a great deal. So take interest, learn the angles. What angle are you going to create when you puncture? Very, very important. Same thing with wires, I will tell you. See here, B3, if your angle is like this, it is going, the wire is going towards the periphery of the liver. So you change your position in such a way that the wire is going toward the center of the liver. So these are small things which you will learn as you go along, but very, very important. Scope position and keeping proper angles. So I'll just show you a quick example. This is a Chbd. You have a segment 2 here, segment 3 here. Now here you turn your scope in such a way that you get a good segment 3. So I'm turning it clockwise. You see, you got a nice segment 3 here. This is from where the needle will come. So you have to assess the angle. What angle should you get to get a good puncture? So I always use fluoro first to see whether my scope is nicely positioned before I puncture. Once you puncture, you see I'm going nicely here. Aspirate that you have bile, and see here, this is the angle I have got. It's not a great angle, but it's decent. I will show you how to pass this with a guide wire. So this is an angle, this is an angle, this is an angle. So these are the angles we have to pass with the guide wire next. So now in the same patient, see this angle, you pass a GH-shaped terimo, and it may go here, it may go here. So use your thumb and the index finger, your assistant should use it to rotate the wire in such a way that it goes in the right direction. See, first it goes wrong. Gently withdraw it, don't be too fast, and then rotate the wire in such a way that it goes up. Now you see, we are rotating the wire and now it has gone up. You see this? Now it has to take another angle. So small increments in the wire length, and then you see rotate it. Luckily, Terimo and VisiGlide both have excellent maneuverability. See how far it moves in any direction. And then you can come here. Once you are at the stricture, you can pass a cystotome to stabilize this wire, and then things become very easy. See, this is a 6 French cystotome. We passed it down. Now we can pass it across the stricture pretty easily because the cystotome stabilizes the wire, and then we pass it down across into the duodenum. So wire manipulation skills are also very, very important. As placement of stents, I already told you, I'll be pretty fast here. See, there are already 2 metal stents placed. Patient is in cholangitis. Left side is not drained at all. So you put a wire here, dilate the track, and place a stent. When you are placing a stent, remember to leave about 3 to 4 centimeters of stent in the stomach. Otherwise, this stent can easily migrate inside. So, because there is no tumor here, so open the stent within your scope and leave about 3 to 4 centimeters of stent if you are doing a hepaticogastrostomy into the stomach. So, small things are important. Otherwise, you can have problems like this. See this? So the stent was placed too close inside. This is the stomach, and it has migrated inside. It has perforated, requiring an operation. So complications can be severe. So be careful with what you are doing. And you see, you can have here, it is the other way. The stent has completely migrated out. So the uncovered part of the stent, bile leaks, and you have a bile leak. So severe complications can happen. Remember that. That's why I said training is essential, and we have been working for last 8 years on creating models for interventional EUS. This is our first model, the 3D printed model. Our second model was a hybrid model for EUS BD and rendezvous. And now finally we have created this magic box. Today afternoon I showed it in a train the trainer session. This is a very good model which allows you to learn EUS biopsy. So you see biopsy pieces here, EUS guided biliary drainage, pancreatic duct drainage, pseudocyst drainage, and GJ. So one box gives you almost everything. Once you do this, you will be able to do advanced procedures, and I hope this is my last slide. So this is a GJ, gastric outlet obstruction, pass a wire across. This is not for the beginners. Please do it much later. Pass a NJ tube. This is a freehand technique. There are multiple techniques. Instill water mixed with methylene blue here. Use your EUS scope. See, nicely fill it with water and methylene blue, and then deploy an hot axios directly without any wire. So you have a nice gastroenterostomy. So sky is the limit. Once you are a little confident, once you know what is your technique, it will take a few years, but these are very, very exciting procedures which help our patient. I think I finished my time. Thank you very much for listening to me.
Thank you, Vinay, for an excellent exposition to EUS for beginners, therapeutic EUS. Now I'd like to open the floor for our panelists to come in and share their viewpoints and have some questions. Please go ahead. Dr. Jayant Samanta, if you have any question, please start.
Yeah, yes, sir.
Oh.
That was an excellent talk as always, sir. So my question would be regarding the dilatation techniques that you use. I mean, what is your take on a 6 French versus an 8.5 French cystotome? I mean, which one do you prefer? You have talked about 6 French, but purposefully I'm asking this question about 6 French versus 8.5, and where do you think maybe an 8.5 may help over a 6 French?
So that's a very good question. You know, when we started with a 10 French cystotome.
Yes,
and we realized that at times it caused some bleeding. It was too big, and then we shifted to 6 French, and after 6 French, we have not needed another cystotome. A 6 French cystotome works in all situations, except when you're doing a Vaughan drainage, where you will have to supplement with a CRE balloon. So 8.5 is not much bigger. So what we do is we do a 6 French, and then we do a 6 mm, not CRE, 6 mm hurricane balloon for Vaughan. And then you can pass the stent easily. So our personal preference has always been a 6 French cystotome. The reason being, it's thin enough, it never causes any bleeding. My Japanese friends tell me that, you know, there can be some bleeding, but we have not encountered any bleeding, and it works like magic in most of our cases. We love our 6 French cystotome.
Yes, sir. Okay, sir.
Our other panelists, Dr. Chaudhary, Ajay Chaudhary, Satyarth Chaudhary, Dr. Batra, Dr. Mandir Kumar, and Dr. Kunal Das. Any points?
Vinay, you made everything look very easy.
Thanks, Mandir. Thanks.
But actually, if you ask me, there are hardly any centers which would have good GI surgeons as well as interventional radiologists to fall back upon.
Absolutely.
No, you are
Don't you
right.
agree?
You are right, and that is why I think these advanced procedures should be limited to
Limited centers.
institutional kind of setups where you have all these facilities. You know, in 5 out of 100 cases, suppose you have complications, but these complications may be so severe that you may not be able to handle. And then sending the patient from your place to a big center with a complication is never a good idea. So always do these procedures where you have good services, and I'm sure people will support me on this, that if you have good support, and not only surgeons, you need sometimes after Vaughan, there is a torrential bleeding, and you need an interventional radiologist in the middle of the night. So he has to come. So support services are essential, and that is what I stressed in the beginning only.
To add to this point, sorry, Mandir. Go ahead, please, Mandir, please.
I just want to know what would be the expected complication rate which we should be explaining to the patients while doing these procedures.
So again, the talk is focused towards beginners. So I would say explain to them about 15% complication rate. As you progress, you learn more, it will come into single digits, and probably you'll be doing a complication rate of probably 6 to 7%. It is never nil. I also create complications even now, I can honestly tell you. But in the beginning, it is more than ERCP. There is no doubt about it. It's about 15% is what I would say.
A small comment, Vinay, if you agree with me. The problem with the conventional techniques of ERCP, what has happened is that the fresh lot of gastroenterologists with so much of enamored EUS interventions, they find it extremely attractive and very glamorous.
Yes.
And they feel that EUS is a replacement for ERCP skill. And I think this is what I want to convey to all the colleagues who are watching today. Yes. That the more proficient your ERCP skills will be, the better interventional EUS guy you will become. Because ultimately for pancreatic duct, you will need supreme ERCP skills. And therefore, I think EUS biliary drainage is not an entire replacement for ERCP for bile duct. This is something what I wanted to share on this platform. Do you agree with me, Vinay?
Excellent point, Vipul. I completely agree with you. EUS supplements ERCP. So what we are doing is, you do ERCP. If it fails, rather than sending it to a radiologist, you have another endoscopic technique by which you can just change the scope, and in the same session, do a drainage. So not to replace ERCP. In fact, what you said is very good. The better your ERCP skills are, the better your interventional EUS skill be. Very, very correct.
Any points on pancreatic ductal interventions in your experience?
So pancreatic ductal interventions, Vipul, are required rarely, very, very rarely. But they are important because there is no PTBD to salvage us there. So if you have a patient in whom you have tried ERCP once or twice and you're not either able to pass a stricture, that is the most common cause. Then you have another route to start from the stomach and go in the other direction. If the wire doesn't go across the stricture, at least you can pass a stent. But probably very few patients, and I'll ask you also to comment on that. Very few patients require a pancreatic.
Well, if you ask me, there are two indications where I would consider that. One would be a post-Whipple. If there is an anastomotic stricture at the pancreatic jejunostomy, and when a patient has a recurrent acute pancreatitis or chronic pancreatitis, that's a good indication. Second would be a disconnected duct syndrome. And a large segment of a pancreatic tail which keeps pouring in, sometimes you may have to supplement along with a plastic stent in the cavity. So these are few very rare clinical indications, as I would understand that you need it.
Absolutely.
But they are very technically demanding because stomach is floating, and it's a tough call.
Yes.
Any other question from our panelists today, Doctor?
I would just
Okay.
like to ask one question to Dr. Dheer sir. Is that I have always believed that mastering diagnostic EUS is much more difficult than mastering therapeutic EUS. That is my take. I do not know about you, sir. And so I would like like to ask you the question for the beginners is that when do the beginners start thinking that now, yes, they can step forward to the therapeutic EUS? And when is that time?
Jayanta, that's such an excellent question. Very, very, very important question. So diagnostic EOS is an entirely different field. I'm doing it for many, I think more than 2 decades, and I still consider myself learning. It challenges you. It is extremely important to be very, very good in diagnostic EOS because I emphasized on scope positions. Scope positions you will only understand if you are good in your diagnostic EOS. So if you are doing a decent diagnostic EUS, if you have done enough number, and I will not put an exact number of FNAs, and then if you have done enough number of FNAs with 19 gauge, then so what happens is, as Vipul very rightly said, it becomes glamorous to venture into this. Now we are here for patient care, and safety is very, very important. So while it is very exciting and I get very excited to do all these procedures, but for patient safety, your diagnostic EUS skills have to be very, very good. And your 19 gauge needle skills have to be very good. So probably I don't want to put a number to it. If you are doing EUS for probably 3 to 4 years is when I think you will get reasonably confident that, okay, I'm understanding what EUS is all about. And then I think you can slowly venture into pseudosis drainage and celiac blocks and then progress from there. Vipul, you want to add anything?
Just one point here I would like to make, Vinay, is that diagnostic EUS has actually taken a back seat because what happened is that we gastroenterologists started relying too much on MR, CT, PET and all those imaging that we have everybody wants to stick a needle. I said, you master the diagnostic is a huge role and that is still untapped as I understand in my practice.
Yes.
So we need to focus, as you rightly said. And yes, I fully agree with you.
Yeah.
People
I
like
have a question. Yeah.
that I have seen you working for so long and you always insert a radial scope so often before inserting a...
Vipul loves radial scope.
I still do that.
It is so true. It is so correct. It is so correct.
I have one question, sir, Dr. Bhej, please. Sir, people who are graduating from ERCP to interventional US, there is a distinct difference in the anatomy. So how do you think we should take care of this? Because the traditional ERCP, the CBD and the pancreatic duct, and when you do the CDS or the SGSS, so there's a lot of difference even in the fluoroscopy images. So what challenges do you think are there, and how should we overcome those?
So very, very good question, very good question. And I think the answer lies in the previous question of Jayanta. You have to be proficient in understanding the EUS anatomy first. The skills that are required from ERCP are, passage of wire, passage of stent, but EUS specific skills are getting a good location to puncture, passing a needle in the right direction. That you will only get after you do a lot of EUSs. So transitioning from ERCP to EUS is basically transitioning from endoscopy to ultrasonography. And that transition is best done by doing lots of diagnostic EUS cases and understanding the EUS anatomy.
Vipul, can I ask a question?
Please go ahead, Anil, please.
Vinay, a brilliant talk, and I think you have served the purpose of talk for the beginners in a very excellent manner. My question is, if you have competitive technologies of all the therapeutic procedures, we know therapeutic EUS the highest morbidity and even the mortality.
Yes.
So I want to ask you two questions. What is the advantage in terms of quality and quality of life? We want to do a glamorous procedure like drainage of the left hepatic duct into the stomach. Does it add to the quality or quantity of life? And then since it has complications which could be fatal, so in a private sector, you have two problems. One is the cost and second is the mortality. So how do you compare it head to head with competitive technologies like PTBD?
Yeah, it's a very, very nice question, and this debate still rages on. So it's right now we just sent a publication for endoscopy. What we have done is, and I think that serves as an example, we compared our data from 2008 when I was not doing interventional EUS and 2019 when I was good at EUS. So I removed the training period, and we took 350 odd biliary drainage procedures, both benign, malignant, distal malignant, proximal malignant, everything. And we compared the two eras, and what we found was that introduction of EUS BD in our department over a period of time, it doesn't happen overnight because this is a decade apart, has reduced cost, has reduced complications. Both things have happened, has reduced hospital stay. All three positive things, significant. And why that has happened is, A, we reduce our dependent on our interventional radiologist colleagues. So today, if I am doing an ERCP and let us say I have injected and I am not able to go across, for example, just an example, I need to drain it. I call my interventional radiologist and he said, no, yaar, I'm busy. I'll come tomorrow morning. I'm telling of situation in Bombay. I don't know how it is there. So the patient is lying. Then the interventional radiologist comes tomorrow and then he has to discuss fresh with the patient and take a fresh consent that, I'm going to do a different procedure. I'm going to enter from a different site. The psyche of the patient gets very disturbed with all this. Then what he does, at least in Bombay, is place a external catheter for 2 days. He says it is an infected system, so let me drain for 2 days. So the hospital stay increases. Another 2 days, the patient is in the ward. Then he comes and puts in an internal stent. So you have created a big, not only cost, but psychological trauma to the patient. If you have EUS BD at your place, what we do is take consent beforehand that suppose ERCP doesn't succeed, we will go in with the EUS scope. So as soon as the ERCP fails, and nowadays it fails pretty fast because we are following the ESG criteria. So we do a pre-cut. So about 4% or 3%, whatever is the failure rate, we just change the scope. And because now we have 10 years of experience, our failure rates in EUS BD are practically nothing. So the patient comes out of the OT with a stent placed. And that is a big investment. So there was an investment of time. I understand what you are saying, but if you develop an interventional EUS person in your department and let him do things over a period of 4, 5, 6 years, you will see that there will be cost savings, there will be complications reduced, and you will be doing endoscopic biliary drainage in 99% of your cases. Your PTBD requirement will be reduced to only complex hilar blocks, nothing else.
Uh, one small question, Vinay.
Yeah.
We have currently, except of hot axios, there is no dedicated US interventional platform. We are still using ERCP accessories. So what is your take for the future direction of development of interventional EUS here on now?
It's very, very good question. We of course we have stents now. I don't consider hot axios or axios to be an ideal stent. We further need refinements. Refinements are happening. For me, the number one accessory I need, because the commonest interventional EUS procedure I do is drainage of Warren. And I think all of you will agree that that is the one which I drain the fluid and the patient comes back with fever. And then I go in. I do not have a good device to remove that necrotic debris. And you're struggling for half an hour, 45 minutes, 1 hour. While I look at my surgeons or the laparoscopic surgeon, they use their fingers. They have such wonderful devices to clean the debris. So something needs to be done to have a better necrosectomy device. Second, lot of malignancy patients come with gastric outlet obstruction. Of course, we used to put enteral stents before. Now we are doing GJ, but I am not happy still with the mechanism which keeps the jejunum fixed close to the stomach. We need a better mechanism than what we currently have. So yes, there is a lot of need for additional accessories. So it's a growing field, and I'm sure a lot of people must be working on all these things to improve it further.
So I think we have exceeded the time here. Can we conclude, Dr. Arora? I would like to thank Dr. Jayanta, Dr. Das, Dr. Bandhir, Dr. Satyartha, and Dr. Ajay for being with us. I thank Anil for allowing me to conduct this very important session. And I thank our star speaker, Dr. Dheer, for a wonderful insight in this subject. Thank you very much, everyone.
Thank you, sir.
Thank you very much for having me. Thanks, Anil. Great. It was a great session. Thank you very much.
Thank you, Dr. Dheer. Thank you, Dr. Vipul, Dr. Jayanta, for this session. So now we move on to the next session. That is another exciting session on therapeutic endoscopy. That is third space endoscopy, recent innovations beyond POEM. And for this, I would like to invite our moderators, Dr. Pankaj J. Pasricha and Dr. K.K. Rawal. Dr. Pasricha is the director at Johns Hopkins Center for Neurogastroenterology, professor of medicine and neurosciences at Johns Hopkins School of Medicine. And Dr. K.K. Rawal is the treasurer of Indian Society of Gastroenterology, Gujarat chapter. He is the governing council member of the Society of GI Endoscopy, and he is also the vice president of the Gastroenterology Endoscopic Society at Rajkot and director, Prime Institute of Digestive Sciences, Panchwati, Main, Rajkot. I think Dr. Pasricha is held up somewhere, so I would.
He's traveling. He's on the road. I think Dr. Rawal will take over.
Yeah, Dr. Rawal, I would like you to start the session, introduce the speaker as well as the panelist.
Thank you, Dr. Anil and his team for this opportunity. Very well organized, and all the topics are really clinically very relevant in day-to-day practice. I really congratulate you for this nice CME. Dr. Amit Mahdev is our speaker. He actually needs no introduction to the Indian endoscopic faculty. Many of the people who are doing endoscopy in India must be knowing him. He is the chairman of the Baldota Institute of Digestive Sciences, Global Hospital, Mumbai. He is the professor emeritus at Department of Surgery, KEM Hospital, and St. GS Medical College, Mumbai. He is the pioneer in bringing many new techniques like POEM, STIR, ARMS, GERD, and of late this bariatric endoscopy in our country. He has published more than 200 papers and 7 textbook chapters. He is on the international editorial board of many reputed journals like GI Endoscopy International Open. In 2013, he received the Padma Shri Award from President of India for his excellent services in gastroenterology and field of medicine. We all know he is a very avid teacher and conducts many popular endoscopic training programs. He will be talking on third space endoscopy, recent innovations beyond the poem. May I invite the panelist for this session, Dr. Mukesh Kalla, Senior Gastroenterologist from SR Kalla Hospital, Jaipur. Dr. Vikas Singla, Director and Head, Gastroenterology and Endoscopy, Max Super Specialty Hospital, Saket, New Delhi. Dr. Sunil Dadhich, Senior Gastroenterologist and Professor at SN Medical College, Jodhpur. Dr. Kapil Sharma, Consultant Gastroenterologist from Batra Hospital, New Delhi. And Dr. Vinay Thorat, the Consultant Gastroenterologist at BJ Medical College and Head Department of Gastroenterology, Pune Hospital and Research Center, Pune. Dr. Vinay happens to be my senior at GB Pant, from where I did my DM. May I request Dr. Amit Mahdev to start his talk, please?
Yeah, thank you so much. First of all, special thanks to Dr. Anil Arora and his entire team for this wonderful conference. And of course, all the esteemed panelists, moderator, my friend KK Rawal, and all the panelists who are themselves experts in third space endoscopy. So let me share my slides. So this topic, as Dr. Rawal said, is very close to my heart, because probably from the time I started this procedure in our country in October 2012, we have seen the amount of growth that third space endoscopy has witnessed, not only in the world, but even in our country. Now we have so many centers in our own country which perform third space endoscopic procedures. Just to bring the whole thing in the right perspective, just to know what exactly is this third space, which has created so much impact over the last decade or so. The third space is nothing but the submucosa. And it is the space between the muscularis mucosa and the muscularis propria, which is the submucosa. And this submucosa, all that it contains is loose areolar tissue and some blood vessels which are coming from outside the organ, crossing the third space or the submucosa and supplying blood to the mucosa. So this is what the third space contains. Now, why did this third space become important? Because these two gentlemen, it was way back that they showed that if we utilize the third space, because traditionally all endoscopists have been practicing luminal endoscopy, which I consider to be the first space. And this third space is got highlighted because they showed that if you make a tunnel in the third space, then you can utilize that tunnel to perform any procedure outside the third space, that is in the muscularis propria, or even for structures outside the muscularis propria, or even outside the organ. Now this, in a traditional sense, could have meant creating a perforation, but here what they showed is that if you make an incision in the third space in the mucosa, in the proximal area, then enter the third space, go down, and then perform any procedures inside the third space, and come out and just close that mucosa. This entire mucosal flap, which is created because of the tunnel in the third space, seals off that procedure or intervention, whatever you have done beyond the third space. So this is the whole concept of third space endoscopy. And the first clinical application of third space endoscopy became a reality after the animal experiment, which was done by Pankaj Pasricha and Chris Gostout, was by Haru Inouye. This was in 2010, where in his first few cases, he showed that in a clinical perspective, we could actually perform a per oral endoscopic myotomy very effectively and very safely by a pure endoscopic technique without a surgical incision, and by utilizing this third space, creating a incision 10 to 15 centimeters above the OG junction, entering the third space, making the tunnel, and go inside the tunnel and cut the muscle fibers of the muscularis propria, and then just come up and close this mucosal incision. So this mucosal flap then seals off this entire tunnel. And this way, this created virtually a revolution. And now it is more than 10 years since POEM has been invented. We have more than 450 publications on POEM and its related various types of modifications, more than 15,000 or probably even more procedures performed all over the world. And the important thing is that this third space now has paved the way for various other interventions by which we can utilize the submucosal tunnel. Now, after POEM, the next thing which was invented was the gastric peroral pyloromyotomy, also called as the GPOEM, where you could actually cut the pyloric muscle fibers from inside through the tunnel for indications of gastroparesis or removal of submucosal tumors in the esophagus or even in the stomach by utilizing the third space, which is called as the STIR. Then we have submucosal tunneling ESD procedure. All of us know that ESD has been traditionally practiced by just cutting it circularly or half circularly and then going and cutting the flap which contains the tumor. But this was a very tedious and a very long procedure. So the submucosal tunneling ESD was invented for reducing the time taken for ESD and for improving the efficiency. Then, of course, was invented was utilizing the third space for cutting the septum in patients of Zenker's or epiphrenic diverticuli. And finally, also utilizing the third space in the rectum for performing a rectal myotomy in patients who had Hirschsprung's disease. Well, for all these procedures to be practiced, what is most important is to first understand how a proper submucosal tunneling procedure is done. So therefore, for any person who wants to know to practice any procedure beyond POEM, it's important to first get a mastery on the POEM procedure. And just to show you, these are the 4 basic steps which one has to master before doing any third space procedure. That is, first is a proper entry into the submucosa by creating the submucosal cushion by a fluid which is containing some amount of dye, either methylene blue or indigo carmine mixed with saline. And then what is most important in the mucosal incision is to cut not only the mucosa, but also the lamina propria or the muscularis mucosa, which is below the mucosa, so as to facilitate easy entry into the third space. So once this step is done by a simple rotation of the endoscope, and after you have cut the muscularis mucosa, one can very easily enter into the third space. You can see here that this is an endoscope which has got a high resolution, high magnification, and we have a distal cap attachment. Now, after entering inside the third space, why do I say that it is necessary to master POEM? Because by this, you will get proper control on your hand movements, hand-eye coordination, as well as proper usage of instruments. And the secret of utilizing the third space is to stay as close to the muscle fibers of the organ as possible. For example, in a POEM procedure, as we are conducting or doing the tunneling in the esophagus in the longitudinal axis, we keep on staying as close as possible to the circular muscle fibers, as you can see here, and keep on cutting the areolar tissue in the submucosa in a relatively left and right fashion, so as to make a reasonably wide tunnel. And after that, as you keep on encountering any blood vessels which come in the way, this is the way we have to achieve a proper hemostasis, because as I told you, what is there in the third space is not just the areolar tissue, but you see such type of blood vessels which are coming from outside the organ, crossing the third space. So we have to identify these blood vessels, anticipate, identify, and then properly coagulate them. You see here, the technique of coagulation is to apply the coagulation as close to the muscle as possible and keep on coagulating it until the entire vessel becomes completely whitish or completely coagulated, and then we cut it. And this is the way we continue dissection down in the tunnel. And then the next part is to check the adequacy of the tunnel. We keep on going in until we can see this 2 vessel sign, which is at the OG junction. Then some people, we can cut these 2 vessels, or we can even go by the side of the 2 vessels. Usually it is recommended that when you reach the OG junction, we go on the right side of the 2 vessel sign, because it is better to do a myotomy a little bit on the right after you cross the OG junction, to prevent cutting of the sling fibers of the stomach and to prevent GERD in the future. And once this is done, the final step is to perform the myotomy. You can see here the complete tunnel is done, which is relatively vascular because we have done a good hemostasis during the tunneling itself. And then the myotomy is started a few centimeters distal to the mucosal incision. Either you can do a circular or proximal myotomy, and we go in and we cut the muscle fibers and then finally come out and we apply clips and close the mucosal incision. The next step after POEM, which was invented, as I told you, was the submucosal tunneling endoscopic resection of submucosal tumors, which was invented in 2012 by Pinggong Zhu from Shanghai. And here he showed that by utilizing the third space, we can enter into this tunnel, reach the submucosal tumor, and then we can actually dissect out the submucosal tumor, actually as if you're doing an underwater swimming, underwater dissection. And then after dissecting the tumor out from all the directions, then we can just simply take the tumor out through the mucosal incision. So normally now we utilize this technique. The most common indication is for symptomatic leiomyomas in the esophagus, and rarely we can also utilize it for certain submucosal tumors in the stomach. Though in the stomach we usually see GIST or stromal tumors, where sometimes we also require to do a full thickness resection instead of just submucosal tunneling resection. But in the esophagus, this is a very, very wonderful technique. Here you can see we are entered the third space. We keep on dissecting the areolar tissue, and we have to maintain a direction towards the submucosal tumor. You can see this is how the submucosal tumor starts appearing. Then by utilizing a variety of knives, we dissect the tumor anteriorly from the mucosa and from the sides, and as well as posteriorly where the tumor is attached to the muscle fibers. We completely dissect the tumor out, and once the tumor is dissected out, then we can catch this tumor after dissection by means of a simple polypectomy snare and pull the tumor out through the mucosal incision. And this is how we can achieve a complete resection of the submucosal tumor. Then we enter inside the tunnel again, after which we have to achieve a proper hemostasis from where the tumor has got disconnected from the muscle fibers. And after achieving a hemostasis, we come out and then we can again close the mucosa by applying a series of clips. This is a wonderful technique which can be utilized for most of the submucosal tumors in the esophagus, provided the size is not more than 6 or 7 centimeters. Another indication where the third space endoscopy is utilized, you can see here, this was published in 2013, where Moin Khashab from the Johns Hopkins from USA came up with this technique for the treatment of gastroparesis. Most of the time, the indication was for idiopathic gastroparesis or post-surgery gastroparesis, but in some patients of diabetic gastroparesis also, this technique can be utilized, where he showed that you can create a submucosal channel few centimeters proximal to the pylorus, keep on dissecting towards the direction of the pylorus, and once we reach the pyloric ring over here, the muscle fibers of the pylorus are cut from distal to the proximal instead of from proximal to the distal, as we do in the POEM procedure. Here you can see one such case of G-POEM, where you can see the pylorus ahead. There is a cap which is attached to the tip of the scope. Now we are injecting this solution in the submucosal space of the stomach, few centimeters proximal to the pylorus. Then in the same technique as I showed you for the POEM, we are making this longitudinal incision in the mucosa and the muscularis mucosa, and then we enter into the submucosal space of the stomach. Mind you, the submucosal space of the stomach is a little bit more vascular than the esophagus. So you have to identify and anticipate appearance of these vessels, catch them, coagulate them, and then keep on dissecting ahead. Another issue is that in the stomach, as you keep on dissecting, we are likely to miss the pyloric ring and go by the side. So in between, you have to pull the scope back and make sure that your dissection is going in the direction of the pylorus. But once we reach the pyloric ring, this is how the pyloric ring fibers start appearing. And there you can see the duodenal mucosa. This is the submucosal space of the duodenum. As against the POEM procedure, we do not do any dissection beyond the pylorus in the duodenum because this is met with a higher chance of perforation of the duodenal mucosa. So there's no need to keep on dissecting inside the duodenum beyond the pylorus. But once the pyloric ring is reached, we take care of, we cut the muscle fibers of the pylorus from distal to proximal by using the insulated tip knife, as you can see here, and pulling the knife backward. and we do a complete myotomy distal to the proximal, especially of the pyloric muscle fibers and some muscle fibers also of the antrum. And with this, now we have seen that if you select the patients properly, then these patients can be relieved substantially of their symptoms of vomiting because of the gastroparesis. Another wonderful technique, which was invented again by Pingong Zhu in 2016, was for the treatment of Zenker's or epiphrenic diverticuli. Traditionally, we have been cutting the septum of these diverticuli directly on the septum by using a needle knife or various types of knife. But here there was a limitation because we could not cut the septum completely because it was associated with leakage in the neck, or it could be associated with various other complications. So therefore, the submucosal tunneling technique, a tunnel is created in the pharynx proximal to the diverticulum, and then the septum is oriented vertically. We keep on going towards the septum, and only the septum muscle fibers are cut. So this is how that procedure is performed. You can see here, this is the septum. On the left side is the diverticulum. On the right side is the esophageal inlet. And all of us know that in patients of Zenker's or epiphrenic diverticulum, the main issue is because of the large size of the diverticulum, the food preferentially goes and stays in the diverticulum. Then the septum causes a functional obstruction to the esophageal inlet. So here, a few centimeters proximal to the septum, we have created a mucosal cushion. Now again, we are cutting the mucosa. Now this submucosa is even more vascular, even than the stomach. So here you have to be even more careful because we have to catch hold of the blood vessels before it bleeds. Here you can see here one such blood vessel here. So we keep on cutting it and we keep on going towards the septum until we reach the septum muscle fibers. And once we start seeing the septum muscle fibers like this, on the right side you can see is the esophageal inlet. On this side is the diverticulum. And then fiber by fiber, by left to right movement or right to left movement, we can cut these muscle fibers of the septum completely right till its junction till the esophageal muscle, so that we can achieve a complete septotomy in a safe manner. Because after doing the septotomy, we are going to pull out the scope and then close the mucosal incision by a series of clips. For a few days, these patients may have a little bit of foreign body sensation because these clips are very high up in the cervical esophagus, just below the cricopharynx. However, later on, because the septum is completely cut, these patients are totally relieved of their symptoms. Now, this being a little difficult technique in the pharynx, a modified technique of Z-poem was recently invented by Alessandro Repici from Milano, where he showed that instead of making the tunnel proximal to the septum in the pharynx, we can directly make a tunnel on the septum. So what he does is, instead of doing a direct cut of the septum, what we do is we make a mucosal cushion by injecting some fluid on the septum itself, and then we make a little bit of a cut and then go by the side of the muscle fibers. Here you can directly see the muscle fibers. So instead of cutting the mucosa, we are going to dig inside like a well. So we push the entire scope with the cap in this small incision and then go by the side of the muscle fibers, and then we keep on cutting the muscle fibers only, but the mucosa is left intact. So this way we keep on cutting the muscle fibers and then we come up and just close this mucosa. So this way we are doing a modified Z-poem procedure, which is also called as the pose procedure. Now this is much easier to perform than a traditional Z-poem procedure, and therefore I would recommend that in most patients now, this is the technique which we tend to follow. This technique, as I told you, is also applicable for doing submucosal tunneling ESD procedures, originally invented by Yamamoto for gastric ESD, where you take a long time for ESD, you're doing a circular incision like this. But here we are doing now a submucosal tunneling ESD. We first do markings, then we make a tunnel, we make a incision proximal part, and then enter below this specimen, which is containing the early gastric cancer, and then we dissect the specimen out completely from below. Now, the main advantage of this is because we have kept the entire mucosa above intact and we are going inside the tunnel, this cap automatically retracts the specimen side, and then we can get a good view of the submucosa. And once we have completely dissected the specimen side from below in the submucosa, then all that we have to do is to cut the edges. And once we cut the edges, we can achieve a complete end block resection of the tumor, as you can see here. Or same way, we can do it for esophagus early cancer. You can see here almost a circumferential esophageal early cancer, where we have done multiple tunnels in the submucosa, not just one tunnel. So various tunnels in different areas, and then we dissect the tumor out below, and then connect all the tunnels inside or below the specimen side, and then later on just cut the edges out. And after doing this procedure, you can see here, you can achieve a en bloc resection of this tumor. You can see here how wide resection has been done. A complete early esophageal cancer has been resected by using the pocket ESD technique or the submucosal tunneling ESD technique. Well, out of all these procedures, the most studied procedure has been the POEM. And you can see here today, just a few years back, there was already a randomized controlled trial which was published, where the POEM was compared with the traditional laparoscopic Heller's myotomy. And in this multi-center randomized trial, where 8 European centers participated, you can see here that the clinical success of POEM was comparable to the lap Heller's myotomy. Serious adverse events were much lesser in the POEM procedure. However, the problem of reflux of POEM still continues to haunt endoscopists of who perform the POEM procedure, even though it is clinically seen in only around 8 to 10% of the times. Abnormal acid exposure can be seen in about 40% of the patients. So therefore, the originator or inventor of the POEM procedure decided to go beyond the third space. And it was a few years back that to take care of this problem or a problem of reflux after POEM procedure, he introduced the POEM with fundoplication procedure, which was actually a fourth space endoscopy procedure, where he actually showed that you can perform an anterior tunnel, and then below the crura of the diaphragm, you can go outside the esophagus, outside the stomach wall into the peritoneum, and then put the scope in the peritoneum, catch hold of the fundus, and pull the fundus inside the tunnel, and thereby you can create a fundoplication on the table itself during the POEM procedure itself. Now see here, this is how that procedure is performed. And since then, some centers in the world, we have started performing the POEM with fundoplication procedure, utilizing the third space and then going inside the fourth space. Here you can see we are doing an anterior tunneling. So there is an anterior incision. So it's somewhere at 11 or 12 o'clock position. And after doing that, we are doing a tunneling procedure. We go down. After that, we do a myotomy. And then how do we know that we have gone beyond the crura of the diaphragm? That is when we start seeing the subdiaphragmatic fat pad. You can see this is the fat pad, which is very classical hallmark of the subdiaphragmatic space. Then the visceral peritoneum, which is there, is cut by using a hemostat forceps. We use a coag grasper, and then we extend this visceral peritoneal incision by using a insulated tip knife, because outside you can see the left lobe of the liver. And there, after cutting this visceral peritoneum, we pass the scope out inside the peritoneal cavity, and then take a left turn, and left here you can see the fundus of the stomach. And then we can mark the fundus of the stomach by first doing a practice pass by catching the fundus, holding it with a grasping forceps, pulling it inside the tunnel, and seeing what type of fundoplication is taking place. So for this, we have to pass another ultra thin scope through the mouth into the stomach, take a U-turn, and once we have identified that area, we attach the fundus with a loop and a clip technique, and the same loop is also attached by a series of clips to the cut muscle inside the tunnel itself of the esophagus. And once that is done, all that we have to do is to tighten that loop, and once we tighten the loop, the fundus gets pulled inside the tunnel of the esophagus, and because of which we can create a loose wrap. It's very important to remember that in patients of achalasia cardia, they already have a abnormal emptying of the esophagus because of impaired motility of the esophageal body. So therefore, we should not do a tight wrap, and that is exactly the reason why surgeons used to do a modified Dor fundoplication, which was a loose wrap. So with this, we can create a loose wrap, and as you can see here, after this wrap is complete, now we are passing the scope inside the stomach, and on taking a U-turn, you can see it looks almost as if a surgically done Dor fundoplication has been created. So now there are some centers in the country where we have started practicing the POEM with fundoplication procedure at the same time of the POEM procedure. But the only problem here is that we have to always do an anterior tunneling, because you cannot do this procedure if there is a posterior tunneling. And this can be probably not very durable because we are using a simple loop and a clip technique. But if you can suture the fundus inside the tunnel, then it can become a durable technique. Well, I just want to tell you that endoscopic technology, you already saw that the number of techniques which have progressed in third space and slowly entered into the fourth space. But simultaneously, endoscopic technology is also evolving. And now there is already a possibility that in the future, in the next few years itself, we will be getting such type of an endoscope and such type of various arms which we can pass on this special platform, which is a multi-armed flexible robotic platform. And in fact, over the last 1 year, we ourselves have been exposed to this platform. We have been using it in our department, this flexible robotic endoscopic platform, where it has got multiple arms. And just imagine that if we start using such type of a multi-arm flexible robotic platform and utilize the third space and enter into the fourth space, the amount of procedures which we can start performing in the future are probably going to be beyond our imagination. And this is already on the horizon. This platform is, of course, presently in the prototype stage. We are just helping them to develop this platform, but I'm quite sure that in the next few years, this platform will become a clinical reality. And endoscopy, what is originally started at diagnostic, then interventional, therapeutic endoscopy, I'm quite sure there will be a new field emerging, which is going to be flexible endoscopic surgery. Thank you for your attention.
Thanks, Amit. Just taking us through the exciting journey of third space. I was feeling just like it is an expedition to the Mars with your scope as a rover. Superb. So now we have a very learned experts here. Let's ask their opinion also about these new innovations which Dr. Amit just described. With submucosal endoscopy, we can remove the tumors arising from the muscles layers, particularly in the esophagus. So, Dr. Vikas, if he is on the board,
yeah.
What are your protocols for the STIR? I mean, you do CT, EUS, FNAC, number one. And number two, is the size a limitation for the STIR?
Yeah, I will take the second question first regarding the size. So I think there are two dimensions. One is the length and second is the diameter. So any length of esophageal submucosal lesion arising from the fourth layer can be removed by the STIR technique. But I think the diameter should be less than 3 centimeter. Otherwise, it will be difficult to remove through the pharynx and the upper esophagus sphincter. So diameter should be less than 3 centimeter. And regarding the workup of these lesions, yeah. So if there is an indication to remove the lesion, and EUS is suggestive that it's a leiomyoma, hypoechoic lesion, and arising from the fourth layer, it can be directly removed without a EUS FNA. And between the EUS and the CT scan, I would prefer doing a EUS. It will give me the layer of origin. It can nearly confirm the diagnosis, and I can also look for the periesophageal lymph nodes. Only if I had suspicion of involvement of the surrounding organs like trachea or other vascular structure, I will go for the CT scan. If EUS is giving me the full adequate information and without lymph nodes, and I have planned the removal, I think one can go ahead without the tissue diagnosis in these cases. If one is planning the follow-up, then one may do a tissue diagnosis initially and can counsel the patient regarding the benign nature of the disease. But the yield of EUS FNA will be around 60 to 70% only.
Okay, true. See, incidence of GERD is quite high, as Amit showed after POEM in most studies, maybe 50% in initially 3 months, then later on even 40%. So there was an editorial in the journal, Will Reflux Kill the Poem, a few years back. So what is your take on POEM F, please, Dr. Sunil Dadich? Should it be combined with the index procedure or afterwards as the needed?
Thanks, Dr. Aval. As we all know, ecclesia is an incurable disease. We just provide the symptomatic relief by cutting the sphincter by various ways and means and relieving the dysphagia symptom by reducing the resistance at the LES level. And LES is the integral part of anti-reflex barrier. So reflex is bound to occur with whatever procedure we are using. So the degree of reflex will depend upon the efficiency of LES cut. So since in POEM we are doing the myotomy directly into the region and inside the wall of the esophagus, so the incidence of reflux is quite high with POEM. And with 24-hour pH monitoring studies, it is around 55 to 60%. And with erosive form of reflux, it is around 20 to 23%. And Dr. Amit has shown the procedure to stop this reflux by doing the fundoplication along with the POEM. But I personally is against this procedure because two reasons. One, we are doing one procedure to cause the complication, and other is to prevent that complication from occurring. I think it should be reserved for the people who have symptomatic or erosive form of reflux and those who are PPI dependent patients or those who cannot tolerate the PPI. Another point here I want to make is with the availability of newer imaging techniques like the functional endoluminal imaging and the FLIP, we can delineate the LES as well as the distal esophagus in a 3D manner. And we can select a site over the LES where we can cut a part of it to relieve the symptom. At the same time, we prevent the occurrence of reflux. Just like you kill the snake as well as you save the stick. So I will be against doing it all and reserving it for the people who have symptomatic reflux or those who are having erosive form of reflux.
Amit, your take on this?
I agree with Sunil because see, we have done this in quite a few patients, and the paper which we published in Digestive Endoscopy, we showed that this procedure doesn't last. See, presently this POEM with fundoplication procedure we are using loop and clip technique is not at all durable. In fact, within 4 to 6 months, most of these clips loosen up, and that fundoplication, which appears so nice during the procedure, opens up. And another thing is, as Sunil said, doing fundoplication in each and every patient is an overkill because only 50% are likely to develop GERD. Only 15%, 10 or 15% may have symptomatic GERD. So I think we should reserve to do anything only for those type of patients. And in them now, instead of doing anything, we can just do an endoscopic full thickness plication by using the Gerdex device. With that, we can achieve a similar result, what we can achieve with a good fundoplication. So I completely agree with that.
Now we are running really short of time, and others are behind me to complete the session. So thank you.
Dr. Rawal, can I ask a question to Amit?
Your pleasure.
Amit, excellent presentation. You are the master of third space endoscopy. It's because of you that we have got stimulated in doing so many procedures, and it has really revolutionized the third space armamentarium in the kitty of the gastroenterologist. I'm lucky to have both you as well as Pankaj, who was my immediate senior at AIMS, who are the founder of this technique. Recently, we removed a 6 centimeter leiomyoma from the mid-esophagus. In the hindsight, I got stuck up for almost 3 hours. I took less time to dissect it by doing a stir technique. By taking it out of the tunnel and from the cricopharynx was a nightmare. So should I continue doing it, or what do you think? Could I have pushed it back? Ultimately, we were able to retrieve it through the cricopharynx, but we spent almost 3 hours. Is it possible to push it down if you cannot get it back into the from the mouth? Can you push it down into the stomach?
Of course. You can push it down into the stomach, or you can do a piecemeal resection. But you have to do the piecemeal resection until it is still attached to the muscle. Because if it is not attached to the muscle, if you try to cut it, it's not going to cut because there is no connection to the body. So you can do a piecemeal, or you push it in the stomach, but you can't get a biopsy. So you leave it in the stomach for some time. You'll be surprised that within a few days or maybe few weeks, this whole tumor will get digested because of gastric acid. It's like a piece of meat somebody has eaten.
Yeah.
And that whole tumor will vanish from the body.
See, when we were trying to extract it out, the muscles were so good, as if these were the muscles of Salman Khan's bicep. So it is so hard, so firm. So I was worried whether it gets digested in the stomach.
It gets very well digested. It will be complete dissolved.
Let us take few more questions. Now, focus has shifted from the septotomy to myotomy as far as Junkers is concerned, because in septotomy you can't completely cut the muscle. So, and the recurrence with the jet poem is obviously very low. So how do we ensure complete division of the septum, Dr. Kapil Sharma? And is it the extension of the myotomy on esophageal side, what Dr. Amit told is important?
1 to 2 centimeter beyond the base of septum, esophageal myotomy is desirable. If you want to extend further, you can land up into the complication like a perforation and the bleeding. You know, there is no muscle on the diverticular side because only there are buccopharyngeal fascia. If you cut too much, then you will land into the problem. You might have perforation. Even though sometimes you have very large diverticula, there will be mucosal access, and then sometimes these mucosal access give rise to pseudo diverticula. We should be aware about it, and then we should have some kind of precaution. We should extend 1 to 2 centimeters beyond the base of septum, but should not extend too much. Otherwise, we'll land into the problem.
Amit?
Yeah, I agree with him. But you know, sometimes when you start doing this septotomy in the submucosal tunneling approach, you keep on cutting, the muscle fibers don't seem to end. It appears that they keep on appearing, they keep on coming. So what you do is, when they become very, very thin, you stop seeing any more vertical muscle fibers. That is the time to stop. You already cut 2 to 3 centimeters on the esophageal side.
Yes, once I went into the esophagus and the muscle was not ending.
Yeah, it doesn't. It appears as if it is not ending. You will finally reach the OG junction.
What is the maximum size of Jenker diverticula that is amenable to the jet poem? Maximum size of diverticula. Size doesn't matter.
Size doesn't matter. Size doesn't matter because most of the times the bigger diverticula are more symptomatic than the smaller diverticula. But you know what happens? I'll tell you what. After doing a Z poem, even if you have done a septotomy, that redundant mucosa which is remaining, that also can cause a little bit of dysphagia. So now you have to cut that mucosa also. So we use a double channel scope. We catch hold of the mucosa, pull it inside from one side and apply an endo loop so that mucosa necrosis is off, and then you create a defect in that mucosa also, because the redundant mucosa is not going to go away. You only cut the septum.
Valid point.
So, see, what is the learning curve? A lot of talking about the poem training and all these, but what is the learning curve for the poem, Dr. Mukesh Kalla, if you can tell us?
Yeah, nice question. Our program started way back in 2017 mid, when Dr. Madhav came first time to Jaipur for doing a poem procedure. So I think observing seniors doing the procedure, and the porcine model is a very perfect model for learning poem procedure, because except for the bleeding part of it, rest is almost similar what you're going to encounter when you're going to do a poem. Some 8 to 10 times having done this experiment on animal porcine model, where you have seen that you have not injured the mucosa and you're successfully across the GE junction. Then what we did was, we requested few of the senior colleagues. Vikas is on panel. He was kind enough. Pankaj Desai was another guy. Both of them were kind enough to supervise our working in our center. And subsequently, then the ball starts rolling. But I am sure like 8 to 10 patients in the supervised patients, and subsequently you can start doing it.
So last time there was a paper from China, and they said 100 poems are required to decrease the complication rate. So I was just wondering, Amit, on your take?
Yeah. Honestly speaking,
yeah. No, you want to say, Mukesh? Yeah,
no,
I also
okay,
feel
sir,
that I also feel that around 100 poems is necessary, because you will keep on seeing some surprise or the other until you reach around 100. 100 is not a magic figure, but some surprise or the other you keep on seeing. There's one message I want to give you, that irrespective of what is your efficiency and what is your experience, don't take any submucosal procedure lightly. Achieve a perfect hemostasis, go slow, don't try to unnecessarily hurry up. And even if you can finish the procedure in 10 minutes or 15 minutes or 20 minutes, take 45 minutes. Only then you can achieve a proper, efficient, and a safe procedure. See, because you'll keep on seeing surprises. Even today, even after doing almost 4,000 poem procedures, you may encounter some fibrosis in some patient, and you try to dissect, and you can create a perforation which you'll have difficulty to close. And it can be a trouble. There can be various issues. I did not show you what difficulties we can raise. I only showed you the rosy picture of the entire thing. A lot of difficulties you can face.
Third
Amit,
space.
is there a limit to the size of the submucosal tumor, say in the gastric, in the greater curvature of the stomach, 4 centimeter leiomyoma?
Stomach is not so easy to do submucosal. In stomach is not simple because you can't create a tunnel so easily inside the stomach around the tumor because it is not so straight like a esophagus. So in stomach, most of the time you don't see leiomyomas. What we see is cysts. And normally for cysts, we don't do submucosal tunneling. They require a complete dissection. You try to remove it from the muscle. If you can't, you have to do a full thickness resection. And then that defect you have to close by using an overstitch, a stitching device, suturing device.
Regarding the stir, first when you are trying to dissect the tumor, first you will dissect from mucosal side, then laterally, then muscle. What is your protocol, sir?
Both. See, mucosa and side is the first, but simultaneously also start dissecting from the muscle.
The problem when you are dissecting the muscles, because there will be attachment with the muscles, then tumor start moving when you are trying to dissect with the mucosa.
Yeah, so muscle is the last. Muscle is the last. First is mucosa, and along with the mucosa side, mucosa and side, mucosa and side, try to go beyond the tumor as much as possible. Because of the cap, sometimes you can't go completely beyond. The cap will prevent you from going beyond. So if that is the case, you dissect as much as possible, free the tumor from the sides and the surface from the mucosa, then start cutting the muscle. And even if some tumor is attached still to the tissues, you can still catch it with a snare and just pull it out. And by applying force, you can detach it from the muscle.
Sometimes the slippery nature of the tumor, you cannot catch hold of by the snare. Then sometimes you have to apply coagulation current, and the tumor will impact it, then you have to pull it out.
Correct. True. Because it is a very slippery tumor.
Yeah, Dr. Amit, sometimes there is a tumor at the G junction and along the greater curvature. You can diameter 2 to 3 centimeter. So in those cases, what you prefer, stir or the EFT or the excavating EST? Bang at the G junction.
First we try stir.
Okay.
But I know that at the G junction, again, because of the curvature, you're going to land in trouble. Will not be able to go around the tumor properly.
Yes.
So excavating ESD is a better choice. So you take a U-turn, take out the mucosa from the superficial part, and then keep on dissecting by the side, expose the entire blob of the tumor, and then cut it from the muscle.
And how will you close the defect at the G junction? It's a suturing or the Ovesco?
We can. Ovesco, that defect can be big. So if the defect is big, you can't close it with Ovesco. So then you have to use either a suturing or you have to use a loop and clip technique.
And any risk of leakage post-operative leak?
What?
Any risk of leak after the closures at the G junction?
No. Okay. If you close it properly, there is no risk of leak. Just put a Riles tube, keep the patient NBM for some time, it will heal. The stomach has got a remarkable property of healing because of excellent vasculature.
Okay.
Dr. Vinay, I know you love music and paintings. We have seen your paintings. So Prem has originated in your city. Prem, I mean, for rectal endoscopic myotomy. So now third space endoscopy has reached up to Chbd, as Amit saw, Chbd poem. So how do you see the future of the third space endoscopy?
Yeah, see, the limitation is going to be technology and imagination. So I think the big area where it can work is dysenergic anal sphincter. If you can do a partial sphincterotomy there by using these techniques, I don't know, that is an area which is really understudied. And I think people should look at that. And of course, implantation of devices like electrical stimulation devices for the esophagus, and especially preferably those who respond to acid exposure in the esophagus. There, the limitation is technology. So I think the only limitation is going to be technology and human imagination. And I think this is procedure here to stay and grow. So the future is very bright for this procedure.
And Amit, you think that robotic endoscopy will take over in due time? Because we at the moment don't have the accessories, proper accessories for the third space.
Yeah, that's what I'm saying. So you saw that video which I showed you of the multi-armed robotic scope, which has got these multiple arms where the accessories are almost like laparoscopic surgery. You know, the grasping forceps, the cutting forceps, and in the future, we'll also probably have a harmonic scalpel, which we can pass through that. And then dissection, cutting through tissues, or even suturing will become quite easy because we can carry a needle also through that robotic platform. We have done everything because this was a prototype model and we started. But Presently, it is very, very raw. It's still under development. We also passed it in humans. We passed it in the esophagus. But the scope was so thick that it was not easy to maneuver across the stomach, the antrum of the stomach. This definitely is going to come in the future because I've actually used it, and we know that this is coming is going to come in clinical practice.
My last question, Amit, this G poem for diabetic gastroparesis is often not rewarding. So how to select the best case for the good results?
It's very difficult to select. See, most important is we have to do nuclear studies, gastric emptying studies. We have to make sure. Sometimes we can also use the endoflip to see the pressure at the pylorus, whether it is spastic. Another way is we can do some botulinum toxin injection in the pylorus and see if that works. If that works, usually G-POEM is going to work. However, we don't do botulinum toxin with the fear that it may cause a little fibrosis in the submucosa. So only with nuclear gastric emptying studies, and if the patient is grossly symptomatic, then we perform the G-POEM, but we give them a guarded prognosis. Because if you do, the success rate is not always guaranteed of G-POEM.
True. So thank you, Dr.
Can I
Amit.
speak in between?
Yes, yes.
So
Yes,
the
Rajesh.
two comments, one doubt. Vikas has asked about the OG junction. The most important thing, whenever you are dealing with the OG junction submucosal tumor, please make sure that your scope should have a bending of 180 degree. Because many of the time, multiple time use of the scope, your scope is not completely bending. At OG junction, you may be able to close the defect with the routine clips also, provided your scope can completely bend. There's very important aspects of treating those patients. Second, which is in my doubt, we talk about the botulinum toxin at the OG, at the pyloric ring to inject and produce a relaxation of the pyloric spasm. But the contrary to that, it also produces a gastroparesis. So I don't know how this concept, this has come in my mind because generally botulinum was tried in some of the obese patients to decrease the gastric emptying. On the contrary, we are releasing the spasm and we are delaying the gastric emptying. Both are going to, there are studies about botulinum toxin in pyloric spasm also. But when we talk about the true gastric emptying post-surgical cases where the vagus nerve are injured, they are the true cases where it is useful, not the diabetic patients. And regarding the botulinum toxin, it is still in my mind, what is the explanation for it? Because it
Rajesh, in obese patients, botulinum was not used at the pylorus. It was used for the antrum. Now, this is purely in the pyloric ring. We have to only relax the pyloric ring, not the stomach motility.
Okay.
We are not injecting botulinum in the stomach.
Okay. Okay.
And Amit, the last question, as the Rajesh raised the issues of the flexibility, do you think a 190 HQ is more rigid than 190 H? Should we change the scope?
No. I don't think so. HQ, you can do it equally well.
Okay.
Proper amount of retroversion.
So if there are no more questions from the panelists, may I conclude the session?
Thank you so much.
Thank you, Dr. Amit, and all the panelists for very lively discussion, raising up all the issues. Thank you all.
Thank you, sir.
Over to
Thank you.
Dr. Asif.
Good night.
Thank you. Bye. Bye.
Thank you, Dr. Amit, for that exciting lecture, especially that robotic endoscopy. Thank you, Dr. Raval, for moderation, and thank you all the panelists. So we move on to the next session, that is EMR and ESD, current indications and techniques. For this, I would like to invite our moderators, Dr. Matthew Phillips and Dr. Nilay Mehta. Dr. Matthew Phillips is senior gastroenterologist at Lizzie Institute of Gastroenterology at Kochi. Dr. Nilay Mehta is gastroenterologist and at the Vedanta Institute of Medical Sciences, Ahmedabad, Gujarat. So over to you, Dr. Matthew and Dr. Nilay, for inviting the speaker and also introducing the panelist.
Nilay, are you there? Very good evening. I think it's a great privilege to attend this conference. It is wonderfully going very well, very relevant topics and excellent discussion. And the beauty of this conference is that there is enough time for discussion. Actually, that is very, very important for having a very successful conference. And now, after having many interesting sessions on therapeutic endoscopy. Now we have yet another very important session on ESD, and that is on the current indications, current status of ESD and EMR. And we have an excellent speaker, that's Dr. Amol Bapaye. He is currently the senior consultant endoscopist and interventional GI endoscopist and chief of Department of Digestive Diseases and Endoscopy at Dinanath Mangeshkar Hospital and Research in Pune. And we have two panelists. My my co-moderator is Dr. Nilay Mehta, and I think I'm not seeing him. He is currently at Citus Hospital, and I request him to also join this meeting. If there is any technical problem, I request the admin group to look into that, please.
Nilay is here.
Yeah.
And we have two panelists, and that is Dr. Amit Singhal. I don't know whether he's joining. Dr. Gaurav Chawla, consultant gastroenterologist, hepatologist, and advanced endoscopist at Kanpur Medical Center. And we have Dr. Nitin Gupta, chief endoscopist at Rajiv Gandhi Cancer Institute. And one more, that is Dr. Vijayendra Kirnake. I don't know whether they have joined or not. So can I start? I request Dr. Amal, who is my close friend, and here we have been associated for so many years. We have traveled together. And so Amal, you are the man of ESD, and almost started very early. And so we would like to know about hear from you about indications, limitations, and current status of ESD and EMR, especially with the Indian background.
Thank you, Matthew. And am I audible there?
Yes, wonderful.
Let me share my screen. At the outset, let me thank Dr. Anil Arora and his team for this kind invitation, and also enjoying this course very much. I enjoyed the previous few lectures as well. Getting some background noise, I don't know. Yeah, okay. So today we're going to discuss a little bit about EMR and ESD, current indications and techniques. And obviously 20 minutes is too short. But endoscopy and GI oncology, so when we are talking about early GI mucosal cancer, the role of the endoscopist is, one is for the diagnosis, where we perform screening, surveillance, high definition scopes, and so on and so forth. And at the same time, also regarding treatment, where endoscopic resection or endoscopic ablation can be performed. And today we're going to limit our discussion to endoscopic resection. So when we're talking about endoscopic resection, based on the layer of origin, lesions from the mucosa or the submucosa can basically be treated using the procedures called as EMR and ESD, and that is what we're going to be discussing about. So what is EMR? So EMR is a technique modified from polypectomy. That means we are going to be using a snare to resect sessile or flapped neoplasms which are confined to the superficial layers, possibly the mucosa only, or sometimes the submucosa of the GI tract. Whereas endoscopic submucosal dissection or ESD is an en-bloc circumferential resection of the pathological mucosa through the middle or the deep submucosa, and we peel the lesion off from the muscle layer. So that's quite a bit of difference in how these procedures are performed. We'll come to that in a while. But what is important to understand is the primary function of both these is to provide tissue for accurate pathological staging. These developments have been possible because of advances in imaging and diagnosis, particularly image-enhanced endoscopy, changing concepts of pathophysiology and management of cancer in general, where organ-preserving resection surgery is becoming more and more popular, and developments in endosurgical techniques where minimally invasive procedures leading to early recovery and return to activity are now possible. So, a few points about early or superficial mucosal cancers. Cancer starts from the superficial mucosal layer and invades deeper down. So what happens is, until it reaches the superficial submucosal layer, it usually will not touch the lymphovascular plexus, and so because of that, the lymphovascular metastasis is quite rare, lymph node metastasis is quite rare, and that is the reason depth of invasion is the most important consideration when we are dealing with early cancers. And the penetration obviously increases the risk of lymph node metastasis, so much so that risk of lymph node metastasis is less than 3% for mucosal lesions, but goes up to nearly 18 to 19% when there is deep submucosal invasion. Therefore, in general, and I'm going to touch upon this in a later part as well, but broadly the indications of EMR and ESD, if we have to consider, is for treatment of superficial or early mucosal GI cancers. Along with that, Barrett's with dysplasia or similar some other premalignant conditions, polyps with intramucosal cancers, even benign lesions of the mucosa, muscularis mucosa, and the submucosal layers can be resected, and the indications are expanding. This is the ESG guidelines published about 5 or 6 years ago, wherein they classified and the lesions from the esophagus, stomach to the colon and the rectum. And here we can see that ESD is the first option for squamous cell cancer of the esophagus, also for the stomach, and colorectal non-granular or depressed lesions which are more than 20 millimeters. Whereas an EMR is the first option for superficial lesions in the Barrett's or gastric lesions which are less than 10 millimeters or which are in a difficult position for ESD, for duodenal lesions, and at the same time colorectal lesions which are non-granular and which are less than 20 millimeters. So today, in today's talk, we're not going to discuss about the mucosal characteristics of the lesions because that will be too long a discussion. But what is important to understand is whichever method that we choose to perform the procedure, there is always a need and a preference for an en bloc resection. That is because one of the roles is to achieve a curative resection, but along with that, we also need to allow the pathologist to make accurate histological evaluation and also assessment of the risk of lymph nodal metastasis. Lesions more than 10 millimeters, we know that they have a malignant potential, and unless we have an en bloc resection, there is a higher chance that residual or recurrent disease can occur. Coming to EMR, so this is a flat lesion in the mucosa, so we elevate the lesion to create a pseudo polyp, and then the pseudo polyp is snared so that this leaves a final defect. Techniques of EMR can be divided into device assisted, where we can use forceps to lift using a double channel scope and then apply a snare, or a cap EMR or a band EMR, and also a freehand technique which is an inject and cut, and also it has other variants like the underwater EMR and cold snare EMR. So we're going to basically be discussing about the freehand techniques because that is probably more important currently with the. So this is a lesion, a flat lesion in the colon and in the rectum. So the lesion is elevated from the deep layer and it is resected either as a piecemeal manner or in an en bloc fashion. Usually lesions up to 20 millimeters can be resected en bloc, but anything beyond that will require a piecemeal resection. A freehand technique is usually good for elevated lesions, and for flat lesions what is important to note is we need to suction as we are applying and closing the snare, and a variety of snares are available like the barb snare, oval snares or round hexagonal, which can help us to grab the adequate amount of tissue. Coming to underwater technique of EMR, this is a relatively new technique where there is no submucosal injection, which is performed, and actually the lumen is filled with water or saline actually, and the air or the carbon dioxide is aspirated completely, so that the entire procedure is performed underwater. The principle is that water submersion causes the mucosa to float because the fat in the submucosal layer is buoyant, and the mucosa involutes, which causes a natural separation from the muscularis propria layer. Therefore, the snare can entrap only the mucosa, and we can in fact get larger pieces, and we can get a en bloc resection for a larger lesion. So, as I mentioned, up to 2 centimeters can be snared en bloc using a standard EMR, but with an underwater we can go up to even 3 centimeters or so. And this also protects against perforation or deep thermal injury, and it is especially useful in the colon and in the duodenum where the mucosa is loose. It is not suitable for the esophagus, stomach, or in the rectum, because there the mucosa is quite adherent to the. So this is the underwater EMR. This is a meta-analysis which showed that en bloc resection as well as recurrence rates were superior for an underwater technique as compared to conventional EMR. The other kid on the block is a cold snare EMR. We know that a deep muscle injury is the most feared adverse event after an EMR. In a cold snare, no diathermy is used and the snare is pulled through the tissue as a cold cut. Usually we prefer to use a thin wire, sharp, stiff snare, and the polyp is oriented at around 6 o'clock, and then the snare is advanced parallel to the wall, and then a suction. We apply suction and simultaneous grasping with cutting through of the polyp. There is a very low incidence of delayed bleed, basically because tissue plasminogen gets activated because of the cold cut, and that causes hemostasis. And it is very useful for diminutive polyps as well as for sessile serrated adenomas, and en bloc as well as piecemeal resections can be performed, and it has a very high safety profile because the risk of muscle injury is almost non-existent. So this was a large study from the Michael Berg's group, and where they studied outcomes of 562 sessile serrated lesions in 474 patients, and they compared 156 cold snare polypectomies with 406 EMRs. The technical success was comparable, recurrence rates were comparable, but adverse events were none with a cold snare approach. So probably for sessile serrated adenomas and for diminutive polyps, the cold snare technique is probably the new standard of care. The one problem with EMR, as I mentioned, is that en bloc resection is possible only for lesions less up to 2 centimeters, and more than 2 centimeters lesions require piecemeal approach, and the plane of dissection can also sometimes be very superficial, which may be oncologically incomplete, and very often because of diathermy artifacts, the margins of the resection cannot be commented upon, and because of that, whenever a piecemeal EMR is performed, recurrence rates have been reported to be much higher as compared to an ESD technique where we achieve an en bloc resection. And that is the reason ESD was actually conceptualized and initially developed, because recurrence rates and the pathological diagnosis put increasing pressure on devices for a wide field EMR, en bloc EMR. Therefore, coming to ESD, the procedure can be covered in 6 steps. We first mark the lesion, then we inject the lesion from the submucosa, and then we incise the mucosa, then we dissect underneath in the submucosa, and then complete the resection. It is a procedure that requires precise cutting and dissection and requires very meticulous handling of the instrument. That is very important. Several instruments are required, a distal cap is required, several knives have been described, and special knives particularly, which can inject and cut at the same time. So this is how a conventional ESD is performed. Now, this is a lesion, a Barrett's cancer at the gastroesophageal junction, and it is extending just beyond the fold, beyond into the stomach. So we mark the lesion all around. I'm going to run through some of these videos. So this is how the lesion is being marked. Now we inject in the submucosa to create a nice elevation, and elevation is achieved on all sides, and then we start mucosal incision. We perform a mucosal incision and we create a little bit of a pre-cutting so that we can introduce our endoscope under the mucosal flap, into the submucosa. The deep submucosal layer is utilized for dissection because that will take care of also the lymphovascular plexus. And here we can see these are the vessels which have been on this side. On the right side lower corner is the muscle layer, and these vessels have to be divided and they have to be taken along with the specimen. The mucosal incision is extended, and then finally we retroflect the scope in the stomach and complete the dissection on the gastric side. Meticulous hemostasis is mandatory because it will also help us to clear the field of vision very clear. And this is the final dissection ulcer. Here you can see we are performing hemostasis, and now that is the final ulcer. We sometimes may use some hemostatic spray underneath, and this is the final specimen. So ESD is basically technically quite a challenging procedure. Several challenges have been encountered and have been reported. One of the major challenges is retraction and countertraction, because unless we retract and apply countertraction, we will not be able to obtain a good plane of dissection, and layer separation cannot be achieved, and then an exposure for safe dissection cannot be maintained. Also, usually these procedures are quite long, lengthy, especially when the lesions are large or circumferential, or when the lesions are located in difficult locations like the right colon, the duodenum, gastric fundus, or on the lesser curvature. Even the gastric antrum and distal rectum are relatively easy. Prior EMR or biopsy can cause submucosal scarring, which causes a difficult lift with difficult dissection and increased risk of perforations or even a longer procedure. And the learning curve is pretty steep. We require a stable endoscope position, and risk of bleeding or perforation as always present intra-procedural or even delayed. And to circumvent these risks, several options have been devised by workers over the last 2 decades or so. I'm going to discuss some of them, not all of them, predominantly about the retraction and the countertraction technique, and also the submucosal cushioning. So one thing is regarding the injectate, what we used to inject in the submucosa. Initially it was recommended to use normal saline, but the problem with normal saline is because it is isotonic, it gets absorbed very rapidly. So several of these injectates have been devised. Our common one that we use is the gelofusine, because that is quite cheap, but there are these commercially available injectates like the Eleview or the Oris gel. And also hyaluronic acid is supposed to be very effective because it can maintain the lift for a very long time. Combined injector knives are also highly useful because they prevent multiple scope exchange, instrument exchanges, and reduce that, and therefore reduce the procedure time. Also hemostatic agents, we prefer to use the Hemolog or the ferrocrilium, but Hemospray and Purostat are others which are available and they can be used for hemostasis. Apart from that, now coming to the retraction techniques, a very simple retraction is using a dental floss and a clip method, where we pull the scope out, we pass the clip applicator through the scope, and we tie a loop of dental floss to this. Then we pass the scope inside, we fire the clip on the edge of the mucosa, and now the line is dangling by the side of the scope, which can be lifted up, and we can get a very nice elevation and separation of the layers, and see how easily we can see the layer separation, and the procedure becomes so quick and we can just cut through so easily. So that is very important. There we can get the procedure done in no time. Similarly, particularly lesions which are in the duodenum, like a duodenal neuroendocrine tumor, these are highly fibrotic lesions and they are densely adherent to the submucosa. And here also a clip and line technique is very useful, because we can lift up the lesion very effectively, and then we can dissect underneath which will also increase the safety profile of the procedure, because then we can prevent a full thickness defect which will require formal closure. So here you can see that it is now lifted up well. So a traction technique is actually much more superior to a conventional ESD, and it has been shown that en bloc resection rates, complete resection rates, and perforation rates and bleeding rates are all significantly improved, and significantly shorter procedure time has been reported. Recently, a new device has been developed, which is a counter called the counter traction clip. Instead of this clip comes preloaded with a spring and a nylon loop. So what is done is, after the mucosal incision, this clip comes out. There is a loop over here, and this becomes very handy because we don't need to pull the scope out, tie the dental floss and all these things. So here now the clip has been applied, and what we do is we apply another clip and we apply that onto the opposite wall, which will give a fantastic retraction now. There we can get a nice lift and we can get this thing. The other technique which Dr. Amit also mentioned about, touched upon a little bit, was the pocket creation technique. Here, instead of a conventional method where we perform a complete resection, we create a small mucosal incision and we undermine the lesion completely so that we dissect in the submucosa, and then we complete the mucosal incision on all sides. And Professor Yamamoto has shown that in an intentional to treat analysis, it has proven to be highly superior to conventional ESD. So this is how we can perform a conventional pocket creation method. And there is also a modified pocket creation which we reported, where we can continue to perform pockets particularly for large lesions. Here is lesion. We are creating a small mucosal incision. We go in, and once we go in, we dissect underneath. Then we complete part of the mucosal incision on one side, on the other side, and then we continue the dissection further. So that is how the final outcome is. Pocket creation also helps in gastric lesions because it helps to coordinate between the scope direction and also the dissection direction, and it helps to assist the procedure. Similarly, like pocket, we can perform a complete tunneling ESD, particularly in the esophagus. It can also be done in the rectum, but it's most useful in the esophagus, where we can perform an oral and an anal mucosal incision and then tunnel like in a poem, and then complete the mucosal incision on all sides to complete the dissection. A final double tunneling butterfly technique has also been reported, which actually helps in this thing. So efficacy of traction techniques has been shown in all organs, is from the esophagus to the colorectum as well as in the stomach. And now coming back to the indications. So although these are the indications which are currently most often followed globally, the JSG guidelines which were published just last year are the most relevant when we are talking about ESD in the Asia at least. So this is for the esophagus. So for epithelial or lamina propria tumors which are non-circumferential, endoscopic resection, and lesions which are less than 5 centimeters, again endoscopic resection, but longer lesions which are circumferential may still require surgical resection or chemoradiation, whereas which are a little bit deeper invading may require surgical intervention earlier. Outcomes of endoscopic resection with chemoradiation are comparable to surgical resection. That is what we need to remember. Coming to for the stomach, so when there is no ulceration, lesions less than 2 centimeters or more than 2 centimeters, and when there is ulceration, lesions up to 3 centimeters. So this is how it has to be performed. So when lesions are without ulceration, without horizontal margin involvement or vertical margin involvement, and no lymphovascular invasion. These are patients who can already follow up, but patients who have some features of deep invasion will require either surgical resection or will require follow-up. And coming to the colorectal, so all colorectal polyps definitely require resection either by EMR or ESD, but the indications for ESD are those in which we require an en bloc resection, particularly LST non-granular type, lesions showing a type 6 pit pattern, shallow T1 submucosal invasion, depressed type of tumors, large protruding type of tumors which are suspected to be carcinoma, as well as lesions with submucosal fibrosis because of prior biopsy or EMR, or patients with inflammatory bowel disease or recurrent lesions as well. Therefore, to conclude, endoscopic resections for early GM mucosal cancers is well established and is the preferred choice. Endoscopic resection can be performed either by an EMR or an ESD. En bloc and complete resection with attention to all oncological principles is always preferred and desirable during the endoscopic resection. Indications for EMR versus ESD have been reasonably standardized by existing guidelines, still exist in certain areas. In general, EMR is easier to perform than ESD, and several techniques to perform EMR and ESD have been described, which are applicable for various tumors or polyp types at various locations. And what is most important is endoscopists in charge of treating patients with early GI mucosal cancers. We must familiarize ourselves with these various techniques, indications and nuances to provide the best and the optimal care to our patients. Thank you so much. Thank you for a patient listening.
Thank you, Amol, for this wonderful talk. And Nilay, are you there? You unmute yourself. I am extremely sorry that I forgot to introduce Dr. Hardik Kotecha. He's a gastroenterologist, consultant gastroenterologist at the Department of Gastroenterology and Hepatology at Zydus Hospital, Ahmedabad. Dr. Kotecha, welcome. And I think, we can start discussing. How many minutes do we have? 10 minutes, organizers?
Yeah.
15 minutes.
15 minutes.
Wonderful.
Okay.
So there are so many questions coming up. And so the pattern is like that. The panelists can ask questions, or we'll put across questions to the panelists, and Amol will finally comment on that. Amol, in the current situation,
right,
or the clinical practice, where will you actually recommend this patient should go only for EMR and the next patient always do ESD? Can you just categorize and tell us? Because we know that EMR is an easy technique and ESD is actually needs a little more learning process.
Okay. So, Matthew, in general, when we are talking about the stomach, I think nearly all lesions require ESD only. Indications for EMR would be very rare unless there is a really very small lesion. When we come to the colon, colorectum, that is where EMR plays a major role. And I think lesions less than 2 centimeters, definitely EMR, no need for ESD at all. And when we are talking about rectal lesions, granular versus non-granular, granular lesions can be tackled using a piecemeal EMR technique, but non-granular lesions should be tackled preferably using an ESD approach because we need an en bloc resection. Having said that, even for granular lesions, if there is a large bulky component, that is where there can be invasive cancer, and that is something that we need to look for. So in those situations, we will need to do an ESD. Proximal colon, I think ESD should not be ventured into unless the person has adequate experience, because that is it is a dangerous procedure in the proximal colon because the wall is very thin. But the indications remain the same, because there is one thing is definite, that if we do an EMR and if there is invasive cancer or if there is malignancy found in the by histology, final histology, that patient is going to go for surgery. So if we are looking at doing an endoscopic resection with a curative intent, I think we need to follow these principles.
Thank you.
Matthew.
Okay, Nilay, your opinion.
Yeah. So basically, there is a good paper where they, in colorectal cancer, they saw that to do EMR in all, to do ESD in all, or to do preferential ESD. And they found out that preferential ESD is the best thing, meaning that if you think that there is a submucosal invasion, then you need ESD. But if you don't think there is submucosal invasion, and we know there are various ways to say that, another thing is rectosigmoid lesion, they should be going for ESD more than the proximal colonic lesions. Because if the rectal lesion has the maximum chances of submucosal invasion if they are polypoidal, if they are non-granular. For Barrett's, most of the times, if it is Barrett's with dysplasia or intramucosal neoplasia, and they are small, EMR is good enough. You don't have to do ESD. Otherwise, Amol has said it all.
Any quick comments from Gaurav, Nitin, Hardik on the selection of patients for EMR versus ESD? Hardik. Are you there, Hardik?
Can't see him on the.
Okay, so Matthew, I have a question to Amol. Amol, we always say that you have a doubt of submucosal invasion, do ESD, but how to say that there is submucosal invasion? Sometimes, many a times it's very easy, but sometimes it's so difficult, especially in esophagus. So how would you say that?
Actually, that was another question which I left. What is the role of pre-procedure high magnification endoscopy and or a role of biopsy or EUS? And I think, before Amol answers that, let us ask Dr. Gaurav Chawla. Before doing ESD or EMR, what other investigations will you do? And how far you rely on high magnification endoscopy like NBI, or do you use chromoendoscopy, etc., etc.? So, Gaurav, are you there?
Gaurav, you're muted.
Sorry, sir. No, yeah. So basically, sir, in our setup, we will usually use high magnification endoscopy, NBI, and then we will do a EUS to assess the layer of involvement, where to up to what layer is involved, and then we will proceed accordingly, sir. We will depend upon this high magnification, this NBI as well as EUS findings, and then proceed.
I have a problem with EUS, especially if it is esophageal. It is extremely difficult to say, sometimes to say whether there is submucosal invasion with the scope we use. If you have a probe, it's a different thing, but with the scope we use, sometimes it's extremely difficult.
Nilay, if I might add to that, I think it all depends on which organ we are talking about. So we are talking about EMR and ESD from top to bottom. So it becomes very difficult. So obviously, in today's current scenario, I think the more focus is on image enhanced endoscopy and less on EUS. So I think the role of EUS is gradually diminishing and image enhanced endoscopy is picking up more and more. When I talk about image enhanced endoscopy, it is mainly high magnification as well as NBI or BLI or whatever. And if and whenever required, possibly additional chromoendoscopy using either indigo carmine or crystal violet or something of that sort, for particularly for lower GI lesions, and Lugol's for upper GI. But that is more for mapping rather than for Lugol's is more for mapping the lesion rather than for deep invasion. Deep invasion, there are, see, very often we need to remember that we will never be 100% sure, but if there is a doubt about deep submucosal invasion and at the same time the lesion is lifting well, then possibly you can go in for an endoscopic resection after explaining to the patient that this is an exploratory ESD or an endoscopic resection, and the final histology will decide the further course of management. Particularly squamous cell cancer, esophagus and rectum, there are now plenty of reports which show that adjuvant chemoradiation in presence of submucosal invasion, superficial submucosal invasion, when there are low lymph nodes, has shown equal results after endoscopic resection.
Yeah, I would just a minute, Matthew,
Yeah.
I'm sorry. I would add to what Amol said. that once you've taken out the specimen goes to the pathologist. You have to ask pathologist what is the invasion length or depth. For esophagus, the depth should not be more than 200 microns if it is a squamous cell carcinoma. If it is adenocarcinoma, it should not be more than 500 microns. And for colon, should not be more than 1,000 microns. If that is the case, if it is more than that, then it is called significant invasion. Because with this, the lymph node metastasis goes up. In case of squamous cell carcinoma, it can go up to 60% if it is SN3 invasion. So additional therapies, either radiation, chemotherapy, or surgery is required in this situation.
Just a question, Dr. Papai. If you have a sessile polyp in the rectum, just on the basis of an image endoscopy and whether it is lifting well with a submucosal injection, would you really go ahead doing a dissection, or you really want to do an EUS before doing that? Because EUS, according to us, we don't find it very good in predicting submucosal invasion. So what we follow is we do an injection. If it lifts up, we go ahead with the dissection. That's what we usually follow in left-sided colony.
I fully agree with
Amol, before you answer the question, I will add on to what Nitin has asked. See, what you are telling earlier is actually a staging ESD. When in doubt, you do an ESD and say staging procedure, and then if there is involvement. But what I suggest is that in those patients where you suspect that, especially in esophagus, you know that the risk of lymph node involvement is much higher. So in those patients where there is endoscopic evaluation, if there is submucosal invasion, in those patients, probably EOS will help you to find out whether there is a lymph node metastasis or not.
Agree.
It may not show you. It may not show you submucosal invasion, but may not show you. And mini probe is also almost available everywhere. But I agree that Nilay, that and Nitin also, the invasion, submucosal invasion may not be very well identified on EUS, but it can actually show lymph node. When you see a lymph node, I would rather say that you go for a PET scan and then finally go for resection, at least in the esophagus. Now we answer the question what Nitin has asked.
Right. Actually, I was going to tell the same thing, Matthew, that even if it does not predict the layer of invasion, I think role of EUS is mainly for lymph node, looking for lymph nodes in the perirectal or the paraesophageal areas, because presence of lymph nodes, particularly with suspicious characteristics of malignancy, then we need to get a PET scan and we need to caution the patient regarding the outcome of the ESD. Even if there is a consensus, even if the PET shows negative, then possibly there is a lot of dilemma in that kind of a situation. So
micrometastasis can occur. Micrometastasis can occur,
exactly.
even if it's negative. But I think we are more worried about esophagus. Nilay, we are more worried about esophagus. Rectum and all, actually our predictions are mostly correct. But in esophagus, sometimes we go wrong. Nilay, please.
Yeah, esophagus is a difficult situation. And last week I did it, US, I was not sure whether there was submucosal invasion or not. And then I decided to do ESD. And fortunately, there was invasion of SM1 only. So and I did EUS. I spent 30 minutes and still I was not sure. But as you said, I was looking for lymph nodes more than the invasion, because I know with my scope, I cannot see. And for rectum, any lymph node, forget about the characteristics. Any lymph node in mesorectum is pathological. So you cannot neglect a lymph node in mesorectum if you find it. But as you said rightly, most of the rectal lesions, you are almost pretty sure that, okay, there is submucosal invasion or not. Problem lies if there is a big lateral spreading tumor and too much of polypoidal nodular component, where even the NBI would not be able to tell you 100%. But if the lesion is big, but there is nodular lesion, it is safe to do ESD. And then, as Amol said, it is a diagnostic ESD. Means you do ESD and send it to pathologist and let the pathologist tell us whether he needs or she needs additional therapy.
Nilay, very good points you have raised. And I think, just another very sensitive and difficult question, and many people do not agree on that. Will you do a biopsy in your patients before you do ESD? No. Yeah. Let me ask Nitin and Gaurav. Nitin.
Yeah, we do biopsy in all cases before doing an ESD, because it is hard to explain it to the relatives that you are going to do an ESD as a diagnostic and a staging modality and ending up with a complication. So, you see a sessile polyp, I know that's a difficult thing, but combined with an NBI, we definitely target the biopsies with the NBI and try to avoid the margins. That's what we usually do.
Gaurav,
Yes, sir. We also, sir, especially in Barrett's, we target the area with NBI and take targeted biopsies to show them the dysplasia is there, and then we do.
Barrett's is a different story. But
Any,
Barrett's
sir,
is a different story.
yes,
Now,
sir.
what I'm
Any,
telling is in a conventional EMR and ESD, will you do or not?
yes, sir. Sir, we will do the biopsies. We know that some
Every
fibrosis.
mostly patient factors. Amol and Nilay.
Yeah.
Nilay first.
Yeah. So basically, you don't take biopsy in colon. Absolutely no, because it's extremely difficult. Sometimes you've taken even 2 biopsies or 3 biopsies, since you find a lot of fibrosis. For esophagus and stomach, it's not a big problem. You can take biopsy in esophagus and stomach, but absolutely in colon, it's absolutely no. Just take it out.
Right.
But generally, let me say, when you see a lesion, it has to be out. There is no doubt regarding that, especially in colon, it has to be out.
It has to be out.
But I agree to that sometimes the patient demands, say that what is the diagnosis? Is it cancer or not? But what I say to them that, many times I also take, but what I suggest to them that, even if it's cancer or no cancer, this is a tumor which is likely to develop cancer in the follow-up. You have to take it out. And moreover, if the lesion is very thin, lesion is very flat and quite superficial, biopsy can actually hamper your ESD techniques. Sometimes it makes problem. But if it is a very proliferative lesion, like what you see in colon, there is no harm in taking that. It may not affect your techniques on dissection. So let me come back to another area, duodenal, because we are seeing more and more duoden now. Earlier we are seeing only NET in duodenum. Now we are seeing even flat polyps and many other things. So I want to ask questions on 2 areas. One is that net, when you see a small NET in first part of duodenum, do you want to do an EMR, ESD, or just a band it and cut it, which is your technique? But I am asking Nitin and Gaurav, then the experts, Nilay and Amol.
No, so as soon as we get a lesion on duodenal lesion which suspected to be an NET, we do a biopsy. And these duodenal NETs, the biopsy is always positive. Now the thing depends whether it is a grade 1 NET or it is grade 2 or 3. In our center at Rajiv Gandhi, grade 2 and grade 3 NETs are handled by surgery, because they have a very high risk of malignant transformation into neuroendocarcinomas later on. Definitely you get our Dotanok and chromogranin done as well. But if it is a grade 1 NET and it's localized to duodenal wall, we usually do a band and dissect. And or in certain cases, just put a band and leave it away, do a repeat endoscopy after 2 weeks, and then that is sloughed off. So that's another thing.
Will you do any imaging for patients with the duodenal net?
So usually for
all patients, sorry, please, Dr. Gaurav.
Sir, for small lesions, usually less than 2 centimeters, less than 1 centimeter, we won't image and we will directly subject them to, I will use usually snare and resect rather than band and resect. For larger NETs, we will do imaging to see. Yes, Dr. Nitin, you can come.
Nitin,
no, we have a policy of
Nitin, if you band and leave, you are not sure that you have removed it totally. So I think, this is a tumor which you have to make sure that that can be done in very elderly people, and you are sure that he is unlikely to. Otherwise, you have to see that the tumor is out. That is very important.
We come back after 6 weeks or 8 weeks, take a biopsy
You have
from
to follow
that
up.
side.
You have to follow up that.
Yeah,
so,
that is
definitely. Opinion from Nilay regarding approach of this patient and role of imaging.
Yeah. So first of all, duodenal carcinoid has to be removed, but I don't remove duodenal carcinoid in all patients. If patient is old, if patient has comorbidities, there is no point in removing these duodenal carcinoids, especially if they are grade 1. So then I decide if I want to take it out, then imaging is absolutely mandatory. You have to do a CT scan. But if you have higher chances of metastasis, like the size is bigger, the WHO grade 2, 3, or at a site like at the ampulla, where you have a higher chance of malignancy, DOTA is absolutely mandatory. If it is a very small multiple carcinoid duodenum, you don't need DOTA scan. But if it is like larger or at particular site, you need DOTA, it's absolutely mandatory. I do both. Sometimes if they are small, I just put a band and cut it and nothing happens. If they are bigger, then ESD is the preferred choice. Problem with ESD is it's very fibrotic. You have to be very cautious. Putting a band and leaving neuroendocrine is not going to work. I don't think it will work. Amol can add on to it.
Right. So I agree with you, Nilay, that duodenal carcinoids, most of them do require resection and they need to be removed. They cannot be just be observed, except for the few conditions when you mentioned elderly patients and comorbidities. That's fine, including the fact that DOTA is required in majority of the patients whenever we do suspect. And particularly when we are going to resect the lesion, it's very important to know that there is no lesion outside the bowel before we resect this one. I do prefer an ESD to an EMR technique. The reason being that with an EMR, you can never be sure that you can get these lesions completely out. Using a snare, even with a band or even with a cap EMR, the chance, see, we have to remember that neuroendocrine tumors are densely adherent to the muscle layer. Even while we're doing the ESD, we really have to separate them out from the muscle layer. Sometimes they are infiltrating deeper inside, and for that reason I think an ESD is required. Sometimes we even end up doing a full thickness resection if we find that the lesion is going deeper inside, and we then close it. But primary closure is always necessary in the duodenum, particularly in the duodenal bulb. This is what I am trying to talk about. The duodenal bulb lesions in the descending duodenum are a little bit different.
Amal,
Yeah.
I
we
think
have to wind up.
Yeah, we have to wind
yeah.
it up. We
Yeah,
got the message from the. So just to add the last sentence, if it is in D2, try to use a cold snare and not the hot snare if it is a polyp. But an excellent session, Dr. Matthew. Great moderation, Dr. Amol, as usual. Very informative talk, and thank you all the panelists for being
Thank you
there
so
and
much.
giving your opinion,
you.
which
Thank
was
you, sir.
very valuable. Thank you, everybody.
Can I
Thank
ask
you,
one
Dr.
question to
Anil
panelists? Can I
Arora.
ask one question to panelists?
No, I think we have exceeded time.
We
We'll
will
have to
ask
wind up.
during your talk, after
Yeah,
your talk.
Rajesh.
Okay, then thank you so much. It's wonderful. Thanks, Anil and Gangaram team for this wonderful conference. And Amol, beautiful speech as usual. Nilay, good moderation. Nitin and Gaurav, thanks a lot. Unfortunately, we missed out Hardik Kotecha and other two panelists. Thanks a lot.
Thank you so much. Thank you.
Thank you, Dr. Matthew. Thank you, Dr. Nilay. And now we move on to the next session, that is newer endoscopic weight reduction therapies. For this, I would like to invite our moderators, Dr. Mahesh Goenka and Dr. Mohit Bhandari. Dr. Mahesh Goenka is the director and head at the Institute of Gastrosciences and Liver Transplant, Apollo Multi-Specialty Hospital, Kolkata. Dr. Mohit Bhandari is the founder, director, and chief surgeon at the Mohak Bariatrics and Robotics Center at Indore. So over to you, both the moderators. Please invite the speaker and introduce the panelist.
Good evening, Ashish, and good evening to everybody. Thanks for asking me to be here, along with Dr. Bhandari. And Dr. Bhandari is a pioneer in the subject which we are going to discuss now. Though he is stationed in Indore, but I suppose he is everywhere in the country. I think my job would be to introduce the speaker, and Rajesh Puri does not require any introduction. In fact, he's presently the secretary of Endoscopic Society of India, as well as the director of gastroenterology at Medanta Hospital in Gurugram. And we have panelists who will be joining us subsequently for the discussion. I could see only 3 of them at this moment. They are Sameer Mahindra, who is the professor of gastroenterology at prestigious Sanjay Gandhi Institute at Lucknow, Gaurav Pandey, who is the additional professor at the same institute, and Professor D.K. Bhargava, who was professor in All India Institute of Medical Sciences and now a senior consultant in Apollo Indraprastha, Delhi. We have 2 more panelists. As and when they join, we'll introduce. With that, with the permission from Dr. Mohit, can we start with the talk? Dr. Mohit, you have to make any initial comment. You have to unmute yourself.
I think we should start with the talk. Thank you so much.
Thank you, Rajesh. It's all yours.
Thank you, Dr. Mahesh Goenka, sir. And I would like to thank Dr. Anil Arora.
Everybody who is not talking need to mute themselves.
Thank you, Dr. Anil and Dr. Ashish, for giving this opportunity, and good evening, dear chairperson and audience. I would like to talk about the neuroendoscopic weight reduction techniques. Before starting the talk, I've already discussed with Dr. Anil, and he don't want to discuss the technical aspects or techniques, how these modalities are working. What he wants, where the endoscopic techniques are fit, what are the guidelines, but unfortunately the topic assigned to me, there is no guidelines, there is no consensus. Which group of the patient is suitable for which endoscopic technique for the weight reduction? And I myself feel that I am not a master of pediatric specialist who can give my view that which patient require which endoscopic technique. So what I'm going to discuss with the data, I will give some little bit of the idea that which group of the patient can be given which kind of endoscopic therapy. And we have an esteemed panel, Dr. Mahesh Goenka sir and Mohit. And Mohit has a vast experience, and I would like to listen his comments. So obesity is a growing public health epidemic and now is getting pan-endemic. It is associated with the increased risk of all causes and cardiovascular mortality. It increases the healthcare cost and it accounts for 2.5 million preventable deaths annually. I think everybody is aware about this photographs. Lifestyle modification and the medications which are least effective and are least risk-related procedures. So they have a less complications or less side effects, but the efficacy is very low. And the meta-analysis shows that they are ineffective way of controlling the weight. They may produce the weight loss in the beginning, but it is very difficult to maintain the sustainable weight loss. On the right side, we have a surgical technique that are very efficacious, very good results, but risk associated with the surgery are high. 17% of the individual faces various surgical related complications. So there's a huge gap between the low risk and low efficacious procedure to the high risk complication with the very efficacious procedure. And I think endoscopic procedure may be able to fill that gap, and what we require a more robust data and head-to-head comparison between various endoscopic techniques to say which group of the patient these endoscopic techniques are suitable. If you look at this paper, which was published in Journal of Obesity 2016, and the reason of not undergoing surgery out of 284, 50 patients, 50% of the patient has a fear that they'll end up into the complication from the surgery. 32% says they don't need surgery to lose the weight. And there are various causes in terms of cost and the expertise. So only 2% of the individual obese patients, they opt for the various surgical procedure, and out of them, 17 to 20% has surgery related complications. So when we talk about the endoscopic therapy, which may fill the gap between the less effective, that is pharmacological and the lifestyle modification versus the surgery, is they are low risk, safe and effective. I think we have a reasonably very good data about their safety and effectivity. The advantage is they are potentially reversible. You can redo the endoscopic procedure right from balloon to the sleeve, endoscopic sleeve gastroplasty. No anatomical alteration, can safely be done in surgically high risk group, effective in controlling the metabolic control like diabetes, NASH, and the dyslipidemia. These are the various mechanisms where the bariatric endotherapy are going to act. That is, they act through the hormones, GLP-1, peptide YY, they accelerate the transit time, they increase the secondary bile acids, restoration of the gut microbiomes, and improve the metabolic profile and increase the insulin sensitivity. So what are the type of endobariatric procedures? If we divide, they are mainly the gastric restrictive devices and the malabsorptive devices. And if you look at the name, the malabsorptive devices, they are mainly meant for controlling the metabolic controls. And gastric restrictive devices, they have both. They control the weight along with the metabolic control. In gastric restriction, we have a space occupying devices, various balloon, which I'm going to talk. along with the transpyloric shuttle or Satisphere and Gelesis 100. What is available in our country is the intragastric balloon. And the gastric restrictive devices is Apollo Overstitch, Post, Endomina. But what I know is about the ESG, endoscopic stapling gastroplasty. And there are other mechanisms, that is Aspire Assist, botulism injection, but I think Aspire Assist may look lucrative and has paper. Paper also shows that it is effective, but not much of the data available. When we talk about the space occupying devices, various balloons are available. And these balloons, the indication of intragastric balloon, according to FDA, patient who has a BMI of 30 to 40, not willing for surgery. And ASG considered that those patients who has a BMI of more than 40 and they are candidate for the surgery, but because of the some comorbidity, they are not able to go directly for surgery. So balloon can act as a bridge. And like patient who have a liver transplant or patient who are super obese, have an obstructive sleep apnea, or patient has other comorbidity, you can place the balloon, you can reduce the BMI, and meanwhile patient can be fit surgically and patient can go for a surgery. So the balloon can be act as a bridge as well as a primary therapy. So the two important balloon, Obera and the Reshape balloon, which are FDA approved, these are the only two FDA approved. They are fluid-filled silicone sphere. They placed as well as removed endoscopically, and they may remain in the stomach for 6 months. I'm not going to discuss the detail. And the Reshape balloon has already withdrawn from the market because of the complication in the form of perforation. So what is available is a Obera balloon. We have an Obalon, which is still not FDA approved, but they are the gas-filled balloon, thin polymer ellipses. They are sequentially swallowed over a week of 2 to 3 weeks, and they remove endoscopically after 6 months. There is another balloon that is Aluron balloon, which can be swallowed. They filled with the water and they disintegrate after 4 months. So these are the various balloon which is available. When we talk about the comparison of the various intragastric balloon, so these are the studies where they have compared the Obera, Reshape and the Obalon balloon, and this is the meta-analysis from Bezerbachi et al. Published in 2018. And what they have shown that fluid-filled balloons are more lead to the weight loss in comparison to gas-filled balloon, but they have a more side effect in terms of vomiting, pain, and the nausea, and more likelihood of remove. This is the meta-analysis from Murray et al. Published in 2019. And what they have shown that gas-filled balloon may be equally effective, especially in the patient who has a BMI of more than 40. So balloons, more or less, they are same, but require an FDA approval. This is the another study, intragastric balloon US pivotal trial, and what they have shown that the Reshape, Obera, and the Obalon, the maximum weight loss was with the Obera balloon, that is 10.2% of the total body weight loss at 6 months. The Chbd balloon, the company says it got the FDA approval, but in literature it is not available. And this is a pivotal trial about the adjustable Chbd balloon. The advantage of Chbd balloon 3 is you can decrease and increase the volume of the balloon according to the need of patient, along with the tolerance of the patient. And this is the study which says that the Chbd balloon has more advantage in terms of success rate, in terms of total body weight loss, in terms of axis body weight loss, and the total weight loss is around 14.9% in comparison to rest of the balloon, which has 6.6 to 10.2. Theoretically, I think because they are readjustable, they have a tolerance because you can increase the volume to 300 to 500 to 800 ml, and they are kept for 1 year. The rest of the balloon are kept for 6 months. Chbd balloon are kept for 1 year. This is the impact of intragastric balloon on obesity-related comorbidity. This is a meta-analysis, and conclusion of this meta-analysis is intragastric balloons are effective than diet in improving the obesity-related metabolic risk factor with the low adverse event. But the strength of evidence is limited given the small number of the patients. So this is a 10 randomized control trial, 30 observational studies, more than 5,500 patients. That shows it also has an effect on BMI, not only on the weight, but also on the glycemic control also. Now, the problem with the balloon are they are temporary because you have to remove after 6 months. And if you look at the obesity, which is a multifactorial chronic disease, it is not a short-term disease. So the balloon which are temporary, there is a chances of regain of the weight after some time, as it happened with the pharmacological treatment. So this is the long follow-up where the multiple balloon was used. And once they have seen after putting the first Obera balloon, the BMI has reduced. And after putting the second balloon, the BMI further reduced. So 6-month follow-up, the sequential balloon replacement helpful in maintaining the weight loss as well as causes further decrease in the weight loss. This is the another study where those shows that balloons are not only effective in management of obesity, but also important for management of non-alcoholic steatohepatitis. And these are the sequential balloon, first, second, and third balloon, and you see there is a fall in the total body weight. So I think sequential balloon can be placed, especially in those subgroup of the patient who was not willing for a surgery, or patients who has BMI of 27 to 35 with the comorbidities. I think these group of the patients are beneficial by using the intragastric balloon. Transpyloric shuttle, I think it is withdrawn from the market, but they are large spherical bulb, which has a larger bulb which remains at the pyloric antrum, and the small silicon bulb remain in the duodenum. They act as a valvular mechanism, and they produce intermittent gastric outlet obstruction that delayed the gastric emptying and help in reducing the weight. So the two studies, endo-obesity trial, 302 patients, 12-month multi-center randomized trial, and what they have shown that the mean weight loss was 9.5% in comparison to sham, which has 2.8, and 67% of the patient in the transpyloric shuttle group, they have achieved more than 5% of the total weight loss, along with the improvement in the metabolic parameter. I am very much fascinated about the aspiration therapy. I think it is feasible, it is doable, and it can be done. It is cheap, and it can be done in our country also very safely. What is Aspire Assist is a little bit modification of the percutaneous endoscopic gastrostomy. In the way we are doing the PEG, the Aspire Assist is the same device, and they remove after eating the food. Patient is allowed to eat the food of his choice, and roughly after 30 minutes, roughly after 20 to 30 minutes, 30% of the total calorie intake will be withdrawn and is thrown in the dustbin. So the patient is allowed to eat, but 30 to 40% of the food is withdrawn from the stomach. That helps in reducing the weight. And this is the pathway study about the Aspire Assist. And what they have seen is the primary endpoint was the total excess body weight should more than 10%, and at least 50% of the patient achieve more than 25% of the excess body weight at 52 weeks. And in pathway studies, Aspire Assist was able to complete as well as intensive treat analysis in both the group. Aspire Assist was better than control group. And when we talk about the satisfaction, more than 2/3 of the patient are satisfied, overall satisfied with the Aspire Assist methods, and they are willing to recommend to other patients. So 2/3 of the patients, they have a very good result. 23% of the patients, they are neither satisfied or not dissatisfied. Only 5 to 7% of the patient was dissatisfied, or they are not able to recommend to other people. So I think this is my personal opinion. Aspire Assist is a good modality, especially in the obese patients who has comorbidity. Doing the PAG, they are allowed to eat, and you can remove the food after 30 minutes of intake. And if you look at the metabolic parameters, improvement with the Aspire Assist, they have a very good metabolic control, not only in terms of excess body weight, but they control the quality of life, improvement in the HDL, triglyceride, glycosylated, hemoglobin, along with the ALT improvement. So aspiration therapy for the treatment of obesity, this is a 4-year results, although the follow-up of the number decreased from 82 to 12, but that shows a significant improvement, not only in the excess body weight, but also in the metabolic control. Endoscopic sleeve gastroplasty, I don't have any experience about this. I think Mohis has the largest experience in our country and maybe in the world, and total around 10,000 cases of the endoscopic sleeve gastroplasty was done worldwide. It is a full thickness suture placed to invaginate the greater curvature of the stomach, and it starts from the incisura to the, you leave the small fundic pouch. You start from the incisura angularis of the greater curvature and you reach up to the fundus, you leave a small portion of the fundus and you decrease the gastric volume by 70%. So endoscopic sleeve gastroplasty, I think, is gaining, and it is alternative to the surgical sleeve gastroplasty. Again, I'm not going into the detail, and if anybody requires, I will be more theoretical. I think Mohit will be able to tell you the practical aspects of this. But if you look at the ESG studies, this is a multi-center retrospective study, 248 patients. And what they have shown that the total body weight at 6 months and 24 months. So this was a multi-center study. At 6 months, total body weight loss was 15.17%. And at 18 to 24 months, 18% of the total body weight loss was there in multi-center trial. So endoscopic sleeve gastroplasty, I think, is very effective. If you look at the meta-analysis of endoscopic sleeve gastroplasty, mean total body weight loss was 17% at 24 months. So 2 years, the total body weight loss was 17%. Excess body weight loss was 67% at 2 years. So excess body weight roughly around 70% loss with the total body weight loss of 17%. This is the randomized control trial on ESG, that is a merit study. I don't have detail, I have read the literature, but I think this is going to be published, or the data is going to be published in the next year, DDW, and Mohit is a part of this group. Mohit will be able to highlight, but merit study investigator announces that there's a successful achievement of the study, primary efficacy and the safety endpoint, meaning that what they have planned for the primary aim and the safety endpoint, this is a randomized control trial, and I think this will be a landmark study to leave the endoscopic sleeve gastroplasty as a landmark endoscopic bariatric procedure. When you compare the ESG with the lap sleeve, the lap sleeve has a better total body weight loss in compared to endoscopic sleeve loss, but the new onset of GERD is significantly less in ESG in comparison to the laparoscopic sleeve gastrectomy. Regarding the Brazilian consensus about the endoscopic sleeve gastroplasty, which was recently published, and they talk about the technique, and they also give the consensus that indication of doing the endoscopic sleeve gastroplasty is no maximum age. What they require is adequate clinical status. Ideal BMI, they impose 30 to 35. Minimum BMI to perform is 27. No upper limit of the BMI when performing the ESG, but you should always look out the contraindication in terms of active gastric ulcer, congestive gastropathy, gastric polyposis, gastric and esophageal varices, or uncontrolled psychiatric disorder. When we talk about the safety profile, this is a recently published paper in GI Endoscopy 2020, and they shows the serious adverse event like GI bleeding and perigastric fluid collection was seen only in 2.26%. So significantly safe endoscopic sleeve gastroplasty, 1,000 consecutive patients, and only 2% of the individual has GI bleed or perigastric fluid collection. The advantage of endoscopic sleeve gastroplasty, you can do the redo endoscopic sleeve gastroplasty where there is a suture dehiscence is there. Pose. This is another endoscopic method where what I understood is here in the ESG, you leave the fundus. Here you apply around 4 to 7 full thickness plication in the fundus, bring the fundus to the G junction level, and you apply 3 to 4 full thickness suture in the body, and it increases the gastric emptying because it makes the tubulize the stomach. When we look at the clinical practice guidelines of the European Association of Endoscopic Surgery, what they have shown that the duodenal bypass, aspiration device, gastric electric stimulation, vasal blockade, and the duodenal mucosa resurfacing, the quality of evidence for these modalities are not there for providing any recommendations. But for endoluminal suturing, may have a role in the treatment of obese patient who has below the BMI of 40. So I think the Brazilian and the European Association of Endoscopic Surgery both has same that the ESG is good for patient who has a BMI of less than 40. A few word about the dialysis. I think this will be a very good effective those patients who are not fit for surgery or those patients who are not fit for endoscopic balloon placement, as well as those who are not fit for the ESG. These are the capsule which you take around half an hour before the meal with the 500 ml of the water. They swollen up and they occupy 25% of volume of stomach. And there is a placebo control trial, and that shows they are effective along with the hypocaloric diet, and the dialysis are able to reduce the weight by 29% of the excess body weight. So those patients who are not fit for anything, those who are contraindicated, not willing, I think this may be the better modality to do it. When we talk about the malabsorptive devices, the endo sleeve, duodenal mucosal resurfacing, Valenex sleeve, incisionless and anastomotic system. Just to tell you what is the difference between the endobarrier sleeve and the Valenex sleeve is, in the endobarrier, either it is in the stomach or in the duodenum, while in the Valenex start from the esophagus. So endobarrier is a duodenojejunal bypass sleeve, which is around 65 centimeter. It initially was anchoring in the duodenum, but the company has withdrawn because of the side effect associated with the liver abscesses and the risk of migration. Now the recent trial of the endobarrier where the proximal end is capped at the antrum by putting a covered metal stent, and the trial is going, and the side effect which is associated with the duodenojejunal sleeve bypass is less. And main mechanism is they act through the malabsorptive process, and 4 randomized control trial shows that they causes a significant loss in the excess weight loss as well as actual weight loss in
Rajesh, sorry, but you have only 2 more minutes.
Yeah, I think my slides are only for 2 minutes. The gastrojejunal bypass, I talked about this. This is similar to the duodenojejunal bypass, but here the anchoring is at the esophagus. You bypass the stomach, duodenum, and the jejunum. Concept is same. Duodenal mucosal resurfacing, where you thermal ablate the duodenal mucosa, and the regenerating duodenal mucosa improve the metabolic control. And what they have shown that the duodenal mucosal resurfacing is very effective in controlling the metabolic control. And the same with the magnet with the endoscopy. So my opinion, the endoscopic bariatric therapy is a very good technique for the bridge therapy, those patients who are super obese, or patient who refuse for a surgery, or patient who has a BMI of 30 to 40. Now, when we divide patient who has a BMI of 30 to 40 or 27 to 35 with metabolic disease, so meaning that obesity with metabolic disease, I think the duodenal devices along with the ESG is better. When you only want to control the weight, the metabolic issue is not the cause, then the space occupying devices are good. But when the BMI is normal and only metabolic issue is there, then the duodenal mucosal surfacing of the endobarrier is better. So I think these 3 points I have discussed with Mohit, and I think this was written in the book also. So patient obese with metabolic disorder, endobarrier along with the ESG or ESG separate. Patient who is only obese, no metabolic issues, I think space occupying devices are good. But if the patient is not obese but diabetic, then the duodenal mucosal resurfacing or endobarrier are better. But I think certain questions are unanswered. There is no head-to-head comparison between various endoscopic procedure. Will ESG go to the laparoscopic sleeve way? I think the next year DDW is going to give the data. Merit trial may give few questions. Currently, there is no recommendation available because the data is still evolving. So ladies and gentlemen, to conclude, I think endoscopic bariatric therapy fill the gap between the medication and surgery. These are reversible, repeatable, cost-effective, and can be used in combination. Both restrictive and the barrier devices should be performed in context of comprehensive multidisciplinary center. Patient has to go for thorough checkup by endoscopist, gastroenterologist, surgeon, endocrinologist, and psychiatrist. And after doing the comprehensive review and knowing that this patient has, what is the problem? Is it an obesity or obesity with the metabolic control, or has a metabolic control? You can choose those therapy. Thank you for patience hearing.
Thank you, Rajesh. And as you rightly mentioned, Mohit, several times in this presentation, I think this platform requires Mohit to make initial comments, and then we will open it to the panelists. Mohit?
Yes, I think very nice lecture, very exhaustive. I think he was given a very challenging task, very tough task, because to cover something like that in such a short period of time, it's really tough. Very nice lecture. What I would like to say is that we should now try to see, in a country like India, where we have so much of type 2 diabetes, we should now try to differentiate between obesity and diabetes. So we will definitely have a lot of patients who have just type 2 diabetes without obesity. And all these space occupying products which we have, they may be intragastric balloon, or we have restrictive procedures like the post-2 or endoscopic sleeve. I would say that they have good results for type 2 diabetes because of weight loss, but they do not have weight independent effects on type 2 diabetes. For weight independent effects on type 2 diabetes, we need something like a duodenal mucosal resurfacing or a DJ liner or an endobarrier sleeve. And these products are going to improve as the time will come in future. But for now, I could say that the space occupying balloons or any space occupying device and endoscopic sleeves and post-2 are more for weight loss. If we talk specifically about endoscopic sleeve, Reen published some data upon, talking about GLP-1s and ghrelin and all those things. But still, we need to come out with some more data whether these really have metabolic effects for weight-independent mechanisms. I'm not talking about weight loss. If you have weight loss, you have diabetes resolution, you have sleep apnea resolution, you have all those good things coming to your way. But if there are weight-independent mechanisms, like we talk about bile acids in bariatric surgery, we talk about bile salts, we talk about microbiome, and several other things in bariatric surgery, I think we need more research. That's what I would say.
So I think with that comment from Mohit, we'll open this discussion. And can I start with Samir? Samir, I think that there are three basic questions which we need to do. Yeah. One is to draw an algorithm as to when do we intervene, at what BMI, with or without comorbidities, or with dyslipidemia or metabolic disorders, and with what intervention. I think this is an open question, and we may not have answers to all the questions today. But let's try to address as much of time in the time which Dr. Anil Arora will permit us. You can stop us any moment, Dr. Arora, but we will just take about 8 to 10 minutes. Let me start with Samir. What is your choice of balloons, Samir? Rajesh talked about 4 or 5 balloons. We have almost completely shifted to Spatz balloon, though I understand that FDA approval is not there. But what's your favorite balloon?
Spatz and Orbera. And regarding your question of intervention, Rajesh very correctly said that there is a difference in guidelines. For example, European guidelines say anything BMI more than 27.5 is the time for intervention. And while the American guidelines say more than 30. Now, regarding the balloon, it depends upon the availability and what you have used. But Orbera and Spatz balloon are the 2 best ones. And as Rajesh rightly said, the flexibility with Spatz 3 balloon, because it depends upon how the patient tolerates the balloon. The biggest problem with balloons are tolerability of the balloon and durability. With Spatz balloon, we can tackle the tolerability of the balloon. So that's a very big advantage with the Spatz 3 balloon.
I will move on to Dr. Gaurav Pandey. Gaurav, what's your take? I think we have to first find out what is available with us. At this moment, to my knowledge, it's only intragastric balloon and endoscopic stitching procedure which is available. I don't think we have sleeves and resurfacing, which look very interesting but are yet available. So what's your way forward, Gaurav?
As has been discussed and very aptly said, balloons have been there for a long time and have shown the results are very well known. Spatz obviously is the preferred balloon for us also at SGPGI, as Professor Samir has pointed out. But the issue is ESG is a very interesting and upcoming field, and it should be available with gastroenterologists probably in the next few coming years. and looks like a very interesting prospect, especially with the repeatability of it. The other very interesting thing that I wanted to bring upon is that a combination of these endoscopic surgeries with medicines, especially the SGLT2 and GLP1, a combination may give us a higher and probably a quicker weight loss and a better control of diabetes in long term. So this is my take, that coming era would also, we'll also be seeing better use of medicines, more judicious use of medicine with these restrictive procedures, because SGLT2 and GLP1 do not possess a severe risk of hypoglycemia per se, and they have, especially SGLT2 has shown significant weight loss. The only issue is studies have to show the combination results of endoscopy and medicines, and probably this is the way forwards.
We have Professor Bhargava here, who is a very wise man and very experienced. Dr. Bhargava, what's your take on this? Do you refer your cases to the surgeon? Do you ask them to go for intragastric balloons, or you are moving towards endoscopic sleep procedures? Dr. Bhargava? Sir, you have to unmute yourself, sir. You have to unmute yourself.
Yes,
Yes.
now.
Yes, we can hear you.
Now, see, I think I am impressed with intragastric balloon, which are mostly of silicone type. However, there is one contraindication, that most of the patients are having hiatus hernia or reflux also. So in those cases, I think the balloon treatment may not be good. Then other technique which is impressing is the aspiration technique, which is very simple also, but one can go on for at least 6 months. Now, there are certain persons who have diabetes, hiatus hernia, heart disease, arthritis with overweight. So these persons will need ultimately endoscopic sleeve gastroplasty, because that procedure will be there, and most of us are not conversant with this technique, but we have to learn gastric sleeve gastropathy. Now, another thing is that the Rajesh Puri has not touched is Botox injection. So this is one of the method also for obesity. And another thing which I wanted to know is that, can you do these procedures if bariatric surgery fails and their results are very poor? Then can we do all these procedures, the bariatric surgery also?
I think we come back to Mohit. Mohit, where do you place laparoscopic surgeries compared to endoscopic surgery now, both in terms of efficacy, complications, and the cost effectiveness?
Yeah, I think very interesting points, and I appreciate the wisdom of and experience of Professor Dinesh Bhargava, because he's raised some very valid points. First of all, I think there should be no comparison between bariatric surgery and bariatric endoscopy, because they are meant for two very different set of individuals. We don't do bariatric surgeries on BMI between 27 to 35. In fact, 27 to 38, you can say most patients do not agree for bariatric surgery. And these are the most patients in India and across the world who are available to gastroenterologists and surgeons like me who are practicing bariatric gastroenterology now to do. So these are the cases where we should do bariatric endoscopy. And as Professor Bhargava correctly said, we have to learn endoscopic sleeve gastroplasty because of the very short-term nature of the intragastric balloons. The intragastric balloons have got 6 months or at most 1 year. And at most times you would say after 3 months, patient would say that he does not feel restriction. Whereas endoscopic sleeve, I am one of the members of the bariatric endoscopy committee at the IPSO. The merit trial is accepted as the best paper in the 10 best abstracts at the International Federation for Surgical Obesity meeting in Miami. And the results I know because I'm a member are very promising at 5 years. So, as bariatric surgeons, I've been trained by Professor Phoebe and we work together a lot at Indore. And he said, don't look at 2 years, 3 years, 4 years, or 5 years, look at 10 years. So let's not look at 5 years, let's look at 10 years. 10 years down the lane, if you are able to maintain your weight, I think at this point of time, endoscopic sleeve gastroplasty is the strongest available tool between a BMI of 27 to 35 for the gastroenterologist and above a BMI of 35 for the surgeons, the bariatric surgery. Let's look at strongest tools available. You can occasionally put a balloon or you can do several other procedures which are not approved in India by CDESCO, like the DMR, as Professor Goenka correctly said, the DMR or several others which are not approved in India. But I think for now, what is ready for the prime time, let's all learn endoscopic sleeve gastroplasty. That's a very, very good procedure. The post 2 is going to be launched soon. We are starting with post 2 cases, and the product is already approved. So post 2 is more durable than the endoscopic sleeve. But till the post 2 comes, let's learn the endoscopic sleeve. And then, above a BMI of 35, bariatric surgery will solve all our problems in times to come. At this time, we should be satisfied with these two.
Mohit, I have a question. You talked about 37 as a cutoff value for surgery versus endoscopy. So can you convert a surgery into endoscopic procedure by putting an intragastric balloon? So you have somebody with a BMI of 40, you reduce it to 35 maybe by putting a BF balloon and then do the endoscopic procedure.
Yeah. So the beauty here is, fantastic question. So the beauty here is any bariatric endoscopic procedure is easily convertible into surgery. That's the beauty of bariatric endoscopy. And that's why this forum I used to pledge to request all the gastroenterologists to learn endoscopic sleeve or intragastric balloon or whatever, because these are very easily convertible to bariatric surgery. I have converted endoscopic sleeves to sleeve gastrectomy, gastric bypass, one anastomosis, gastric bypass, everything without complications and easily. There is no problem. The reason is that everything what you cut by stapler comes on the side of the specimen. So there is no leak, no bleed, nothing. So anybody who is saying that, oh, don't do an endoscopic sleeve or a balloon because balloon causes ulcers and there are a lot of problems, they don't have data basically. They just talk by picking up a meta-analysis from the Google Scholar, but they don't have data. I have data. I have converted at least 200 procedures from different other surgeons who have done a balloon or an endoscopic sleeve or post 2 to bariatric surgery very easily with very minimal complications, number one. Number two, bariatric surgeries, when they fail, the only option we have available today is bariatric endoscopy. If I have a failed sleeve, and let me tell you this very straight away, I'm a bariatric surgeon, 50% of the sleeves will fail by 5 years and almost 80% by 10 years. And the only solution we have now, which is without complications, is to treat these patients by doing an endoscopic sleeve, reducing the size of the sleeve, which has been performed by a surgeon by endoscopy. Similarly, for a gastric bypass, you can reduce the outlet by using the argon energy source, and then reduce the outlet by using the endoscopic sleeve and reduce the pouch. The same applies to mini gastric bypass or one anastomosis. So what I'm going to say, that bariatric endoscopic procedures can be converted to surgery, and surgical procedures, when they fail, can be treated by bariatric endoscopy.
I think, Mohit, you gave a very interesting data that 50% of the surgical sleeves fail after 5 years to 10 years. So what is inferior in surgical procedure compared to endoscopic procedure?
The inferior part is the Barrett's esophagus. That's the Achilles heel. And Barham, my friend, published upon it. With sleeve gastrectomy, we are getting so much of Barrett's esophagus, so much of GERD, so much of severe form of esophagitis. And, maybe 10 years down the lane, we have so much of cancers out of sleeves that, we are ourselves afraid. So what I would say is that we need both these therapies. We need bariatric endoscopy. We need bariatric surgery. We need both these therapies. But as you said, what is the inferior part of the bariatric surgery? The inferior part is the GERD and the Barrett's esophagus. And let me tell you, I have been tired to talk to surgeons to do their endoscopies, but they don't do the endoscopies and follow up. Until you go and see for it, you will never find it. If you do endoscopies in all your patients who have done bariatric surgery, you will find severe esophagitis and Barrett's in patients of sleep. So that's what I would try to say, that, we all try, but we don't have data. I'm trying to maintain some data and try to talk about it.
Can I ask Rajesh?
Yes, Anil. Yes, Anil. One question to Rajesh. Rajesh has given his talk. What is a learning curve, Rajesh, about learning endoscopic techniques? Rajesh, did you review the learning curve, how fast one can learn?
So I think for the intragastric balloon, I don't think it's just required to.
No, I'm talking of endoscopic sleeve.
Yeah, endoscopic sleeve, I think 35 cases under supervision. What I have learned, because the data I have not read it, but I heard from Mohit.
There's one paper. Yeah, so there's one paper from Vivek Kumri Vivek is a good friend. He's from New Zealand, and Vivek says that 7 cases to understand the procedure, 20 cases to be efficient, and 38 to 40 cases to be proficient in doing the procedure. I think 40 cases should be a good. I think 40 cases should be a very good because we need to make a very tight tube which does not succumb to time. So 40 cases.
So Anil, Dr. Anil Arora, your question, please.
Yeah, I think I will have to comment on what Rajesh started with. He totally derided the role of lifestyle modification and diet. Let me remind Rajesh, the basic problem in pathogenesis of obesity is the hormonal problem related to the ghrelin, to the behavioral problem. That is the reason hop on, hop off flights like balloon or sleeve gastrectomy will have only limited effect. So if you deride it completely, that is what happens in the recurrence of the problem. We have Dr. Pasricha with us, who is the master of GI physiology. Can we have his comments, Dr. Pasricha, please?
Jay, can you unmute yourself? Yeah.
Hi.
Jay, what is new coming in? You are thinking 5 years ahead. So tell us what is new which is going to come in.
Let's all stop eating.
So we should have more webinars.
You know, we're trying to solve a problem with the crudest of tools, whether it's endoscopy or bariatrics or surgery. These are, yes, necessities, and necessity is the mother of invention. But we can do better than this, guys. We don't have to completely distort somebody's physiology. It's like Anil said, it is a multifactorial issue. And if we don't tackle all the factors, we're going to be failing. Yes, we will have a subset of patients who will take the cost of morbidity by messing with the stomach for the cosmetic and the health benefits of weight loss. And it's not an insignificant amount of people, but compared to the amount of people who are morbidly obese, it's a drop in the ocean. So if you're talking about procedures or technologies, like Rajesh said, which affects hundreds of millions of people, pandemic in his words, these are not tools that are going to solve that problem. They may work for a few patients here and there. So we should put our thinking hats on and think more broadly and more disruptively. That's all I've got to say. But I love this discussion, and congratulations to all of you, and to Rajesh and Mohit for their wonderful comments. I learn a lot every time I listen to you guys.
Thank you, Jay. And with that, I would close the session. Thanks to the speaker, Dr. Rajesh Puri, the panelists, as well as the comments by Dr. Arora and Jay Pasricha. Thank you.
Thank you. Thank you, sir.
No more. I think Rajesh.
Very important comment. Very important comment.
We should leave something for the next time we hear you.
It's very important, sir.
Okay, half a minute.
So diet is an integral part even after endoscopic or bariatric surgery. The question was diet as an alone is ineffective. You have to restrict the diet even after the surgery as well as endoscopy.
I think this is very important point that we cannot get away from that. I remember a story of a Pathan who put a balloon and he gained weight, and he says, after I put a balloon, I start eating half a kg of mutton in the morning and I'm gaining weight. So I think that has to be taken care of. You have to tell them that you cannot be liberal with your diet, whatever the procedures you do. Thank you very much. Let's move on to the next session.
Thank you, Dr. Goenka. Thank you, Dr. Bandari, for moderating this session. So now we move on to the last session of this meeting, that is future of endoscopy, and where we'll be presenting 5 best recent papers which are considered to be the game changers. And for this, I would like to invite our moderators, Dr. Pankaj J. Pasricha and Dr. S.L. Brewer. Dr. Pankaj Pasricha is Director, John Hopkins Center for Neurogastroenterology, Professor of Medicine and Neurosciences, John Hopkins School of Medicine, and Professor of Innovative Management, John Hopkins Carey School of Business, Baltimore, USA. And Dr. Brewer is a Senior Consultant, Department of Gastroenterology and Hepatology at Apollo Hospital, New Delhi. He is the former Director, Professor and Head Department of Gastroenterology at G.V. Pant Hospital, New Delhi. In this session, we'll have 5 speakers. Dr. Pankaj Desai, who's the Director and Head at the Department of Endoscopy and US at the Surat Institute of Digestive Sciences. Then we'll have Dr. Monish Chabra. He is the Director of Gastroenterology and Hepatology at Fortis Multi-Specialty Hospital, Mohali. Then we'll have talk by Dr. Deepak Gunjan, who is the Assistant Professor, Department of Gastroenterology at AIIMS. Dr. Gaurav K. Patil, who is a Consultant Gastroenterology at BITS Global Hospital, Mumbai, and Dr. Sri Hari Anikhindi, who is a Consultant in Department of Gastroenterology at Sir Ganga Ram Hospital, New Delhi. So I request the moderators, Dr. Pankaj Pasricha and Dr. Brewer, to invite the panelists and start the session.
Before they started, I think it's my pleasant duty to introduce Dr. Brewer and Dr. Pankaj Pasricha. As all of you know, Pankaj was our senior at All India Institute of Medical Sciences, and he has been the pioneer for developing so many new firsts, starting with the botulinum toxin for achalasia cardia and Botox injection in various places of the body. And if you have heard the talk of Dr. Amit Medeo, he is the father of third space endoscopy for us. I'm privileged to have him with us. Thank you, Dr. J, for joining. We had given him the responsibility of giving us a talk on future of endoscopy, but he was generous enough to hand it over to the 5 juniors consultant from our India, who are going to tell us about the game-changing articles in 5 minutes each. And we have Dr. Pasricha and Dr. Brewer who are going to moderate the session. Over to Dr. Brewer and Dr. Pasricha.
Thank you, Anil, for that generous introduction. I'll hand this over to my esteemed colleague and friend, Dr. Brewer. Please, let's get started. I think it's getting late. People have to eat their half kilo of mutton still.
Okay, I think we'd like to start with our first presentation, which is by Dr. Pankaj Desai, who's already been introduced. Can I request Dr. Pankaj Desai to give us the first paper presentation, please?
Yeah.
May I request all the presenters to finish in time so that we have enough time for discussion and good comments by the moderators?
Absolutely. I'll start straight away thanking Dr. Anil Arora. And it's always it's a great privilege to have Pankaj Pasricha and Dr. Brewer to moderate the session. What article I have chosen is piecemeal cold snap polypectomy versus conventional EMR for large sessile serrated lesions. Retrospective comparison across 2 successive periods. This is by the Michael J. Berg group in Australia. And why is this study important in clinical practice is because large SSL are pre-malignant, as we know, and they can develop into interval cancers. Typically encountered as flat lesions in the proximal colon. EMR is effective for these large SSLs, but however, they are associated with the risk of post-EMR bleeding and deep mural injury. Cold snap polypectomy may provide a safe alternative to EMR by omitting electrocautery-induced injury. However, the data is lacking on the long-term outcomes and safety. So, the aim in the study is to compare EMR and cold snap polypectomy in the management of large SSLs. So, what they did was, it is a prospective observational comparative studies at 4 centers in Australia from July 2008 to Jan 2020. Consecutive patients undergoing endoscopic resection for large SSL were taken. EMR group was from 2008 to 2016 and cold snare polypectomy was from 216 April to January 2020. Follow-up endoscopy was done at 6 months and 18 months post the index procedure, and the primary outcome they looked for was comparison of technical success between these 2 techniques. They treated all the lesions which were more than 20 mm during the index colonoscopy. The large SSLs detected during the follow-up procedures were not eligible for inclusion, and when the lesion had focal dysplasia, that is Kudo 3, 4 or 5, they resected it by EMR. So these were the things they did, used high definition scopes and confirmed the lesions that they were not deep invasive with white light, NBI and magnification, and used gelofuscin and indigo carmine with epinephrine for all the procedures. Piecemeal EMR was done with stiff wire snares, leaving a 3 mm margin of the normal mucosa, and EMR was done in the standard fashion. They observed the patient 4 hours post procedure, and this is how they did their EMRs. This is an example, seeing the lesion, injecting with gelofuscin, and then doing a piecemeal cold snare polypectomy, and this is a classical EMR. So the results, what they found, that they had a comparable age group in both. ASS scores were comparable. The lesion size in both the groups were also comparable. Majority of the lesions were 25 to 35 millimeters. They had few lesions which were more than 35 millimeter also. And the basic majority of the lesions were in the transverse colon, hepatic flexure, and the ascending colon. And 7.1% in the EMR group had previous procedures done. They found that technical success in both the groups, cold snare polypectomy and EMR, was almost 100%. En bloc resection, however, in the cold snare polypectomy group was 0 compared to 99, which was statistically significant, and the resection time was comparable. The complications or the adverse events, that is in the cold snare polypectomy group, we can see that the post-operative bleeding, intraoperative bleeding, deep muscle injury and delayed perforations, there was no adverse event seen in the cold snare, while EMR had some complications ranging to 5.6 to 5%, which was statistically significant. But the limitations of these study was that prospective database study, it's not a randomized trial. Submucosal injection prior to resection was not uniformly performed in the cold snare polypectomy group because some were resected without injecting. Procedure was performed in expert centers only and therefore may limit generalization of the study results. So to take home, they say that cold snare polypectomy in the management of large sessile serrated lesions appears to be safer and equally efficacious when compared to traditional endoscopic mucosal resection with no procedure related bleeding or deep muscle injury in the study cohort. So how it can have impact on clinical practice is if we start having cold snare polypectomy as a new standard of care in large SSL. This would dramatically reduce, improve the safety outcomes, minimizing unscheduled hospital admissions. And the ease of cold snare polypectomy combined with improved safety allows for multiple SSLs to be removed in one setting, potentially reducing the number of colonoscopies required to clear the colon of the lesions in patients with serrated polyposis syndrome. So this is the take-home message. Thank you for a patient hearing.
Thank you very much. Do we have, Anil, do we have the discussion at the end of all the 5
yes,
papers?
because the papers are different. We should have discussion on each paper as a standalone.
Okay. Any comments from the panelists?
Dr. Pankaj, is cold snare polypectomy going to be the order of the day for almost all types of polyp? Why going for hot snare?
Yeah, that's a good question. So first, let me just ask Dr. Desai, what was the definition of technical success?
The technical success was the removal of the whole polyp.
By pathological?
Yeah.
So they had they looked at the margins and everything?
They looked at the margins, yes.
Okay.
Margins free of
and
the tumor and the depth, which
and
was
did they
not showing
follow
any
the
tumor.
patient for recurrence?
Yeah, at 6 months and 18 months, that is what.
And there was no recurrence?
There were recurrences, but I don't think they have mentioned about the recurrence because they did not consider the recurrences in the study in both the
But
groups.
that's a critical point, isn't it?
Yeah, I think so. But I could not find it in the article.
I think it's difficult to really draw a conclusion if you have in one group a much higher incidence of recurrence. So I think that's a piece of data that is missing that really limits the interpretation of this study. So I think the move towards cold is been there for a few years now. It started with actually small polyps and now is becoming more adopted because of the obvious lower risk for injury, and the fear of bleeding has not been substantiated. So it makes some sense that we'll go towards cold snare polypectomy for these lesions. Now, the only thing I would say is there are newer forms of energy that are coming out beyond the traditional, cautery currents that we use, microwave energy and others that are already being tested, and in some cases, large studies are being performed. These are combined with newer devices. The speedboat is an example of that. I don't know if you all have heard about that.
Yes. Yeah.
And so we will have to wait and see whether those technologies are even better, particularly if you look at, recurrence. For me, recurrence is the key thing, right? And if it doesn't matter what you do at the time, if you have to go back every few months, that is not only adds to the cost, but is extremely demoralizing and discouraging for the patient.
I think probably the same. Pankaj, do you have some more long-term data? In this study, the follow-up was only up to 12 months, but do you have longer follow-up about the recurrence of the disease after these two techniques?
So I think this is the data ends in 2020, and I could not find any more data on this topic from their paper. So I think what they have shown is technically it is without any complications. That is what they wanted to highlight in the paper. That is what I think, and probably we need some more data, as Dr. Pankaj is telling, that regarding recurrence, which is very essential.
Now, the fear is that with this kind of piecemeal polypectomy, one may not be always able to remove the entire polypoid tissue.
Yeah, that debate is always there. Yes, I agree. It's in either if you use EMR or cold snare, and there is chance of recurrence in both.
Any other comment by any of the panelists?
Let me introduce the panelists. We have 5 panelists. Dr. Rohit Gupta, who is the additional professor and head of gastroenterology at AIIMS Rishikesh. Dr. Vijay Chandel, who is a professor and head division of gastroenterology at Government Medical College Jammu. Dr. Saroj Dubey, who is senior consultant gastroenterology at Kailash Hospital, Noida. And Dr. Rachit Agrawal, who is a consultant gastroenterologist at Orange City Hospital Institute, Nagpur. And Dr. Ravi Daswani, who is a senior consultant gastroenterologist at Midas Multispecialty Hospital, Nagpur.
I think there is one line which is written. I just saw the recurrence is 4.3% in both. That is what they have written.
Yeah, but the
No numbers. It is 4.3%. It's same in both. That is what.
The follow-up is not very long. It's just only 12 months follow-up. That's all.
Yeah, 18 months, I think. 6.
Pankaj, why not cold snare polypectomy across the board? Why not do it with hot snare? What is wrong?
Why not for all the polyps?
Yeah.
Cold snare. I don't think very large polyps, if they are there, it's amenable for cold snare. Flat polyps, I think, yes, it makes sense using this. But when you have pedunculated polyps, or when you have polyps which are not very flat, then cold snare might be a difficult proposition to use, and might require a little bit of strength and avulsion of the mucosa. I am not very sure whether it would be very helpful in lesions which are polypoidal rather than apart from flat lesions or very small lesions.
I think you're talking about you're not talking about pedunculated polyps. You're talking about flat polyps, right?
Yeah, so flat polyps, possibly you can always, you can use.
Obviously, for pedunculated polyps with a vascular stalk, it's going to be.
It doesn't make any sense.
Yeah.
Have to move to the next.
Okay, with this, I think we go on to the next paper, which will be presented by Dr. Moinish Chbd, who is a senior consultant in the Department of Gastroenterology at Fortis Hospital, Bali. Dr. Chbd, please.
Thank you, Dr. Barur. Can you please play my recorded lecture? Good evening, ladies and gentlemen. At the outset, I would like to thank Dr. Anil Arora and his team for inviting me for this session on future of endoscopy, 5 best recent papers considered to be game changers. I've selected this paper published online, Nature Machine Intelligence, on enabling the future of colonoscopy with intelligent and autonomous magnetic manipulation. The paradigm described in this paper combines the use of robotics, artificial intelligence, computer vision, and advanced control to devise an intuitive and effective endoscopy system which can even be used by non-experts in unstructured environments like colon. Colonoscopy remains the gold standard for screening of colorectal cancers, And almost 19 million screening colonoscopies are done annually in USA and European Union, and it is expected to rise by 16% in next decade. There are a lot of limitations of flexible endoscopy, including pain, perforation, sedation, its side effects, and the most limiting one being the shortage of expert endoscopists with respect to demand. Magnetic endoscopes are promising alternatives. However, magnetic manipulation was considered earlier as complex and unintuitive, as the external magnetic field was non-linearly related to the movement of the scope. In this study, authors use robotics with machine vision and advanced control to develop intelligence and autonomous control of magnetic endoscopes, enabling non-expert users to effectively perform colonoscopy in vivo. The objectives of the study were: how can intelligent control strategies overcome the inherent complexities of controlling magnetic endoscopes? What level of autonomy is required to enable a non-expert operator to navigate a magnetic endoscope in colon while maintaining procedure duration comparable to a flexible endoscope? And can effective intelligent control strategies reduce the physical and mental burden of the operator? If you see here an overview of magnetic flexible endoscope, it almost contains all the features of a conventional endoscope. Internal permanent magnet is there at the tip. External permanent magnet is mounted on a robot, and coupling of these two magnets produces a forward pull actuation inside the colon, which prevents looping, buckling, reduces pain, chances of perforation, and reduced needs of anesthesia. The navigation system has many elementary blocks, but they are arranged in three basic layers. The first layer is a direct robot operation, where there is no autonomy. The user controls the movement of the robot to manipulate the movement of endoscope. In second, which is intelligent endoscope teleoperation, the user controls the movement of the endoscope, whereas the system controls the movement of the robot according to the localizing information from the sensory data it receives from the tip of the endoscope. The third, which is a semi-autonomous navigation, here both the system takes care of the movement of the robot as well as endoscope is steered autonomously by localizing the lumen by analysis of the video feed it is getting by advanced image algorithms. However, here the operator can override the autonomous control. The first part of experimental setup was done in latex phantoms, which were configured into a colon. 10 untrained users were asked to use the magnetic flexible endoscopes from going from rectum to cecum, and the times were recorded. And the task was completed if they were able to do this, reach cecum in less than 20 minutes. And three different control strategies, as I have already described, were used. Here you can see the operator user is using the joystick with the right hand. He's feeding the tether from the left hand. And this is the completed trajectory of the MFE by using the robotic operation. And this is intelligent operation, intelligent endoscopic teleoperation. And third is completed trajectory of the semi-autonomous navigation. The results of the study show that intelligent endoscope navigation and semi-autonomous navigation outperform the conventional endoscope as far as untrained and early trained users are concerned. The time to reach cecum is reduced and is comparable to experienced clinicians. As far as the ease of use is concerned, the semi-autonomous navigation shows least workload scores in almost all the fields as compared to rest of the strategies, and it makes the task less demanding and more time for the user to monitor the procedure. In vivo study on porcine model was performed by two operators. They were not aware or had prior knowledge of endoscopy, and this study was designed to compare the conventional pediatric colonoscope with the magnetic flexible endoscopes. The farthest point reach in the colon by the pediatric colonoscope was marked and tattooed and was used as a reference target for the MFEs. And here also, if you see, the average completion rates of intelligent endoscope teleoperation and semi-autonomous navigation are almost comparable to the completion rates of the flexible endoscopy by using the pediatric colonoscope. The ease of workload of semi-autonomous navigation and intelligent endoscope teleoperation is far less as compared to the standard flexible endoscopy in almost all the fields. This led authors to conclude that intelligent and autonomous control of magnetic flexible endoscopes can enable even the non-expert users to successfully perform colonoscopy compared to flexible endoscope. In future, the final aim is to reduce the complexity of the endoscopic procedures by automating the manual aspects and enabling more focus on the clinical aspects of the procedure. This work is crucial as a scientific foundation for transitioning to clinical trials, where other crucial hypotheses such as acceptability, level of pain associated with the procedure can be tested. And this technology has a disruptive potential to revolutionize current practice if artificial intelligence in diagnosis of lesions and autonomous navigation are combined together in future, and it will improve the patient care in both diagnosis and therapy. Thank you very much.
Dr. Brewer, you're muted.
I'm sure Dr. Pankaj Pasricha would like to make a comment on this presentation.
It's a very nice presentation. And it's a very interesting paper. So when I look at this paper, I think of almost 20 years of papers that have come before, various forms of technology to do a better job. And I always ask the question, what is the true unmet need, right? What is the problem that this technology is trying to solve? And it's not clear to me what it is, because you need more than one thing, right? It's not, yes, you can have theoretically somebody who's not even a medical doctor do this, right? And so you say we are providing accessibility, right? But accessibility is not enough. Let's even forget the problems that somebody has to go through to get qualified to do this. Let's not even go there, but let's talk about other things apart from accessibility, right? Affordability. This is a very sophisticated piece of equipment which is going to have associated capital costs. One of the reasons many of the previous technologies, better types of colonoscopes, failed was because it was difficult for them to get into the market, which, as you know, the big players have already established their presence. It is going to be very hard for a system to say, I'm going to throw out all my Olympus or Pentax or whatever you use scopes and now put this in. In addition to doing the kind of training that might be required for a medical board to give privileges to somebody to do it. So if that's all you're going to do is say, I'm going to make it accessible, I think these kinds of technologies will generally not succeed. And it's not that the technology isn't sophisticated or it isn't very creative. So I'm not criticizing that. But it takes a lot more to actually make an impact on patient care than just technology itself. So that's my general comment on this. And you know, there are all those specific things here, but it's a wonderful example of technology. It's what I call a wonderful example of a hammer looking for a nail.
Pankaj, yes.
Pankaj, do you think it has a future? AI has a future?
Oh, so this is not, of course, this is not about AI. AI as a broad field, yes, definitely. This is in the context of having a smart colonoscope, right? And so I'm not talking about AI in general. Yeah.
Any guess how much is likely to be the cost of this procedure?
So this is just in a very preliminary stage. There have not been any human trials, and the same group published another paper in 2021 in Endoscopy International Open, where they again did it on a phantom model, but they used internal medicine graduates as well as the fellows, and then they compared that it is an ease of technology that they can do the colonoscopy. I think they had two ideas in mind when they started this project. One was the unmet needs for colonoscopic screening of a population where there is a shortage of gastroenterologists and the training required is long, and they should have at least 300 colonoscopies before they are able to reach the cecum. And the second need, what I got is that ease of the procedure, that the gastroenterologist should concentrate on the job for what he is doing a colonoscopy rather than just spending time on maneuvering the scope till the cecum. So I think these were the two main ideas, that you do the clinical job, have more time for the clinical job rather than spending more time on negotiating the scope till cecum.
Thank you, Dr. Chbd. I think with this, we go to the next paper, which is to be presented by Dr. Deepak Gunjan, who is assistant professor in the Department of Gastroenterology at AIIMS, New Delhi. Dr. Gunjan, please.
Good evening, sir. And thank you, organized. Technical team, please share my slides. I am not able to share it.
Anil?
Yes. I think Dr.
Who is going to share the slides?
Shefali, are you there?
Backend
Hello?
team. Yeah. Shefali, can you just share Dr. Deepak's slides?
Sir, we were not aware of it. It has not reached the tech
Okay, we
team
can
as
move
yet.
to the
If you can
next.
do the next speaker,
one.
I'll have it sent.
Yeah.
Okay, the next speaker is Dr. Gaurav K. Patil. I think he works in BIDS Hospital, Mumbai. Can I request Dr. Patil to give us his presentation, please?
Can you see my slides?
Yeah, we can see. Yeah.
Good evening, ladies and gentlemen. Good evening to the moderators and chairpersons. At the outset, I'd like to thank Dr. Anil Arora and the team at Gangaram for the excellent conference. I've thoroughly enjoyed it, and it's an honor and a privilege to be invited. So as a game-changing paper and endoscopic techniques which have changed our practice, I would like to present a paper from our department about a common disease that we see routinely, gastroesophageal reflux disease, and outcomes while performing ARMS, anti-reflux mucosectomy for PPI-dependent GER. So, as we know, GER is a very common problem. A day-to-day OPD practice has at least 40 to 50% of patients who have GER, and it's rapidly increasing. Heartburn, regurgitation, chest pain, all lead to decreased quality of life, increased anxiety, and other effects. We know PPIs are superior to most therapies. However, significant proportion become PPI dependent and require long-term therapy. The side effects of PPI, notably osteoporosis, kidney damage, and the increased risk of infection. We know for such patients, laparoscopic Nissen's fundoplication is currently the standard surgical treatment, and it has benefits in almost 80 to 90% of the patients. However, new onset dysphagia, nausea, hyperflatulence, gas bloat, pretty annoying symptoms can be seen up to 6 to 12%. And 2 to 5% patients may require conversion to an open surgery. Anti-reflux mucosectomy was first described by Inouye et al. And when he observed while performing circumferential EMR for a Barrett's esophagus, he resulted in improvement in GER. And he later on went on to describe this procedure in details. However, the long-term outcomes were unexplored, and we presented the first Indian experience for this procedure. So this was a prospective study from 2016 to August 2019 in patients who were PPI dependent. That is, they were optimized with PPI for at least 6 months prior to the enrollment. They had an abnormal DMester score with more than 14. Acid exposure type was more than 6% on a 24 hours pH. They were stopped for PPS for 1 week prior to the 24-hour study. They all needed to have a normal esophageal motility. Major and minor disorders of peristalsis were ruled out. The exclusion criteria was important. Patients who had a hiatal hernia more than 2 centimeters, The G junction flap valve, that is the Hills grade 3 and 4, were ruled out. And when you see the Hills grade 3 and 4, this is not just the hiatus, but there's also crural separation starts to begin at this stage. And therefore, these patients have an indolent herniated stomach, which is entering the thoracic cavity. Arms or any such procedures completely infradiaphragmatic fundoplication. So we need to address patients who have a small grade of G junction flap valve disorders. We excluded patients who had severe esophagitis, ulcerative esophagitis, peptic strictures, Barrett's esophagus, pregnancy, previous surgeries, and any esophageal varices or significant portal hypertension. Outcome measures, technical success were defined as complete resection of the gastric cardia with adequate hemostasis. Clinical success was 50% reduction of GERD-Q score at 2 months and complete cessation of PPI use. The last available clinical follow-up was used to assess patient response. A telephonic follow-up was done at 1 year after the procedures. All adverse events that occurred immediately and on long-term follow-up were noted. The procedural technique was the standard technique described by Inouye. All patients underwent general anesthesia in a supine position, EMR kit with the cap EMR along with a crescentic snare was used to perform this resection. Prior to beginning the resection, the mucosal area along the gastric cardia, which is occupying 2/3 of the circumference along the lesser curve, was pre-marked with either a dual or a TTJ knife with forced coagulation. That is 270 degrees pre-marking was performing, leaving aside the mucosa along the greater curve. After injecting this area with methylene blue and saline, piecemeal EMR was performed in a crescentic fashion using endocut mode, endocut effect 3. This EMR was carried out vertically from the Z line. So we just started just below the Z line, approximately 1.5 to 2 centimeter on the gastric side. And till the mucosectomy is performed, till the previously marked mucosal zone was resected. So these are the images. This is just the Hills grade 2 OIR injection, marking injection and using cap EMR technique. I'd like to show you a video. So this is where we start. First you inject the mucosa after you mark. The care should be made. No deeper injection should be made on the gastric side. Just as your injection standard techniques of EMR, just withdraw the needle. And after you have injected, use the crescentic snare. The snare has to fix into the groove made for the cap. And using suction and some scope manipulation, you get the entire, you create a polyp-like structure and you use endocut to resect this. With each injection, you maximum can resect up to 2 such EMR can be done. If you try to do more than 2 such things, you may end up having deeper muscular injury, which we noted in a few patients, or you may end up not sucking enough of the gastric submucosa. So care must be taken that every injection up and 2 resections have to be taken place. So this is some video of the EMR that has been performed. After you perform the crescentic EMR, the entire lesion has to be, entire defect has to be visualized for deeper submucosal vessels. And these submucosal vessels, irrespective of whether they're bleeding or not, have to be coagulated prophylaxically before you end the procedure. Care should be taken. All the section has to be carried out below the Z line and towards the gastric side, approximately 1.5 to 2 centimeter. We have carefully left the mucosa around the greater curve. And this is a result after 1 month. There's a very good G-junction flap valve created. And along with it, you can see the mucosal folds on the lesser curve are very. So post-procedure, these patients were kept nil by mouth for 24 hours, started on clear liquids next day, then soft diet, transitioned to a solid diet as tolerated. PPIs were given on the day of procedure, switched to oral PPIs for 2 weeks and then stopped. And patients who had mild symptoms were either asked to take on-demand PPI or a low-dose PPI. The demographics were, we had total of 62 patients who underwent this procedure, 71 were males, all were PPI dependent. The duration of PPI therapy for at least 13 months, 67 had a Hills grade 2, whereas grade A esophagitis was the main, almost 50% had grade A esophagitis. So total 89 were recruited, 62 underwent the inclusion criteria, procedural technical success was 100%, and at 2 months, almost 70% stopped their PPIs completely. We followed up these patients telephonically at 6 and 12 months, and we found that 38 patients were on follow-up and that 60 patients were completely off PPI. We noted dysphagia in 5 patients, and this dysphagia was in the first 2 weeks of the procedure. And this dysphagia was successfully treated by single endoscopic balloon dilatation with a CRE balloon. And these patients continue to maintain their response. That is, they continue to maintain the G junction flap valve even after dilatation. There were 11% patients who had failures of performing a good arms. All these patients had a good G junction flap valve maintained. Some of them had a grade 2. They were referred for anti-reflux surgery. However, because of the low GERD-Q scores, they refused for surgery. We kept in a combination of PPI plus tricyclic antidepressants, and they were followed up. So here's this box plot showing the changes in DMESTER score and GERD-Q score. And the mucosal flap valve was maintained as almost 90% of the patients after arms. This is a video. There's a recent patient who underwent arms and he developed a stricture after procedure. He presented in 2 weeks. The stricture was dilated with a CRE balloon up to 14 mm. And even after dilatation, when we enter the stomach, we can see that the G junction flap valve is maintained even after dilatation. And that's one important point, that arms is a very strong, it creates a very good, you can see at most 4 folds of the gastric mucosa are created on the lesser curve, and it's a very good flap valve maintained on the gastric cardia. So it is a very good technique where there is a healing by secondary intention and causing a strong G junction flap valve. So the limitations of study: at 1 year, patients had to be followed up telephonically. We would have preferred to have a clinical and endoscopic follow-up. We lost 9 patients to follow-up at 1 year. Complications were of GR, like peptic strictures and Barrett's were excluded. Impedance pH would have been helpful if we had to identify patients who had volume reflux and their outcomes to arms. A comparative study of PPI versus anti-reflux endoscopy or a surgery would be ideal to the long-term effectiveness. To summarize, ARMS is a safe and effective endoscopic anti-reflux modality for PPI-dependent GR with a small hiatal hernia, standardization of definitions of hiatus hernia, and improvement in the resection design, that is the length and the degree of resection, can be useful to prevent stricture formation. Head-to-head studies are warranted to know effectiveness of this procedure and if it can fill the gap between medical and surgical management of GER. Thank you.
Thank you, Gaurav. Very nice paper. Are there any criteria which help us to decide that these patients are ideally suited for the endoscopy therapy rather than surgery? And then in the endoscopy therapy, how do we decide what is the experience with other endoscopy techniques like radio frequency application or endoscopic fundoplication? Where do you decide to use mucosectomy? Is there any reasons where you should prefer one over other kind of therapy?
So a good question, sir. So when we have a hiatus hernia, the length of the hiatus is more than 2 centimeters, or the grade of the flap valve is grade 3 or beyond. These patients tend to have a more crural separation. It is not just a hiatus, but the diaphragmatic crura is more widely separated. And just by doing infradiaphragmatic approach to these patients, it's not going to really benefit. So these are candidates for surgery, straightforward. However, patients who have a small hiatus and a shorter, early G junction flap valve dysfunction, we can subject them to arms. We also perform GERD-X. And of recently, we started performing ARMA, but the results are still not, out. So we give them a choice of arms versus fundoplication using the GERD-X device. However, in our setting, we found a durable and sustained response with arms as compared to endoscopic fundoplication.
Gaurav, we have started using ARMA, anti-reflux mucosal ablation at Gangaram Hospital. How would you compare it? Because in terms of ease, it's much easier to do ARMA than mucosal resection.
Absolutely, so I completely agree. ARMA is much easier and technically more, easier as compared to a challenging procedure. The only thing is if ARMA we can actually cause a deeper submucosal injury or a deeper submucosal ablation with ARMA, either with a spray coag or a force coag, or even with other methods of coagulation like APC. The importance is if you observe ARMA, when we do observe ARMA, we do an endoscopy after 2 days, and the defect has to mimic a defect of a EMR or the entire submucosa or the superficial muscle needs to be seen, and that's I think a predictor where you have achieved good ablation or good scarring can occur in such patients.
Because the incidence and the rate of muscular injury is much less. The reason being you are injecting it, you are raising a bleb, then you're doing ablation.
Correct, sir. Right.
Gaurav, how does it affect the Barrett esophagus? Does it decrease the progress and also the complication of adenocarcinoma of the esophagus in those who are the Barrett's?
Endoscopic therapies for GERD so far in long term, we don't have any data on whether it affects the progression of Barrett's or progression of progression to a peptic stricture or complications of GER. But we have treated patients with sleeve gastrectomy who've got severe GER with procedure like ARMS. So we have experience with one procedure leading to another endoscopic treatment. But in terms of Barrett's and peptic strictures, we still don't have enough data.
Any question from the panelists?
Hi, Dr. Gaurav. There's a question. Does it help in non-acidic reflux as well?
Yeah.
Any data on that?
Yeah, so in our case study, we had almost 50% were grade A and rest were grade B and grade C. Any RD, we would want to do an impedance study to know whether it's pure volume or it is air or it is food, what type of reflux the patient is having. So volume refluxes should ideally, technically, if you see by conceptually, it should help volume refluxes, but we need to first evaluate whether with the 24-hour impedance to see if these are helpful.
And many of these patients have hypersensitivity issues, and anxiety is a predominant component. So that is also one thing which needs to be addressed.
So I highlighted in my slide, 11 patients were still present, and none chose to go for surgery, even they were PPI dependent. So the GERD-Q scores were not as bad as they were pre-ARMS.
Hi, Gaurav, what was the follow-up of these patients? After how much time these patients were followed up?
But the follow-up was 12 months, and we lost 9 patients to follow-up at the end of the entire time. So whoever have maintained follow-up at 6 months have continued to have PPI, they've stopped at 12 months. That's one thing we observed.
Gaurav, the 3 endoscopy modalities, which one is currently being most commonly used?
We use ARMS and GERDEX both. ARMA is something we are still looking at the results that we have at our center. So ARMS and GERDEX both are, the patient is given option.
What is the overall experience reported in the literature? Which of these 3 modalities is the best?
Right now, I think they're moving towards TIF and TIF2. In fact, TIF2 combined approach where you can actually shorten the crural opening and perform endoscopic fundoplication. I think that's what they're doing for the grade and beyond the larger hernias. But in our center in India, I think we are with the GERDEX and ARMS. So I think we choose ARMS as a first treatment option for small hernias.
Can we have Dr. Pasricha's comment? Dr. There's a lot of patients with reflux, especially it is a popular surgery, laparoscopic fundoplication in pediatric age group in US. So what happens in adults? And status of GERD, status of strata and RFA, what is the current status?
So this technique, very nice paper. Congratulations to you and Dr. Maydev for doing this. This is a injury-induced approach. This is similar to what Strata and radio frequency was trying to do. I think this is just another modality for trying to stiffen the esophagus, put in scar tissue or whatever variant of that you believe in. I think it's never really taken off in the US, Strata, because of two reasons. One is that even though they were randomized clinical trials showing clinical efficacy, there's much less evidence in the long term that it prevents acid reflux. So one of the and then of course there's a cost and expense associated with it, and that's a different story. But it's really been about whether this is truly effective in reducing acid reflux. Has never really been resolved. Now, this is a more profound injury with the mucosal resection than with the Strata. So perhaps you're getting better results for that. But I will caution by saying that despite this, more than a third of patients did not respond. Your response rate was somewhere in the 60%, even assuming the follow-up was adequate, which, you had more than 10% loss to follow-up. So you have to be careful about, how you want to go forward. You'll probably have to get better than a 65% response rate to justify procedures like that, at least for the larger population. Now, there may be an individual patient who insists that they don't want to be on a PPI every day. And yes, I think these are options that are available. All of this might change. I don't know if it will, but people are betting on it with the new PCABs coming out, the new acid suppressive, the next generation beyond PPIs, which can achieve much greater reduction in acid. So whether that will change the equation for acid reflux, we don't know either. But very nice paper. Thank you.
Thank you.
We have to move to the next paper. Next will be by Dr. Srihari, and that would be followed by Dr. Deepak.
Are my slides visible, sir?
Yeah.
Yes. Yeah. So very good evening to the distinguished moderators, chairpersons, and members of the audience. It is indeed a great honor for me to be presenting in front of this distinguished panel. I shall be discussing one of the recently published articles in GI endoscopy, which has been very often talked about in the recent days. So this was an article by Anthony Teo and his group, which was done at the Prince of Wales Hospital in Hong Kong. So the study compared EUS guided biliary drainage versus laparoscopic cholecystectomy for acute cholecystitis. It was a propensity score analysis with a 1-year follow-up data. So as a prelude, we all know that laparoscopic cholecystectomy is considered the standard of treatment for acute cholecystitis. However, there is a distinct subset of patients who are unfit for laparoscopic cholecystectomy. So the treatment options for patients who are unfit for laparoscopic cholecystectomy are either radiology guided interventions or endoscopic interventions. Radiological interventions include percutaneous GB drainage, and the endoscopic interventions include a transpapillary GB drainage or a EUS guided GB drainage. Because of the technical difficulties in doing transpapillary GB drainage, it has now mostly fallen out of favor. And now what are the two most common techniques that are followed is one is percutaneous GB drainage or EUS guided GB drainage in most of the patients. There was a recent multi-center randomized control trial by the same group who had compared the outcomes of the EUS guided GB drainage versus percutaneous GB drainage. And they found out that the number of adverse events with EUS guided GB drainage was much less as compared to percutaneous GB drainage. The number of re-interventions that were required after EUS guided GB drainage were also significantly lower as compared to percutaneous GB drainage. The most common re-intervention required because of percutaneous GB drainage was because of the blockage of the tube. And the technical success rates and the clinical success rates were almost equivalent with either of these two modalities. So EUS guided GB drainage is has been found to be an excellent modality, maybe having slightly better results as compared to a percutaneous GB drainage. So for this study, we already knew that US guided GB drainage is a safe alternative to percutaneous cholecystostomy, that is percutaneous GB drainage for acute cholecystitis. The researchers tried to compare that how GB drainage compares with laparoscopic cholecystectomy. And the aim of this current study was to compare the outcomes of US guided GB drainage with laparoscopic cholecystectomy for acute cholecystitis. So for this patient, consecutive patients who were admitted between 2012 and 2018, who received either US guided GB drainage or laparoscopic cholecystectomy were included. Because obviously the indications for both these sets of patients were different, these patients were matched, and they tried to use the propensity score matching for age, sex, and age adjusted Charlson score. The outcome measures which were seen were 30-day adverse events, mortality, the rates of recurrent cholecystitis or biliary events, the number of re-interventions that were required, and readmissions in all these patients. Typical patients who were enrolled for US guided biliary drainage were patients who were very elderly, more than 80 years of age, or who had high anesthetic risk with a ASA of more than or equal to grade 3, age adjusted Charlson comorbidity score of more than 5 and or Karnofsky score of less than 50. Also, elderly patients who refused surgery were enrolled for US GBD. The decision of not going in for the laparoscopic cholecystectomy was taken jointly by the surgeons and the anesthesiologist. For the US guided GB drainage procedure, the gallbladder localized either from the stomach or the duodenum, a well distended gallbladder, was punctured either by these two techniques. In this video, what is being seen is a lumen opposing stent. This is a freehand technique which is much more easier and now used very frequently. After the puncture has been achieved, all the secretions are aspirated, and then in the same setting or in subsequent settings, the side wing scope is changed over to a forward wing scope. The lamps is dilated to 12 mm, and then you can actually enter with an endoscope into the gallbladder lumen and remove the stones. So there has been some criticism as to whether you actually need to remove the stones or even maintaining a patency with the gallbladder is good enough with the lamps or a plastic stent. But in this study, they did remove all the stones either in the same setting or on follow-up settings. So after the gallbladder was clean, the patient was observed for signs of improvement, and if there was any further worsening, further investigations were done. For follow-up interventions, patients who had undergone US-guided gallbladder drainage, a per-oral cholecystoscopy with a forwarding scope was done at 1 month. This was under conscious sedation, and it was seen whether GB was cleared of all stones. If the GB was clear, the lamps was removed, and a 7 French double pigtail stent was placed permanently. If the GB was not cleared, a repeat cholecystoscopy was done every month until the stone clearance was achieved. And once the stone clearance was achieved, subsequently the lamps was removed and a 7 French double pigtail stent was placed permanently. In a small subset of patients who could not undergo repeated endoscopies because they were very sick, the lamps was kept permanently in all such patients. So 30 patients in the US GBD group were compared with 30 patients who were matched with each other on the laparoscopic cholecystectomy group. There was fair matching in the age, the sex ratio, the age adjusted Charlson score, the white blood cell counts, and the severity of acute cholecystitis. The mean follow-up of all these patients was nearly equal to or more than 1 year. When the outcomes were compared, it was seen that the technical success with US guided gallbladder drainage was nearly 100%. Clinical success was almost around 93.3%. So technical success was the ability to have a good drainage of the gallbladder, and clinical success was defined as the improvement in the clinical symptoms and vital parameters after the procedure. The length of hospital stay was not significantly different among these two groups. The 30-day adverse events was also not significantly different among these two groups. The 30-day mortality percentage was slightly on the higher side. The reasons for mortality I have discussed in the next slide, but there was no statistical significance. There was no statistical significance either in the number of events of recurrent cholecystitis or recurrent biliary events. The recurrent biliary events in these two groups were because of some stones in the common bile duct, which were later removed. The number of reintervention rates was also not statistically significant, neither was the unplanned readmission rate. The adverse events that were observed in the US gallbladder drainage group, one of the patients presented with an upper GI bleed in which a fair endoscopic hemostasis was achieved and there were no further complications. In the another patient, there was a blocked stent. So a double pigtail stent was placed within the lambs and patient improved clinically. A third patient had aspiration pneumonia and the another patient had uncontrolled sepsis, which eventually led to the death of these two patients. So these were the two reasons for mortality in the US Chbd group. So the researchers concluded that the outcome of US gallbladder drainage for acute cholecystitis were comparable with LC with acceptable rates of recurrent acute cholecystitis. But yes, they have accepted the caveat that although the study lacked power, so that the study lacked power, it was not well powered to establish this equivalence. But yes, this was a start. They have used propensity score matching, which might not be the ideal way. The study supports, however, the role of US gallbladder drainage as an alternative to laparoscopic cholecystectomy in patients who may or may not be surgically fit to undergo definitive cholecystectomy. There were few limitations, of course, that the sample size was very small, so the study was prone to type 2 errors. The researchers used propensity score matching to make two distinct populations comparable, so inherent bias can still exist. So although US gallbladder drainage can treat acute cholecystitis, there is always a risk of recurrent gallstones. So a need for subsequent cholecystectomy will always persist. However, a study published in 2007, which followed up patients who had undergone percutaneous gallbladder drainage, 10 years they were followed up for, and it was found that only 20.9% of these patients eventually required cholecystectomy because of recurrent cholecystitis. So the rate was not very high. So what is the future? One of the unmet needs from this study was the inability to achieve a ablation of the gallbladder. But there have been recently published studies which were recently published where they have shown that they could achieve success rates of around 80 to 85% in achieving gallbladder ablation by either using cryoablation or using chemical agents like absolute ethanol. So ladies and gentlemen, we could still have a future, and I foresee it that an endoscopic intervention, especially US guided one, could well be an answer as an alternative to surgery for patients with acute cholecystitis. Thank you very much.
Dr. Shrihari, do you think in a Ganges belt where there is a direct relationship between the inflamed gallbladder, gallstones, and incidence of carcinoma gallbladder, especially in those who are fit to undergo surgery, there is any role of US cholecystectomy?
Sir, if you consider that, I mean, in right now, it might, the laparoscopic cholecystectomy might be way better as compared to US guided intervention, but we don't know what lies in future. So obviously there has always been a trend towards more and more non-invasive techniques. When laparoscopic cholecystectomy came into existence, I think there were already multiple questions as to whether it would be better than an open cholecystectomy, but we have evolved since then. So considering the magnificent strides that have undergone in the endoscopic arena, I think we can well foresee a future that endoscopic techniques will be even better, and we might achieve what can be achieved with a lap chole with an endoscopy.
But you know that comparison is not justified. In both the cases, open versus laparoscopic cholecystectomy, you are removing the gallbladder, whereas in this case, you are leaving the gallbladder in situ. That is the problem.
Absolutely. So that is why I brought out the last slide, that the unmet need as of now is how do you ablate the remnant gallbladder.
Can
You
only
have been
be
able
a
to ablate.
temporizing measure.
Sorry, sir.
It can only be a temporizing measure. It is
As
not
of now, yes. As of now, yes. but maybe in future we will have something to permanently take care of the remnant gallbladder.
What percentage patient required cholecystectomy? What percentage no surgery was needed?
So, sir, those patients who had undergone the US gallbladder drainage were elderly, they were sick. So, patients who were intended to be kept on permanent stents, in patients who got better clinically, eventually a laparoscopic cholecystectomy was done. This was around 5 to 10% of the patients who underwent US GPD. One of the issues that was brought out that once you do a US gallbladder drainage and you have a stent in situ, it might be technically difficult for the laparoscopic cholecystectomy, but none of these patients, the researchers found that there was any issue for the surgeon to take care of the defect, remove the stent, and do a lap pull.
And those patients who do not require cholecystectomy, you have to change the stent frequently because you have to keep in the stent for the whole of their life.
Yeah. So what they have done is they removed the lamps, and once the gallbladder was clear, they removed the lamps and they placed a double pigtail plastic stent, which was kept permanently. However, there are other studies in which lamps was kept in situ for more than 3 years, and there were no significant adverse events, even with keeping the lamps for more than 3 years.
Dr. Shrihari, if somebody eats half a kilo of mutton, as Dr. Mahesh Goenka said, you think 250 gram will go with that 12 millimeter balloon dilatation into the gallbladder after eating?
So food impaction is one of there have been events of food impaction in these stents, and that was one of the reasons why they had to place additional double pigtail stents. So if you have a choice between choosing between a gastric access and a duodenal access, the chances of food impaction in a gastric access are much more. So that would be one of the reasons for gaining a duodenal gallbladder access as compared to a gastric access. In that, the food impaction rates were much lower, but clinically significant events which led to failure of procedure were not seen in this study.
Thank you very much. I think very
Dr. Shrihari, hi.
Yeah.
Sorry. Somebody wanted to make a comment?
So can I make a question? Yeah, so Dr. Shrihari, I just had a point that when we do laparoscopic cholecystectomy, there are times when we have to convert it to open because either the gallbladder is very contracted or adherent. So when we are trying to do EOS guided GBD drainage, do you foresee similar problems that if there is a contracted GB or if the GB lumen is distant from the intestinal lumen, do you think that might be a problem still?
So this problem was encountered in around 5% of the patients where they were technically it was not feasible to do a US guided gallbladder drainage. There are just on this lines there was also those patients who had undergone a percutaneous gallbladder drainage, and because after you do a percutaneous gallbladder drainage, eventually if they were planned for a US guided gallbladder drainage, it was not possible end phase because the gallbladder is collapsed after you do a percutaneous GB drainage. So what they did in that case is they inserted saline through the percutaneous tube, inflated the gallbladder, and then they achieved a US guided access. So yes, in cases where the GB is collapsed, but this situation occurring in a case of acute cholecystitis is very unlikely. It could be a case of chronic cholecystitis. So yes, obviously in such cases, you cannot have a technical success. So those patients were out in this patient.
Thank you very much. I think we have exceeded our time. We go to the last paper, Dr. Deepak Gunjan, if your slides are ready. Dr. Gunjan is assistant professor in the Department of Gastroenterology at AIIMS, New Delhi.
Thank you, sir. Good evening. So I will talk on the US guided fine needle biopsy devices versus ROSE versus no ROSE in a multi-center randomized control non-inferiority trial that was published in Gastroenterology this year. Next slide. So we know USFNA is a very standard procedures for solid pancreatic lesions. And apart from that, rapid on-site evaluation is very important part of that. And the benefits of ROSE that we know, immediately we know what is the diagnosis, and we also know what is the optimum number of needle passes required for reaching a diagnosis. However, demerits is that we don't have an expert pancreatic cytopathology and also the related cost apart from this, and it is available in some only few centers. Next slide, please. So now the various needle, that is FNB devices, biopsy devices are available, at least side cutting and in cutting needle. The reason being, you can have a core tissue, and also you can do the ICS staining on this. And at least one or two study has shown that FNB needles perform better than the FNA device, or it is as compared to US FNA plus ROSE. So the aim of the study, next slide. So aim of this study was that the diagnostic accuracy versus FNB versus FNB plus ROSE. So both groups have FNB, but one group have a ROSE. So in FNB ROSE arm, they have collected the specimen and they have rolled down the slides so that they can get the touch imprint smear. However, in US FNB alone arm, they directly put the samples in the formalin vial. And in both the groups, maximum of 3 passes was allowed. And the primary endpoint was the diagnostic accuracy in both the groups and the adverse event rates. Next slide. So they have randomized 845 patients. They have selected an 800 patients. They have randomized 400 patients in both the groups. And they do the both modified intention to treat and per protocol analysis. And in the results, next slide, that most common lesions were in the head, and the most commonly needle they have used the Francine tip 22 gauge needle, and the most common site for needle biopsy was the stomach. Next slide. Apart from that, the sampling techniques, although these are the parameters they have not randomized, the fanning technique was the most commonly in the more than 90% of the patient it was used, and the pancreatic ductal adenocarcinoma was the most common diagnosis. And repeated sampling require only in 1 to 2% of the patients. Next slide, please. For primary endpoints, if you will see there, in sensitivity and specificity in both the arms, whether US FNB plus ROSE versus US FNB alone, the sensitivity and specificity are equal, and also accuracy is equal in 96.4% in ROSE arm and 97.4% in FNB alone arm, with 1% absolute difference. Next slide, please. And in secondary outcomes, adverse events were in 12 patients, in 2.1% in ROSE arm and 1% in FNB alone arm. Definitely the time for sampling was less than 6 minutes less in US FNB arm. The tissue quantity and blood contamination of the slides was equal in both the arms. Next slide, please. So if you will see the post-procedural events, there were 12 patients, but surprisingly, 8 patients has a pancreatitis-related events. Although it was mild, but as a gastroenterologist, you are always afraid of acute pancreatitis. Next slide. So until now, US FNA ROSE was the preferred technique. Now this study, this large sample size, have comparable diagnostic accuracy in both arms, and US FNB alone is non-inferior to US FNB plus ROSE arm. So it has benefit that those institutions that lack ROSE services, they can use US FNB alone devices, will facilitate widespread use of US guided sampling, and definitely in malignant treatment, it is a next future road for the personalized treatment. However, there are some limitations that the pathologist had limited experience in touch imprinting technique. All involved centers were highly experienced, and all the endoscopic FNB was done by the experts. And there is different histological needles without randomization. We know that side core cutting has less diagnostic accuracy. However, they have a subset of, they have analyzed it different again in this study, and they have found there is no difference in diagnostic accuracy. However, if there is a training, do we require ROSE or not? We don't know. And in less experienced center, whether ROSE will gain acceptance or not, that's another question. And apart from that, the US FNB device has almost the cost is double of the FNA devices. Next slide. Thank you.
Thank you very much. Any quick comment by any of the panelists? Comment, questions?
Yeah, can you stop sharing the slides?
Gunjan, can you tell us how much is the discrepancy usually in these patients by the diagnosis which is obtained by FNA samples versus the histology which you get from the resected specimen?
So in different studies, the discrepancy is not very much, except that if it is, you are thinking that benign conditions, you are not sure of the diagnosis. So you require a long-term, at least 6 months of a follow-up, because most of the time in pancreatic lesions, it is pancreatic ductal adenocarcinoma. That's the worst fear we have.
May I know how many centers are using ROSE as a bedside evaluation at the endoscopy room evaluation?
Sir, we are using it, but I'm not sure of many of that's the demerit of USFNA plus ROSE, that many centers do not use. Apart from that, you can take 4 or 5 samples in USFNA, but you require less, at least 2 or 3 passes will suffice for the USFNB.
You see, as much as every gastroenterologist and endocrinologist would love to have a bedside pathologist or in the EUS room, but problem is they are neither available, and because sedation requires changeover of the time, they are in a rush to go back, and for all logistical purposes, and it's very difficult to have them on board.
Yeah,
as much as one would finish.
Another question which I had, the neuroendocrine tumors, they are hypercellular. Necrosis is not a very common feature. So do we get a diagnostic yield better in neuroendocrine tumors compared to ductal adenocarcinoma?
So in this study, they have also included the neuroendocrine tumor. However, there is no difference in the diagnostic yield in both arms.
But what is the overall impression? In this study, the number may not be adequate enough.
Yeah, of course, sir. For neuroendocrine tumors, definitely, because we require WHO grading also, and we require a spatial staining also to characterize it. So probably FNAB devices will be better.
Okay. Well, if there are no other questions, comments, I'd like to thank all our speakers for excellent presentation.
I'd just like to one last comment on the previous paper. A very nice paper, and good job in presenting. This is actually, to go back to what Anil had asked earlier about AI, you can actually potentially think about near future development where AI imaging at the bedside can replace the cytopathologist. So that would take care of some of the logistical issues. I think that's where a lot of these techniques are going.
Okay,
Is this being practiced in US at the moment, or it is still in the experimental stage?
I think we're getting there, right? It's being done in dermatopathology a lot now. It's going to be done in, people have been a little hesitant about tumors because, you know, nobody really wants to, as yet, hand over life and death decisions to a computer. But I think it's not that you're going to replace the cytopathologist, but bedside, you're going to get ability to get immediate feedback on both the adequacy of the sample and its diagnostic yield can be greatly facilitated by AI-aided image recognition. So I think that's going to be a big boon for those kinds of diagnoses.
Okay, I think with this, we like to end the session. I must thank Dr. Pankaj Pasricha for being so kind and moderating the session. Must thank all the speakers for excellent presentation, all the panelists for contribution. And lastly, since this is the last session, I must thank Dr. Anil Arora and his whole team for a very successful organization of this meeting. Thank you very much. I think I hand over to Dr. Anil Arora.
Thank you, Dr. Brood. Thank you, Dr. Pasricha, for moderating.
You're not audible.
Thank you, Dr. Brood. Thank you, Dr. Pasricha, for moderating this session. So we had 6 very interesting sessions this evening, and we learned a lot. And I would request Dr. Mandhir to summarize in 5 minutes.
Do we really have the time, Ashish?
In 5 minutes, I think you can just summarize what we learned today. Then we'll go.
Okay, okay. Yeah, see, our first session was by Dr. Nageshwar Reddy, and what he told was that cholangioscopy has evolved over the years, from the advent of mother-baby scope to spy scope, and now we are having a direct cholangioscope also. And what he told was that it is important for determining the cause of stricture and take biopsies as well, and also for therapy of the large CBD stones. Next session was by Dr. Vinay Dheer about therapeutic EUS for beginners. First of all, it requires a good setup with a good backup, a good assistant, good IV, the interventional radiologist, and GI surgeon, and an anesthetist to stand by. And one should start with simple procedures like celiac block and pseudocyst drainage. Most important of all was that one should have to learn to have a stable scope. It has a long learning curve. At least one should be proficient with EUS guided FNACs for 3 to 4 years and be ready to put another 3 to 4 years, a dedicated movement to do therapeutic endoscopic procedures. Next session was on third space endoscopy by Dr. Amit Medhio. What is beyond POEM? As of now in 2021, what we are doing most commonly is POEM only. G-POEM is still experimental, especially for diabetic gastroparesis because of the difficulty in making a diagnosis. STIR is the procedure which is coming up, and then D-POEM, especially for Zenkers. That is very important, and a per-rectal endoscopic POEM for Hirschsprung disease. Most important during this all the procedure is entry into the submucosa, a proper tunnel creation, adequate tunnel should be there, and myotomy. Then most important is to put up a good hemostasis and then incisional closure. And of all the things, POEM was not inferior to laparoscopic myotomy. However, the adverse events are less in POEM, but reflex increases, which is around 15%, which is clinically significant. Learning curve should be, one should always try to do it in models first, and around 100 procedures are required for a proper learning curve. Never take lightly, even if you have done 1000 points. Next session was by Dr. Amit Medhio, which was on EMR and ESD. The current indications were basically to do extended polypectomy or early carcinomas. Most important was that for stomach, the lesion size should ideally be less than 1 centimeter, and in colon less than 2 centimeters if you are going to do EMR. And for any lesion beyond it, it is better to have a lesion, do EST. One has to do a good white light and a high efficiency endoscopy, and EUS is not mandatory for diagnosing all these things. However, EUS has to be done if you are going to do something rectal, because any lymph node outside may be malignant. This was the, and recurrence rates can be around 20% in lesions around 2 centimeter in size. ESD is a lengthy procedure. The risks are higher, and one has to do gel effusion, use something, and traction technique is the new kid on the block. Last session, which I would recommend, was by Dr. Rajesh Puri on newer endoscopic methodologies for weight reduction. Still, the most important part, which should never be neglected, though it has a poor efficacy but is safe, is the lifestyle modification. Surgery carries a risk of 15% in as a vis-a-vis of complications, and only 2% of the people undergo surgery, as 50% do not want surgery. And then the latest kid on the block is endoscopic method, which is safe as compared to surgery. The gastric balloons are not very effective. They are basically used as bridge to surgery to decrease the BMI from higher to somewhat lower, so that the person can undergo surgery. And in persons who are to undergo transplant, where there is important. Aspiration therapy was something which is being propagated, where a peg can be placed and 2/3 of the patients are satisfied by it. I don't think any one of us is using it at present. Endoscopic sleeve gastroplasty is a newly effective methodology with a weight loss of around 18%, as compared to around 20% done by the surgical technique. It is comparatively less complicated, but however, one more important thing is that after 5 years, even in patients who are having obesity and have undergone the sleeve gastrectomy, the laparoscopic, they start gaining weight. We don't know what is going to the future of endoscopic. I don't think there are any comments to make on the paper discussions which you just completed just now. I think that would be enough for today.
Thank you, Dr. Mandir. So before I hand over to Dr. Anil Arora for concluding this meeting, I would like to propose a vote of thanks. So we had 4 interesting days. First day was of hepatology on 4th September, then 5th September was luminal gastroenterology, and yesterday and today we discussed endoscopy, diagnostic as well as therapeutic, and we had very interesting sessions. So I would like to thank all the speakers who participated from across the globe, and all the moderators and all the chairpersons and panelists for these sessions. There were total about more than 1800 registrations and 225 faculty members. I would like to thank each one of them. And in addition, I would also like to thank our event manager partner, Maisha, especially Shefali, for the flawless conduction of this event. And I would also like to thank our industry partners who supported us, Microlabs, Dr. Reddy's, Natco, Abbott, Elnick, Medley, Medtronic, Zydus, Bountiful, Boston, Ferring, Fords, and Samarth Life Sciences. And also thanks to all the delegates who attended. And this entire session will be available on YouTube, so you can also go through it later as well. So with this, I would hand over back to Dr. Anil Arora for making the final concluding.
Thank you, Ashish. I will not come between you all and the eating delicious dinner. I think I'm extremely thankful to all the chairpersons, moderators, speakers, and also the audience who actively participated in this lively discussion over the last 2 weekends, in which we tried our best to cover up the latest advances which impact the practice of gastroenterology and hepatology in our day-to-day practice. So with that note, we look forward to having all of you again during our next virtual clinics. Possibly we may have a physical meeting next time if the logistics and the geopolitical conditions permit. Till then, thank you so much. Good night and goodbye. And thank you once again for joining us in our academic endeavor.
Good night. Bye-bye. Thank you.
Thank you. Bye-bye.